So hello bachcho, good afternoon everyone. Hopefully the audio visuals are clear. Let me know in the chat box if the audio visuals are fine, so then we can proceed with the session further. So in today's session, we'll be covering all the most important and the high yielding topics of surgery, but in the form of MCQs, because near the examination, what happens is you tend to recall because you have revised surgery enough number of times. The main problem happens in these kind of clinical subjects like surgery and obs-gynae is usually the application of the knowledge that you have gained throughout. So usually you get stuck in the next best step, in the first step, in the investigation of choice, gold standard investigation kind of questions. So in today's session, I have focused more on these kind of questions itself so that you don't have trouble in solving the MCQs in the FMGE examination. Sure. Great. So without any further delay, let's start. There would be 50 questions and it would be a mixed bag of questions where I've included some very easy questions, some moderate question and some difficult or out of the box questions too. Okay, so the same way they are going to appear in the examination. Okay, so let's start without any further delay. Now, these are basically the links for all the channels that you can join me with or you can stay connected me with. Okay, either the Instagram handle, the Telegram handle or the YouTube handle as well. Okay, so don't forget after the session also watch the most expected surgery MCQs that I've taken on my channel as well. So both of them together, there would be around 150 questions and they would be the most probable questions and the expected questions in the FMG examination for surgery. Hopefully clear? Chalo. Now let's start with the first question itself. It states we are having a 36-year-old woman, beta, who is brought to the emergency department following a car crash. That means she is having an accident or she had basically a trauma where she was the driver. On examination, the blood pressure of the female is 80 by 60 millimeters of mercury, that is hypotension. Pulse rate is 118 beats per minute, that is tachycardia. And we all know that whenever the patient is going to have hypotension along with tachycardia, that is usually suggestive of shock, or we can say the patient is hemodynamically unstable, beta. Clear? So that is important. Apart from that, respiratory rate which is there, it is going to be around 5 breaths per minute. Okay, right lower chest wall with right upper quadrant tenderness was noted. Okay, so there was tenderness in the right lower chest wall as well as in the right upper quadrant of the abdomen as well, and diminished breath sounds are noted. Now, please tell me what is going to be the immediate priority to perform in this patient. What is the provisional diagnosis? So, whenever a clinical case scenario or a lengthy question appears in the examination, the first step, as you all know, we do is nothing else but get the clinical diagnosis or the provisional diagnosis of the patient. So, please tell me, beta, what do you expect is going to be the provisional diagnosis of this patient? The provisional diagnosis of the patient is going to be anybody? Let me know in the chat box. So we all know whenever the patient is going to be hemodynamically unstable, along with that patient is going to have respiratory distress or bradypnea because the respiratory rate is only 5 breaths per minute, beta. Along with that, the patient is having diminished breath sounds on auscultation, beta. Then we know it is a very classical scenario of nothing else but option B. It is nothing else but a classical scenario of a case of tension pneumothorax. Okay, so we all know it is a classical case of tension pneumothorax. Okay, I've always told you tension pneumothorax means what? Whenever either the lung of the patient has been injured or the pleura of the patient or chest wall of the patient has been injured, and as there is injury to the lung or the pleura of the chest wall, what is going to pleura and the chest wall, what is going to happen, beta? A lot of air is actually going to collect inside the pleural cavity. Let's say if due to this trauma, beta, the pleura or the chest wall was injured, what will happen? A lot of air from outside will enter inside the pleural cavity and a lot of air will collect inside the pleural cavity. And this excess air in the pleural cavity is going to put a lot of pressure on the lung, and due to which the patient's lung will get collapsed, right? That is the reason for respiratory distress in the patient. In this condition where excess air is collected in the pleural or thoracic cavity of the patient, we know it is called as pneumothorax. Then why we call it as tension? I've always told you one thing, that whenever the pneumothorax is so severe that it is making the patient hemodynamically unstable, beta, or there is a hemodynamic compromise, we know that type of pneumothorax is only called as tension pneumothorax. if the patient is hemodynamically stable or if the patient's vitals are going to be stable. Then you don't call it as tension, then you call it as simple pneumothorax. Okay. So due to pneumothorax, if the patient is stable, call it as simple pneumothorax. Due to pneumothorax, if the patient is unstable, call it as tension pneumothorax. Hopefully clear to all of you now. That is what is important. Now, I've always told you, even when chest x-ray is not done, beta, still we can make a clinical diagnosis of tension pneumothorax in the emergency. And the clinical diagnosis ke liye I've always told you the ABCs. Now, what are the ABCs of tension pneumothorax? So A basically stands for the absent air entry and absent breath sounds, beta, on the affected side. Obviously, because you can see the lung of the patient has been collapsed on the affected side. Therefore, there will be absent air entry and absent breath sound on the affected side of the chest, beta. Second important is breathlessness. The patient is going to present to us with breathlessness, beta, which can also be written as shortness of breath, respiratory distress, bradypnea, okay, dyspnea, all of that. So anything they write regarding the respiratory distress, we know they are talking about breathlessness, beta. And C is basically nothing else but congested neck veins, beta. And we know that congested neck veins can also be written as rise in the JVP or the jugular venous pressure, beta, right? So there will be rise in JVP or jugular venous pressure. Why? Reason, we all know, beta, whenever there is a pneumothorax, obviously it is going to compress the heart. The tension pneumothorax will compress the heart as the right side of the heart is collapsed. Therefore, it is not able to receive the blood. So all the blood collects inside the superior vena cava, and therefore all the blood collects in the internal jugular vein. And that's the reason why there are congested neck veins or rise in the jugular venous pressure, beta. Clear? So do remember, in the question, if you are able to see this classical ABCs of tension pneumothorax, do remember the diagnosis is very clear. Okay. Apart from this, as I've said, tension pneumothorax we will only say whenever the patient is hemodynamically unstable. That means the patient is having a low blood pressure or hypertension, or we can say the patient is in shock. Clear? Apart from that, when I do a percussion, on percussion, beta, you are able to get hyper resonance. See, normally whenever you do percussion of the chest, beta, you usually get resonance. But as here there is more air collection in the pleural cavity, we get hyper resonance. And this hyper resonance can be the keyword, beta, to differentiate a case of pneumothorax from hemothorax. Because in pneumothorax and hemothorax both, you can have these ABC. Yes, absent air entry and breath sounds, breathlessness, and congested neck veins. These are the three features which can be seen in a case of pneumothorax also and in a case of hemothorax also. Then how to clinically differentiate them? So to clinically differentiate pneumothorax and hemothorax, we do a percussion. If I do a percussion in a case of tension pneumothorax, as I've told you, we get hyper resonance. Whereas if I do percussion in a case of hemothorax, when there is blood inside the pleural cavity, I get dullness, beta. So if they say on percussion, you are able to get dullness in the chest, that is a provisional diagnosis of hemothorax mostly. Hopefully clear? So that is what is important to be remembered. Now, in this condition of tension pneumothorax, when the patient is hemodynamically unstable, I don't wait for a chest x-ray to be done. I just make a clinical diagnosis of the patient and I directly proceed for the immediate treatment or the emergency treatment. Reason, if I'm not going to do an emergency treatment, the patient is going to lose his life. Clear? So, chest x-ray is not a priority over here, beta. Now, important is, whenever a patient of trauma comes to us, we know we have to manage that patient of trauma according to the ATLS protocol. What is ATLS? ATLS is Advanced Trauma Life Support, beta. So whenever any patient of trauma who comes to us, we manage that patient according to the ATLS protocol, that is Advanced Trauma Life Support. Hopefully clear? And we all know, in the primary survey of ATLS protocol, our aim is to save the patient's life, beta. And what we do to save the patient's life? To save the patient's life, beta, we have to perform the basic resuscitation, right? To save the patient's life, we perform basic resuscitation. Now, important is, when I do basic resuscitation, what is the sequence of basic resuscitation in a patient of trauma? Let me know in the chat box whether it is ABC or is it CAB. In a case of trauma, when you follow the ATLS protocol, what is the sequence of basic resuscitation that you tend to follow? Whether it is ABC or it is CAB. Let me know in the chat box. Do participate in the questions so that you're able to understand. Does not matter even if you're doing mistakes, that's absolutely fine. You have time to be corrected. So do remember, beta, according to ATLS protocol, the sequence of basic resuscitation is going to be A, B, C, D, E, beta. Yes. According to ATLS protocol, the sequence of basic resuscitation is A, B, C, D, E, where utmost priority is always given to airway management. Clear? The CAB sequence that you are able to recall, that CAB, that is circulation, airway and breathing, that is a sequence followed in the BLS or the ACLS protocol when the patient is suffering from cardiac arrest, where you start giving CPR or chest compressions to the patient. In BLS or ACLS protocol, you follow the sequence CAB, but in ATLS protocol of trauma, we have to follow the sequence A, B, C, D, E, where utmost priority is given to airway, followed by breathing, followed by circulation, followed by disability, and followed by exposure, beta. Okay, so do remember, any patient of trauma, utmost priority is always the airway management. And to manage the patient's airway, beta, what we should do over here, to manage my patient's airway, I have to go for option C. That is nothing else but thoracostomy. What is thoracostomy? You have to insert a needle inside the thoracic cavity, beta. Yes, in the intercostal space, just insert a wide bore needle, beta. That is what is called as needle thoracostomy. Why? So that at least some air which is collected in the pleural cavity will be able to escape out from that needle. And if the air escapes out from the needle, beta, the pressure in the pleural cavity is going to decrease. And as the pressure in the pleural cavity decreases, beta, the lung will be able to expand and the patient's respiratory distress is going to be resolved, or the patient's airway status will be properly maintained or managed, beta. Clear about? That is what is important to be remembered. So the first step in management is a thoracostomy. That is nothing else but a needle thoracostomy has to be a priority. And whenever we have to do a needle thoracostomy, I hope all of you are quite aware about one thing, that we have to insert the needle in the fifth intercostal space, beta, just anterior to the mid-axillary line if the patient is an adult. If the patient is an adult, insert the needle in the fifth intercostal space just anterior to the mid-axillary line. But whereas if the patient is a small child, beta, insert the needle in the second intercostal space, beta, that is usually on the mid-clavicular line. So whenever a child is having tension pneumothorax, then insert the needle in the second intercostal space, beta, on the mid-clavicular line. That has to be kept in mind. No issues with this, anybody? So these are the points that you have to remember. Now, in a PYQ, basically, beta, do remember there was a question that where the needle has to be inserted, along which border of which rib. So do remember, beta, if this is the intercostal space, you have to insert the needle along the upper border of the second rib. You have to insert along the upper border of the lower rib, beta. Do remember. So whenever you have to insert the needle, beta, in a case of needle thoracostomy, always remember we have to insert the needle along the upper border of the lower rib. Why along the upper border of lower rib? Reason is, just below the lower border of upper rib, beta, you are going to have the neurovascular bundle. And if you insert the needle along the lower border of the upper rib, beta, the neurovascular bundle will get damaged. And that's the reason the site of needle insertion is always along the upper border of lower rib. That has been a PYQ in FMGE June 2023. Clear? Apart from that, whether it is second or whether it is fifth, so do remember basically, beta, it is going to be fifth intercostal space anterior to mid-axillary line in adult and second intercostal space on mid-clavicular line in a child. In a recent PYQ in the FMGE exam, yes, the question was about an adult for a needle thoracostomy or needle decompression, but fifth intercostal space was not given an option. As fifth intercostal space was not given an option, therefore the answer was second intercostal space. If fifth intercostal space was an option, my preferred choice would have been fifth intercostal space itself. So don't rectify the PYQ answers. That is what is a mistake that most of the people do. They rectify the PYQ. Did you even see the options properly? Okay? So it depends on the option. You have to choose the single best option, beta, whatever are available among them. So as fifth was not an option, therefore we marked it as second in the recent examination. Hopefully clear. Now hopefully your doubt is going to be resolved. Clear? Now why not BP? Bhai, if the patient's airway is compromised, the patient is going to die in the next 10 minutes itself. Okay, due to BP or due to hypovolemic shock, the patient may die after half an hour. So what will be your practical approach? Obviously to manage the patient's airway and breathing first, and followed by that I will give IV fluids. Okay, So once I manage the airway and breathing, then obviously I have to manage the circulation and I have to start IV fluids. Clear? But respiratory distress or respiratory arrest can cause an immediate death. Low BP or hypotension is not going to cause an immediate death. Understood? Clear? So that is what is important. So इसीलिए to save your patient's life, you have to go for a thoracostomy or a needle decompression beta as the first choice in a case of tension pneumothorax. Once your patient's airway and breathing has been managed, then you can start IV fluids beta. Chest x-ray is not a priority over here because we know clinical diagnosis of tension pneumothorax is very clear. So you don't need a chest x-ray just to confirm the diagnosis. Once the patient is going to be managed, that means once needle thoracostomy and IV fluids are given, then you can do a chest x-ray also beta. Clear? Endotracheal intubation is not going to be useful in managing the patient's airway. Why? Reason is, we know if you insert the endotracheal tube and start the mechanical ventilation, yes, the ventilator is pushing the air, but problem is due to the excessive air in the pleural cavity or due to the excessive pressure in the pleural cavity, lung is collapsed. Now does not matter with how much pressure the ventilator is going to push the lung beta, but lung is going to be collapsed, so it will not be able to expand and the patient's respiratory distress will never improve. So endotracheal intubation is not going to be a good choice beta. It will not be helpful in managing the patient's airway of tension pneumothorax. So first priority is always needle thoracostomy, also known as needle decompression. Clear? Then followed by IV fluids, then followed by chest x-ray. When you do chest x-ray in patients of tension pneumothorax, do remember few points. First of all, as there is more air collection, therefore on the affected side, you are able to see increased blackening, which is also known as hyperlucency beta. Apart from hyperlucency, you can see the trachea which is there, it is not central beta. It has been pushed or it has been shifted to the opposite side. So you can see there is a contralateral tracheal shift which is seen. Okay. So one is hyperlucency, second is a contralateral tracheal shift. Third, due to excess air collection beta, you can see this white shadow is suggestive of a collapsed lung. Due to excess air pressure, the lung of the patient has been collapsed on the affected side. Next, you can also see beta that the diaphragm on the affected side which is there, it appears comparatively flat. Okay, so there is flattening of the diaphragm on the affected side which is seen. And last but most important is this. You can see there is a deep CP angle or a deep costophrenic angle. And we all know that whenever deep CP angle or deep costophrenic angle is seen on a chest x-ray, it is classically called as the deep sulcus sign. And deep sulcus sign is a very classical finding on chest x-ray of tension pneumothorax beta. So deep sulcus sign is a very classical finding on the chest x-ray of a case of tension pneumothorax. Hopefully clear. So if x-ray comes in a case of tension pneumothorax, these are going to be the findings that you will be able to observe. Hopefully clear. Now if they ask you what is the first line management, we know the first line management has to be needle decompression or the needle thoracostomy in the fifth intercostal space or the second intercostal space beta. Okay. But definitive management would be what? So do remember the best treatment or the definitive treatment is going to be ICD tube insertion beta. And we all know ICD tube is nothing else but intercostal drainage tube. So you have to insert the intercostal drainage tube beta so that all the air is able to escape out the pleural cavity beta. Okay? And this ICD tube insertion is also known as tube thoracostomy. Like needle decompression is known as needle thoracostomy. In same manner, ICD tube insertion can also be referred to as tube thoracostomy. That has to be kept in mind. And do remember one point, that this ICD tube insertion or tube thoracostomy beta, that is also done in the fifth intercostal space. But exactly where? In the triangle of safety. It is usually done in the fifth intercostal space beta, in the triangle of safety. Okay? So triangle of safety is in the axilla. Anterior border formed by the pectoralis major muscle, posterior border formed by latissimus dorsi muscle, apex of the triangle formed by base of axilla, and the base of the triangle formed by the fifth intercostal space. In that triangle of safety, in the fifth intercostal space, insert your ICD tube, okay, for the drainage of all the air collected in the pleural cavity. Hopefully clear. So that was about the first question. Second question, if I talk about, is a young patient presents to you beta in the OPD with complaints of a midline neck swelling, and this swelling has progressed slowly over the last few years beta. Okay, it has not developed in one day, so it is a chronic condition where the swelling has developed over the last few years slowly. He does not mention any kind of tenderness or dyspnea. So we know there is no pain, so less likely to be an infection or an inflammation. There is no dyspnea, so that means the swelling is not huge. It is not causing any tracheal compression, or it is not causing any respiratory distress as such, right? On examination, the swelling is noticed to move. Okay, the swelling which is there, it is noticed to move with deglutition, that is known as swallowing. Okay, the swelling moves with deglutition of swallowing, and swelling also moves with protrusion of tongue as well. What is the most appropriate next step in this case? What is your provisional diagnosis? What do you think? I'm not sure why the first line is not visible. So now if it is visible, tell me what is actually going to be your provisional diagnosis beta in this condition. What are you thinking about? So we know, yes, the provisional diagnosis of this case is nothing else but a thyroglossal cyst. Very good. Shabash. So we know beta, the provisional diagnosis in this condition is nothing else but the thyroglossal cyst beta. That has to be remembered. We know thyroglossal cyst is what? Whenever there is collection of fluid inside the thyroglossal tract beta. Okay. So whenever there is a patent thyroglossal tract, and in that patent thyroglossal tract, there is collection of fluid over a period of time leading to formation of a classical thyroglossal cyst. We know all the thyroid swellings are the ones beta, they are going to be midline neck swellings. Okay? All the thyroid swellings are going to be midline neck swellings, and these swellings which are there beta, they are always going to move with deglutition. Yes, if the swelling is moving with deglutition, we know it is a thyroid swelling. But not all the swellings of thyroid gland move with protrusion of tongue or movement of tongue. So as soon as they say that the swelling moves with protrusion of tongue or movement of tongue beta, then do remember, we know it is definitely a case of thyroglossal cyst beta. Because in thyroglossal cyst, we know the thyroglossal tract is patent and it is connected to the tongue. Therefore, as the swelling, as the tongue moves, the swelling is also going to move beta. That is what is important. So protrusion of tongue, which leads to movement of the swelling, is a key feature in the diagnosis of thyroglossal cyst. We all know that the most common site for development of a thyroglossal cyst was a PYQ in the FMGE exam. And do remember, the most common site for a thyroglossal cyst is subhyoid, also called as infrahyoid beta. So subhyoid or infrahyoid is the location of thyroglossal cyst. Now if they ask you what is the next step, so we all know in this condition beta, the next step has to be investigation first. Why? Because without doing an investigation beta, I cannot confirm the diagnosis, right? So yes, I will be providing the annotated PDF in my Telegram group at the end of the session. Don't worry about it. Clear? So you can definitely remember beta that here the next best step is first to confirm the diagnosis beta. And to confirm the diagnosis of thyroglossal cyst, the next step has to be nothing else but option D, that is ultrasound neck. Yes, for any fluid collections or for any neck swellings beta, the first line investigation or investigation of choice in most of the scenarios would be an ultrasound neck beta. Okay, FNSC or biopsy is usually not recommended in cases of thyroglossal cyst. Reason, FNSC or biopsy or incision, if you do beta, then there can be a formation of a thyroglossal fistula, and due to the risk of thyroglossal fistula, FNSC or biopsy are not going to be the choices to be done in cases of thyroglossal cyst. Yes, in case if the thyroid score, that is thyroid imaging reporting and data system, if the thyroid score is high, then you may think about FNSC as the choice. But do remember, without the thyroid score, you never go for the FNSC beta. And thyroid score you get after an ultrasound. The first step is do an ultrasound, get to know about the thyroid score. If the thyroid score is low, if the thyroid score is 1 and 2, you don't need to do an FNSC, because thyroids 1 and thyroids 2 are suggestive of benign lesions beta. But if the thyroid score is high, that is thyroids 3, 4 or 5, so thyroids 3, 4 and 5 are suggestive of malignancy. In those conditions, you may go for a FNSC as the next step beta. Clear? So that is what is important to be remembered. No issues with this? Chalo. Next important if I talk about is, if they would have asked me that what is the treatment of choice, or if they would have said that ultrasound neck has been done and it has confirmed the diagnosis of thyroglossal cyst, then my next step definitely would have been cyst trunks operation beta. So do remember, cyst trunks operation is surely the treatment of choice in cases of thyroglossal cyst. What we do in cyst trunks operation, we basically do a surgical removal or a surgical excision of the thyroglossal cyst along with the thyroglossal tract, along with the part of hyoid bone as well, beta. That is known as cyst trunk surgery. Do remember, cyst trunk surgery is usually done in both the conditions, beta, whether it is a diagnosis of thyroglossal cyst or it is a diagnosis of thyroglossal fistula. Hopefully clear. That is what is important. Clear? But directly you don't go for treatment. First you do diagnosis now. Or do you say a person has come to the OPD, check directly OT? You don't say that, right? First you do investigations, first you confirm the diagnosis, then you go for surgery. Clear? Radioactive iodine scan, beta, again, radioactive iodine scan is usually not needed, beta, in this condition. Okay? Hopefully clear. So next line would have been ultrasound and treatment of choice would have been cyst trunk operation. Okay? This is how the thyroglossal cyst is going to appear, beta, in the middle of the neck, and as you can see, as the patient moves the tongue or protrudes out the tongue, the swelling also moves, beta. The swelling is moved upwards. Clear? That is the classical presentation of a case of thyroglossal cyst, beta. That is what is important. Hopefully clear. Next, if I talk about now is question number 3, beta, which states, beta, okay, young female management bhi hota hai. Even if the question was next step in management, still my answer would have remained ultrasound neck itself. Management is not treatment directly. Management is first making a diagnosis and then doing the treatment of the patient. Understood, Kushagra? Okay. So if I talk about question number 3, a young female in the postpartum period, that is after delivery, beta, in the lactation phase, presented to the OPD with complaints like pain and fullness inside her left breast, beta. She gives history that the child refuses the feed from her left breast. Due to whatsoever reason, the child is not taking the feeds from the left breast, beta. They are asking you what is the first line treatment option in this female. What is your provisional diagnosis? First, let me know that. What is your provisional diagnosis, beta, in this condition? Provisional diagnosis first. Without provisional diagnosis, I don't go for a treatment. You don't even know what is the condition and you're directly deciding treatment. How is that possible? Without knowing that provisional diagnosis, how you're deciding treatment? What are you going to tell your patient? Yeah, I don't know the diagnosis, but I'm doing this. It is not breast abscess, first of all. It is not at all breast abscess. Did they mention any kind of fever? Did they mention any local sign of inflammation like redness or swelling? If nothing is mentioned, how the hell are we thinking of breast abscess, which is an infection and that to a severe infection? The condition is breast engorgement. Shabash bacho. The provisional diagnosis of this condition is a breast engorgement. And engorgement literally means fullness. Engorgement is literally fullness. Clear? Now, as the baby was not taking the feeds, beta, from one of the breasts. So what happened? All the milk was collected inside that particular breast, beta, for a longer duration of time. And as there was excess milk in that breast, beta, the breast was full with milk or the breast was engorged with milk. Understood? That is a classical case of breast engorgement, not even mastitis. Do remember, because mastitis is infection of the breast. Again, fever or local signs of inflammation will be present in a case of mastitis. Here, apart from pain, no other sign of local inflammation I am able to see and no history of fever is given. So therefore, mastitis and breast abscess becomes less likely as a diagnosis. The diagnosis in this condition is breast engorgement, which is actually a more common question in the FMGE exam compared to breast abscess. But as a lot of people are always so obsessed with abscess, I'm not sure why, that they think every question of breast condition is abscess only. No, it's not. If they have only mentioned patient is having pain and fullness, beta, then the diagnosis has to be breast engorgement. Clear about? So pain is basically because the breast is so full or so engorged with milk that the patient is having pain, beta. Understood? So that is what is important. So this is a classical diagnosis of breast engorgement and we all know. Yes. Now all of you are right. Breast engorgement with the treatment which is there is nothing else but option C, beta. You have to express out the milk and at the same time you can apply some warm moist compresses around the breast, beta. Now as the mother is expressing out the milk, she can do it manually also or she can do it with the help of a breast pump also, beta. But she has to express out all that collected milk inside the breast so that she'll have pain relief, beta, in the condition. Clear? And that warm moist compresses are applied around the breast to just give her some pain relief or symptomatic relief, beta. Understood? That is important. Now if I would have said a case of breast abscess, then do remember, we know if the patient is having mastitis, then that condition can further progress to a breast abscess, beta. And we all know abscess is a pus collection. Okay. So whenever there is breast abscess, that means there is pus collection in the breast. Whether they ask you what is the most common cause of mastitis, or they ask you what most common cause of breast abscess. Yes, the name of the organism remains the same, beta. That is nothing else but called as Staph aureus vitae. The name of the organism remains same. That is nothing else but Staph aureus, as a lot of you have answered already. Clear? In cases of breast abscess, beta, do remember there should be a cracked nipple or a dry nipple, because from that cracked or dry nipple, the Staph aureus from the baby's mouth will go inside the breast and it is going to cause an infection or an abscess, beta. And when there is an abscess, do remember the symptoms. Yes, the patient may have pain inside the breast, but along with that, the patient may have redness over the breast, the patient may have warmth over the breast. That is the local signs of inflammation like pain, redness, and warmth are present, as you are able to see in the picture. Apart from that, yes, very important, the patient is also going to have fever, beta. Okay, the patient is also going to have fever, and most importantly, a late sign which is seen, beta. Yes, a late sign which is seen, that is nothing else but fluctuant swelling, beta. Due to fluid collection or due to a pus collection, beta, you are able to see a classical fluctuant swelling inside the breast. So if they are mentioning local signs of inflammation, fever, fluctuant swelling, or this kind of image is given, then my answer is definitely a case of nothing else but breast abscess, beta. In cases of breast abscess, if they ask you what is going to be your first line treatment, do remember breast abscess ka diagnosis has to be confirmed by an ultrasound. So whenever a patient comes to you with a classical clinical case scenario of breast abscess and they ask you what should be the next best step. So if the patient has not been diagnosed yet, then please do a ultrasound breast first, and by ultrasound breast confirm the diagnosis first. Once you have confirmed the diagnosis by an ultrasound breast, then you will go for treatment. And when I talk about treatment in cases of breast abscess, do remember the first line treatment is going to be an ultrasound guided aspiration or an ultrasound guided needle aspiration. Yes, you don't directly jump onto incision and drainage as the treatment, beta. So initially you can try for a needle aspiration or an ultrasound guided aspiration. How many attempts? I can do 2 attempts of ultrasound guided aspiration along with antibiotics, beta. So do ultrasound guided aspiration or needle aspiration along with antibiotics. That can be done twice basically, beta. Clear? That is what is important. But do remember, beta, if both the attempts of ultrasound guided aspiration fail, then the treatment is nothing else but, beta, incision and drainage. Yes. If the ultrasound guided aspiration fails, or if they ask you what is the best treatment or most appropriate treatment for breast abscess, then you can mark it as IND, that is incision and drainage, along with antibiotics, beta. Important is, we know incision and drainage is done with the help of which number surgical blade? Let me know that in the chat box. Which number surgical blade is used for the treatment of breast abscess or for incision and drainage? And we know the antibiotics given in patients of breast abscess are penicillins like cloxacillin or dicloxacillin, beta. Right? So penicillins like cloxacillin and dicloxacillin are the safest antibiotics to be used in the treatment of mastitis or breast abscess, beta, in a lactating female. This was the PYQ need to do. Remember the antibiotics used are cloxacillin or dicloxacillin, beta. Okay? So that is what is important to be remembered. Mastitis or breast abscess, I have told you, mastitis mein the patient will have pain, redness and warmth along with fever also. But the patient will never have any kind of fluctuant swelling. The patient will never have ultrasound showing fluid collection. If they say fluctuant swelling is present or ultrasound is showing fluid collection, then it is a case of breast abscess, beta. Clear? So to differentiate a case of mastitis from breast abscess, you need to do a clinical examination and ultrasound of the patient properly. Then only you can confirm the diagnosis. Very good. Yes, the number 11 surgical blade or the stab blade basically, beta, which is used. Clear? For the incision and drainage for the treatment of breast abscess. Hopefully clear? Chalo, great. Next important if I talk about is question number 4 that says question number 4 says a 30-year-old patient, beta, presents to you with complaints like palpitations, tremors and diaphoresis. Okay, we know palpitations in this patient are due to tachycardia and the diaphoresis is excessive sweating. He also gives history of episodic headache, beta. Okay, so suddenly the patient's blood pressure spikes up. That means there is an episodic hypertension, and due to that the patient might be having episodic headache. And the patient is also having weight loss over the last 1 year. On examination, his pulse rate is found to be 110 beats per minute. Blood pressure is 156 by 90 millimeters of mercury and respiratory rate is 24 breaths per minute. Lab values reveal beta there is an elevated plasma fractionated metanephrin. Now they're asking you what shall be the next appropriate step in this scenario. First, at looking at the question, tell me the provisional diagnosis. Nobody is going to directly mark the answer today. Okay, you might be used to marking the answers directly, but I am not fond of directly marking the answers without knowing what are you thinking about. I'll be sharing the PDF at the end of the session once it is annotated. Beta. Clear? Very good. The provisional diagnosis of the condition. As soon as they say a classical clinical triad, palpitations along with diaphoresis, along with episodic headache beta. So we know this is a classical clinical triad seen in patients of pheochromocytoma. Shabash. And we know the diagnosis was almost confirmed beta by elevated plasma fractionated metanephrines. We know as soon as they mention that the plasma fractionated metanephrines are high, we know it is definitely a diagnosis of pheochromocytoma. And we all know pheochromocytoma can be either a benign or a malignant tumor beta arising from the chromaffin cells. So it is a benign or a malignant tumor arising from the chromaffin cells beta. We know pheochromocytoma is a tumor which is known to cause excess secretion of catecholamines beta. And I hope all of you are quite aware, catecholamines are nothing else but substances like epinephrine, norepinephrine and dopamine beta. They are the substances like epinephrine, norepinephrine and dopamine. So do remember, we know all the catecholamines like epinephrine, norepinephrine and dopamine are sympathetic in nature. As there is excess secretion of catecholamines, there is increased sympathetic activity in cases of pheochromocytoma. And due to that increased sympathetic activity, you can see the patient is having a high blood pressure, that is hypertension, and an increased heart rate, that is tachycardia beta. Clear? That is what is important to be remembered in the patient. Hopefully clear. Now in cases of pheochromocytoma, we know the screening test that we do is nothing else but the 24-hour urinary metanephrine levels or the 24-hour urinary catecholamine levels beta. So 24-hour urinary catecholamine levels, 24-hour urinary metanephrine levels or 24-hour urinary VMA levels beta. All of these are going to be the screening test in a case of pheochromocytoma. Whereas investigation of choice, one would be a plasma fractionated metanephrines beta, and second important is going to be MRI abdomen. So we know plasma fractionated metanephrines will tell you whether the metanephrines or catecholamine levels are high or not, and MRI abdomen will help you to locate the tumor beta. If you want to localize the tumor, then you have to do a MRI abdomen. Okay, why MRI abdomen? Because I hope all of you remember the rule of 10 in cases of pheochromocytoma beta. Okay, when I talk about rule of 10 in pheochromocytoma, we all know few things. That is, according to the rule of 10 of pheochromocytoma, only 10% cases of pheochromocytoma are bilateral in nature, whereas 90% cases are unilateral beta. Only 10% cases of pheochromocytoma are seen in children, whereas 90% cases are seen in adults beta. Only 10% cases of pheochromocytoma are usually malignant in nature, whereas rest 90% cases of pheochromocytoma are going to be benign in nature itself. And usually around 10-20% cases of pheochromocytoma beta are extra-adrenal in nature. Rest 80 to 90% cases of pheochromocytoma are going to arise from the adrenal medulla itself beta. And as majority of the pheochromocytomas arise from the adrenal medulla itself, therefore we can do a MRI abdomen to localize the tumor beta or to confirm the size of tumor, site of tumor, extent of tumor, everything. Okay? And when you do MRI abdomen, this kind of tumor you can see arising from the adrenal gland, or to be specific from the adrenal medulla beta. Hopefully clear. So now here already the plasma fractionated metanephrines they have checked, and they are saying that the plasma fractionated metanephrines are already high. So we know it is definitely a diagnosis of pheochromocytoma. So what should be our next step beta? Definitely our next appropriate step should be localizing the tumor beta. The next step should definitely be finding the tumor. Very good all of you. And therefore to find the tumor beta, my answer has to be nothing else but option A, that is MRI abdomen to be done. The next step is definitely beta. I have to definitely start MRI, I have to perform the MRI abdomen beta. Once I perform the MRI abdomen definitely, then I can confirm the diagnosis beta. Clear? And once I have confirmed the diagnosis, then I have to definitely start phenoxybenzamine and propranolol beta to manage the patient's hypertension. We all know that phenoxybenzamine is nothing else but a non-selective alpha blocker and propranolol is a non-selective beta blocker. And in the same sequence, they have to be started with that is alpha followed by beta. So to manage the preoperative hypertension before the surgery beta, you have to start giving phenoxybenzamine to the patient. Along with that, you have to start giving propranolol to the patient beta. That is what is important to remember. Clear? These are the drugs which will help in managing the preoperative hypertension. Then, in the meanwhile, you can also plan an adrenalectomy in the patient beta. Once the diagnosis has been confirmed and the preoperative hypertension has been managed, then you can plan an adrenalectomy. And while you are doing an adrenalectomy or while you are doing a surgery for the removal of tumor beta, we know patient might have an intraoperative hypertension. And if the patient is going to have an intraop hypertension basically, then do remember for that, we have to give a drug that is IV phentolamine with it. For managing the intraoperative hypertension, we have to give a alpha blocker again, and that drug is known as IV phentolamine. Hopefully clear. So that is the case for nothing else but pheochromocytoma beta. And do remember, these few cases of pheochromocytoma beta which arise from the extra-adrenal sites, that is the organ of Zucker candle basically beta. Okay? Organ of Zucker candle basically, or from the sympathetic chain. For diagnosis of them, we have to do which investigation? Let me know in the chat box. For diagnosing extra-adrenal pheochromocytomas, which investigation is done? Anybody? Post-operatively, you can start the patient basically on propranolol drugs as well. Anybody? So do remember, for diagnosing the location of the adrenal pheochromocytoma, we do a MRI abdomen. In case if the pheochromocytoma is very small in size, then we can do a MIBG scan. Yes, if the tumor is very small in size or it is deep seated inside the adrenal medulla, then you do a MIBG scan. But if there is an extra-adrenal pheochromocytoma, then please tell me, for extra-adrenal pheochromocytomas beta, then what has to be done? For an extra-adrenal pheochromocytoma. So do remember, to confirm the diagnosis of extra-adrenal pheochromocytoma, to confirm the location of extra-adrenal pheochromocytoma, we do a PET-CT beta. Yes, a whole body PET-CT scan has to be done whenever I have to do a confirmation of an extra-adrenal pheochromocytoma. That is what is important to be remembered. Understood? Sure. So these were the things that you have to keep in mind, beta. Pheochromocytoma is one of the commonest questions in the FMGE exam. Next is question number 5. Here the question says, a middle-aged male who is a chronic alcoholic presents to the emergency room beta with sudden onset hematemesis. He is a known case of CLD, that is chronic liver disease, and also has abdominal distension. Which of the following is the most likely cause? What is going to be your answer within this question? Let me know in the chat box now. What is going to be your answer in this question? Options are Mallory-Weiss-Dier, Boerhaave syndrome, perforated peptic ulcer, and bleeding varices. Hopefully now it is visible. Dotatate is basically nothing else but beta, the contrast that we use. Not even one. Not even one. And the answer to this question is not Mallory-Weiss-Dier. Not at all Mallory-Weiss-Dier. Yes. This was a PYQ in the FMGE exam. Don't make blunders in the PYQs of FMGE exam at least. Clear? Here there is a chronic alcoholic. I understand that. Okay, fine. But did they mention any history of binge drinking or binge eating in the question? No. So did they mention any severe vomiting or retching episodes in the patient? No. Then how the hell are we thinking about a tear in the esophagus? If there is no binge drinking, if there is no vomiting only, how there can be a tear in the esophagus? Okay? So do remember, here they mention some keywords. That is, a patient is a known case of CLD. I hope all of you are quite aware. CLD is what? CLD is nothing else but chronic liver disease. And chronic liver disease is another name for cirrhosis. So here the patient is a known case of chronic liver disease or cirrhosis beta. That has to be kept in mind. Now, if I talk about chronic liver disease or cirrhosis, why it is associated with chronic alcoholic? Reason, the most common cause of chronic liver disease or the most common cause of cirrhosis is alcohol. So alcoholic cirrhosis or alcoholic liver disease is the most common type of cirrhosis. Hopefully clear? That is what is important to be remembered. Clear about? Next important is, we know they have also mentioned the patient is having abdominal distension. A patient of cirrhosis or chronic liver disease, if he is having abdominal distension, that means the patient is having ascites. Okay. So the patient of cirrhosis or chronic liver disease is having ascites. And ascites usually develops beta in patients of cirrhosis, and it can also be commonly associated with portal hypertension. So ascites and portal hypertensions are the two features which can be seen in a patient of chronic liver disease or cirrhosis. And we know whenever there is portal hypertension or whenever the pressure inside the portal circulation is going to increase, the pressure at all the sites of portosystemic shunts or the pressure at all the sites of portosystemic anastomosis is going to increase beta, leading to three problems. First of all, the lower esophageal vessels will get dilated and they'll become tortuous, leading to formation of esophageal varices. And we know in the esophageal vessels, when the pressure increases too much, initially they get dilated and they become tortuous like these, as you are able to see in the picture. These are known as esophageal varices. But at times they may rupture and can cause an upper GI bleeding or upper GI hemorrhage, which can manifest as hematemesis. Clear? Second important, we know the periumbilical vessels will get dilated and they'll become tortuous. The periumbilical vessels, when they become dilated and tortuous, that phenomena is classically known as caput medusae beta. That is classically known as caput medusae. And third, the rectal vessels will become dilated and tortuous. When the rectal vessels will become dilated and tortuous, that is classically known as rectal varices, or some of them are hemorrhoids. And these rectal varices of hemorrhoids, when they are going to rupture, then the patient is going to have lower GI hemorrhage or lower GI bleeding, which can manifest as hematochezia. Hopefully clear. So a patient of cirrhosis or chronic liver disease may develop portal hypertension, and due to portal hypertension the patient may develop esophageal varices which can bleed, and therefore the patient is presenting to you with hematemesis beta. Okay, here there was no history of binge drinking, no history of vomiting or retching. So malarious tear as well as Boerhaave syndrome, both are ruled out from the option because they only happen when the pressure inside the esophagus increases, because malarious is a tear and Boerhaave syndrome is a perforation of the esophagus. Okay, that is important. Perforated peptic ulcer, yes, this could be a case, but please remember beta, perforated peptic ulcer hota, then the patient would definitely have signs of peritonitis beta. That is nothing else but the patient will have severe abdominal pain along with guarding and board-like rigidity, and the patient would be hemodynamically unstable at times. So yes, then I would have said it is a case of perforated peptic ulcer, but no such feature is given over here basically. Clear about that is what is important. Yes, I've told you that perforated peptic ulcer or hollow viscous perforation would have been the case, but here definitely beta, they have not mentioned any signs of peritonitis. Then how I can think about a perforated peptic ulcer? They have not even said that there is a gas under diaphragm seen on the X-ray as well. So then perforation ka case becomes very less likely in the case. The question clear? The answer has to be option D. That is nothing else but bleeding esophageal varices. We all know that esophageal varices are going to bleed beta whenever the pressure. Esophageal varices are going to form beta whenever the pressure inside them is going to exceed more than 10 millimeters of mercury, and we know esophageal varices are going to bleed beta whenever the pressure inside them is going to exceed more than 12 millimeters of mercury. Hopefully clear to all of you. That has to be remembered. Whenever a patient of bleeding esophageal varices is brought to you, please tell me what should be the first line management. If my question in this case would have been what is going to be a first line management, what is your answer? Let me know in the chat box. If they ask you what is the first line management in this question, then what is going to be your answer beta? Please tell me that also, because that could be another probable question. Jaldi batao. What should be your first line management in a case of bleeding esophageal varices? Very good, shabash. Yes, so do remember the first line treatment. If they would have asked me beta, my answer would not be terlipressin or octreotide or anything like that. My answer would be straightforward basic resuscitation. Very good. that is nothing else but I will stabilize the patient beta and I'll take care of my patients A, B, C. That is, as the patient is having ongoing bleed, he will be hemodynamically unstable. Therefore, my first step is nothing else but beta, I will give IV fluids to my patient to stabilize him. Yes, that is important. So basic resuscitation or IV fluids will be my first choice beta. And then I can go for an upper GI endoscopy beta. Then I can go for an upper GI endoscopy if needed. Clear? Next important, definitive treatment may we know beta. Then I will go for the medical management. And medical management can be done with drugs like IV terlipressin, we know. IV terlipressin. Terlipressin is a desmopressin analog or IV octreotide. Octreotide is a somatostatin analog. So terlipressin is better if available. If not, then you can use octreotide. So terlipressin or octreotide can help you to stop the bleeding beta. In case if the bleeding is not stopped even after giving terlipressin or octreotide, then the next option is usually going to be banding or sclerotherapy beta. In case if the bleeding does not stop even after giving terlipressin or octreotide, then I can go for banding or sclerotherapy. So endoscopic banding or endoscopic sclerotherapy can be done to control the bleeding. In case if banding or sclerotherapy also does not help, like if banding or sclerotherapy also fails, then in that condition the last option is a surgery called as TIPS. In that condition the last option is a surgery known as TIPS, that is transjugular intrahepatic portosystemic shunt beta. Then it is basically a transjugular intrahepatic portosystemic shunt which is going to be seen. Hopefully clear to all of you now. So that is what is the treatment or the management in a case of nothing else but beta, the esophageal varices when they are bleeding. Next important, if I talk about the basic differences for those who are always confused in between malarious and Boerhaave syndrome. Just remember the differences I'm telling you. In both the cases, they'll say that the patient is a chronic alcoholic beta, but they'll also mention that the patient had a binge drinking or a binge eating episode. The patient had a binge drinking or a binge eating episode. Followed by this, they'll mention patient had severe retching or vomiting beta. Followed by this, they'll mention the patient had severe retching or vomiting. Hopefully clear. That is what is important. And now if they say after this retching or vomiting, if the patient presented to you only with hematemesis beta, if the patient presented to you only with hematemesis, that is upper GI bleeding or the blood in vomitus, then definitely my diagnosis has to be malarious tear beta. Then definitely my diagnosis is going to be malarious tear. Hopefully clear. Malarious tear is usually seen in the lower 1/3 of the esophagus beta due to excessive pressure inside the esophagus or due to severe retching and vomiting beta. Clear? So as you are able to see from gastroesophageal junction, there is a tear extending upwards. This is a malarious tear in the lower esophagus beta. And the most common vessel to bleed in patients of malarious tear is the left gastric artery. The commonest vessel to bleed in malarious tear, I hope all of you are quite aware, it is classically the left gastric artery that has to be remembered. No issues with this? Chalo. Coming back to the another question beta, that is, if they say the same history is there, but along with that, the patient is having the classical macular striae beta. And I hope all of you are quite aware about the macular striae. One is chest pain, second is vomiting, and third is a subcutaneous emphysema. So when they'll mention these kind of conditions beta, like the patient is having chest pain, there is vomiting, there is subcutaneous emphysema beta, or there are signs of pneumomediastinum. That means Hammond-Krantz sign on auscultation or the continuous diaphragm sign on chest x-ray. So if you are able to see features of pneumomediastinum beta, then definitely your diagnosis comes down to Boerhaave syndrome beta, that is nothing else but a spontaneous esophageal perforation due to excessive pressure in the esophagus or due to severe retching and vomiting. This is a spontaneous esophageal perforation or an esophageal rupture beta. Hopefully clear. So yaad rakhna, whenever only hematemesis is mentioned after this history, think about malarious tear as the diagnosis. When chest pain, subcutaneous emphysema, pneumomediastinum is mentioned after this history, think about Boerhaave syndrome or a spontaneous esophageal perforation beta. That is what is important. Chalo, hopefully clear to all of you now. No doubts left with malarious tear also. Okay. Chalo. Next important question now is question number 6 beta. It states the neonate in the 4th week of life was brought to the pediatrics OPD with complaints like a projectile vomiting after feeds. So whenever you're feeding the child had a projectile vomiting. There was failure to thrive. The failure to thrive means the child was not able to gain weight beta. बच्चे का वजन नहीं बढ़ रहा था. And there was lethargy. Child appears dehydrated beta. And palpation reveals there is an olive-shaped lump inside the epigastrium. What shall be the next best step in the condition? First, tell me what is the provisional diagnosis. Please tell me what is the provisional diagnosis. Very good. So we all know whenever a child or neonate is brought to you after 2 to 3 weeks of life beta with the projectile vomiting after feeds, okay, and the child is having failure to thrive, lethargy, and the child appears dehydrated, and an olive-shaped lump is palpable in the epigastrium. We all know the provisional diagnosis of this case has to be nothing else but CHPS, that is congenital hypertrophic pyloric stenosis beta. Here the diagnosis has to be nothing else but CHPS, that is congenital hypertrophic pyloric stenosis, also called as IHPS. We all know congenital hypertrophic pyloric stenosis is when there is hypertrophy of the pyloric muscles which is seen beta. And as there is hypertrophy of the pyloric muscles, we know the pyloric canal becomes very narrow, causing a gastric outlet obstruction. And as there is a gastric outlet obstruction, therefore the child has regurgitation of food beta, causing a projectile vomiting. So we know a case of CHPS can happen whenever the mother has basically taken erythromycin during pregnancy. This was a PYQ repeated in the FMGE exam. If the mother has taken erythromycin in pregnancy, that can increase the risk of CHPS in the baby beta. That has to be remembered. Apart from this, do remember one thing, that CHPS mein the child comes to you with chronic vomiting. That's the reason the child is going to present to you with features of dehydration, and apart from that, the child is going to have a metabolic or an electrolyte disturbance. The metabolic or electrolyte disturbance is nothing else but the child is going to have hypokalemic, hyponatremic, hypochloremic, metabolic alkalosis, because as the child is losing the acid in vomitus, that's the reason the child is going to have hypokalemic, hyponatremic, hypochloremic, metabolic alkalosis beta, along with paradoxical aciduria. Hopefully clear. So that is the electrolyte disturbance seen in the child suffering from CHPS beta. That is what is important. And we know when you palpate the abdomen, obviously you'll find the olive-shaped lump. Please tell me in the chat box, sausage-shaped lump is a feature of which condition? Sausage-shaped lump is a feature of which condition? Let me know in the chat box beta. Sausage-shaped lump is a feature seen in which condition? And in this condition beta, as the child is coming to us with all these features, obviously here I will do definitely a X-ray abdomen beta, and on that X-ray abdomen we are able to see a very classical sign known as the single bubble sign beta. We can do a X-ray abdo on which you are able to see a very classical sign called as the single bubble sign. Apart from that, you can even do a barium meal, and when I will do a barium meal beta, we are able to see two classical findings, and the two classical findings are: one, the narrow pylorus is appearing as a string sign beta. The narrow pyloric canal appears as a string sign. And second important, this appearance that you are able to see, it is classically known as mushroom sign. This another sign in barium meal is classically known as mushroom sign. The string sign or mushroom sign will be visible on the barium meal of the child of CHPS. Very good. Sausage-shaped lump is a feature of intussusception beta. Do remember that. Sausage-shaped lump is seen in children suffering from intussusception. That is extremely important. Clear? Apart from this, we know investigation of choice in children who are suffering from CHPS or congenital hypertrophic pyloric stenosis is nothing else but ultrasound abdomen beta. So ultrasound abdomen is usually done to confirm the diagnosis of CHPS in the baby, on which you are able to find beta that the thickness of the pyloric muscles which are there, that is going to be more than 4 millimeter. The thickness of the pyloric muscle is more than 4 millimeter, and that confirms the diagnosis. And we all know the treatment which is there. First of all, we have to start IV fluids in the patient beta. The treatment is we have to start IV fluids in the patient, and the fluid of choice that is given in the patient of CHPS has to be half normal saline plus 5% dextrose plus minus KCl beta. KCl or potassium chloride is only given if the child's renal function is normal beta. Only if the child's renal function is normal, then you give a correction of potassium. If this fluid is not in option beta, if this fluid is not given an option, which was not there in a PYQ, then definitely your second best choice has to be your NS or normal saline. So again, don't rectify the PYQ, because in PYQ, as there was no option of half normal saline plus 5% dextrose plus minus KCl beta, therefore the answer was normal saline. Okay? So best choice is half normal saline. If not an option, then you can definitely mark it as normal saline beta. But please tell me in the chat box that which fluid is avoided in children suffering from CHPS. That is important. Which fluid is avoided in a child suffering from CHPS beta? Let me know in the chat box. Okay? Once you have given this fluid, then obviously the treatment of choice, all of us are quite aware, is the classical Ramsted's pyloromyotomy beta. The treatment of choice in a case of CHPS is the classical Ramsted's pyloromyotomy. Hopefully clear. Now please answer the question logically. Think logically and then answer the question beta. Very good. Ringer's lactate has to be avoided. The fluid of choice is this or normal saline, but always avoid Ringer's lactate beta, because Ringer's lactate is going to worsen the metabolic alkalosis in the child. When you give Ringer's lactate, the patient has metabolic alkalosis, therefore the child's condition is going to worsen further. Okay, please tell me what is the next best step. They did not ask you the final step, they did not ask you anything else, they just ask you next best step when a child comes to you with dehydration. When the child comes to you with dehydration, very good, shabash. When the child comes to you with dehydration, the next best step has to be option D. That is, first start giving IV fluids to the child beta. Because if the child is having severe dehydration, we know we can lose the child's life till the time we are going to do an ultrasound and everything. Clear? So the first step or next best step is IV fluids. Very good. Now you have started thinking in the right direction. Very good, shabash. Once you have given IV fluids beta and once the dehydration of the child is managed, then definitely you can go for an ultrasound abdomen in the child beta to confirm the diagnosis further. Hopefully clear? That is what is important to remember. Okay? Great. All of you. Shabash. Next is question number 7. Okay, direct easy question it is now. An elderly female who is a known hypertensive beta, but she is non-compliant. That means she is not taking the medications on time for hypertension. So she will have an uncontrolled hypertension. She has been brought to the casualty with complaints of sudden severe chest pain, which is radiating to the interscapular area or to the center of the back. The chest pain is radiating. The patient is also having recurrent syncopal attacks. On assessment, the vitals of the female are stable. ECG of the female appears absolutely normal beta. And the chest X-ray reveals there is widening of mediastinum. What shall be done next to manage the case? Now in this condition beta, please tell me what is the provisional diagnosis? Very good, shabash. What is the provisional diagnosis in this condition? So we all know beta, it is a classical case of not an aortic aneurysm but an aortic dissection beta. This is a classical case. Hopefully now the question is visible. Very good. The classical provisional diagnosis in this scenario is nothing else but a case of aortic dissection. Due to a uncontrolled hypertension beta, the patient would have a tear inside the aortic wall. And therefore it is a classical diagnosis of nothing else but aortic dissection beta. That has to be kept in mind. Clear? Now we know aortic dissection happens due to an uncontrolled hypertension, therefore seen in a patient who is non-compliant hypertensive beta. Clear? And the patient will have a very classical presentation, that is chest pain radiating to interscapular area along with syncopal attacks beta. These are the keywords for the diagnosis of aortic dissection. In aortic dissection, I hope we know if there is tear in the aortic wall, enough blood will not go to the lower limbs of the patient. And that's the reason you can see an unequal blood pressure in the upper limbs and lower limbs of the patient. Yes, one condition you might have heard beta, where there is unequal BP in upper and lower limbs, that is coarctation of aorta. To be specific, postductal coarctation of aorta. But we know unequal blood pressure in upper limbs and lower limbs are also seen if the patient is usually suffering from aortic dissection beta. That is what is important to be remembered. Clear? In this condition, they say ECG appears normal. Why was ECG done? Obviously, any patient coming to us with severe chest pain, the first line investigation is definitely a ECG to rule out myocardial infarction beta. But the ECG appears normal. Chest X-ray was also done beta, and that reveals widening of mediastinum. That is another keyword for the diagnosis of aortic dissection in the patient beta that has to be remembered. Now, after doing a chest X-ray, they are asking you what should be the next step to manage the case. So we know now the next step is nothing else but option D, CT angiography to be done beta. Do remember, I have always told you in my classes that investigation of choice for the central vessels of the body like aorta is CT angiography beta. But investigation of choice for peripheral vessels of the body like the upper limb vessels or the lower limb vessels is the duplex scan or the color Doppler beta. Clear? That is important. As aorta is a central vessel, the investigation of choice is CT angiography. And can I do a CT angiography? Absolutely yes, because they have said that the patient is hemodynamically stable or the vitals of the patient are stable. If they would have said beta that my patient is not hemodynamically unstable, if my patient is not hemodynamically stable, then the investigation of choice would be a transesophageal echo. If they would have said that my patient's vitals are hemodynamically unstable, then my answer would have been option A, that is the transesophageal echo beta. Okay. Next, if I talk about CT angiography in aortic dissection, it shows you with sign. So all of you are rightly marked. Yes, here you are able to see this is the main lumen of aorta and this is a tear in the aorta, giving you a very classical sign beta called as a tennis ball sign. So CT angio in case of aortic dissection shows us the very classical tennis ball sign beta. Hopefully clear. That is important. And do remember in this condition beta, what should be the management? Now, whether I should go for IV esmolol and monitoring or I should go for a surgical repair, that completely depends beta on which type of aortic dissection is it. So we have to see the classification. Do remember, one is the DBK's classification, which classifies aortic dissection into three types, type 1, 2 and 3. But second is the Stanford classification, which classifies aortic dissection into two types, that is Stanford type A and Stanford type B. And this is more important for us to decide the treatment. If it is Stanford type A beta, you can see that the tear is not only seen in the ascending, but it is even extending up to the descending aorta. So when the tear is involving the ascending plus the descending aorta, we call it as a case of Stanford type A. Second, we can also say the Stanford type A if there is involvement of ascending aorta only. So do remember, Stanford type A is usually seen in two conditions. One is ascending plus descending aorta, or second is ascending aorta only beta. Clear? Next, if I talk about the Stanford type B. Now in Stanford type B beta, you can see there is involvement of only and only the descending aorta beta. In Stanford type B, there is involvement of only and only the descending aorta. Hopefully clear. Now if I talk about the definitive treatment, so do remember the definitive treatment in cases of Stanford A and Stanford B is. So I hope all of you are quite aware. First of all, whenever the patient's BP is high, then give IV esmolol. Only if the patient's blood pressure is high, then you can give IV esmolol to manage the blood pressure. Then if it is Stanford A, then go for a surgical repair beta. Then if it is Stanford A, go for a surgical repair. But if it is Stanford B, then the management is nothing else but monitoring or observation, whatever you say. If it is Stanford B, then the management is only monitoring or observation beta. Only if the patient's condition is going to worsen, then you go for a surgical repair. In Stanford type B, only if the patient's condition is going to worsen, then you go for the surgery beta. That is what is important. Next to manage is not only the treatment. Management is an overall approach now how you are going to manage your patient. Management is not only treatment. Management means everything. Diagnosis plus treatment together. Everything together is known as management. Okay? Managing the patient is not only treating the patient. Na? That is what is important. So that is a common misconception that a lot of students have. The next one is a very easy and a Sarkari question repeated in the FMGE exam. I hope all of you are quite aware. Here they are saying, what should be the treatment of the condition beta that is given in the below image. Now here, this is a Sarkari bacha which comes in the examination beta who is having a fluctuant swelling on the lateral canthus of eye. And this child who is having fluctuant swelling on the lateral canthus of eye is a provisional diagnosis of which case? Let me know in the chat box. What is the provisional diagnosis of this case that has shown in the that I've shown in the picture? So we know this is a classical case of nothing else but a dermoid cyst. Very good. This is a classical case of a dermoid cyst that you are able to see. And if I talk about a dermoid cyst, it is nothing else but beta collection of the epithelial elements. That is what is known as the dermoid cyst. And here the patient will come to you with a complaint of a fluctuant swelling, and the most common site which is there, as you are able to see, it is nothing else but the lateral canthus of eye. The most common site is also the lateral canthus of eye. Do remember, but this fluctuant swelling is not going to have any kind of punctum. It is not going to have any whitish discharge beta. So no punctum and no discharge is usually seen if the patient is actually having a dermoid cyst beta. And yes, all of you are right. The treatment is directly option A, that is a surgical excision beta. So surgical excision or surgical removal is the best treatment for dermoid cyst. If it is an abscess, then we go for incision and drainage. Cryotherapy or cryosurgery is usually done for warts beta. You might have heard warts or condyloma acuminata like conditions. Over there we go for cryosurgery or cryotherapy. Needle aspiration is again done in cases of cyst or in cases of abscess beta. So cyst or abscess may we go for a needle aspiration. Clear? Next, if this condition comes, here you are able to see beta, the patient is having fluctuant swelling, but that is seen on the scrotum of the patient. So they'll say the patient had a fluctuant swelling on the scrotum, and along with that, you are able to see there is going to be punctum also visible. Punctum is a small opening that is visible on the swelling beta, and along with that, there is a whitish discharge coming out of the swelling. So whenever they say there is a punctum, along with there is a whitish discharge coming out of the swelling beta. So I hope all of you are quite aware. What is the condition then? Fluctuant swelling along with punctum, along with whitish discharge, mainly seen in the scalp or the scrotum beta. Mainly seen in the scalp or the scrotum. Okay? So that is what is important. Beta, whatever doubts you are having completely apart from the topic that we are discussing, please you can reach out to me personally, and I've always cleared the doubts, but not in the session. I don't want to make the session lengthier just because of all the doubts you're having. For doubts, you can reach out to me personally and you will definitely get an answer always. Clear? You can reach out to me on Telegram or any platform that you have. Clear? So do remember, it is a classical diagnosis of nothing else but sebaceous cyst. It is a classical diagnosis of sebaceous cyst, and treatment for a case of sebaceous cyst is nothing else but again a surgical excision or a surgical removal. Treatment of sebaceous cyst is again a surgical excision or a surgical removal to be done beta. That is what is to remember this. Clear? Next, if I talk about is this classical presentation, you can see there is a fluctuant swelling in the floor of mouth, and this fluctuant swelling which is seen in the floor of mouth, which can cause sometimes a discomfort or a dysphagia, is a classical presentation of ranula. So we all know beta, ranula is seen over here. Please tell me what is the best treatment for ranula. What is the best treatment for ranula till the time I am telling ranula. So do remember beta, ranula we all know, it is basically a mucus extravasation cyst. That means whenever there is excess mucus collected in the floor of mouth beta, you can see a mucus extravasation cyst beta in the floor of mouth. And this mucus extravasation cyst in the floor of mouth is classically known as ranula. That happens due to the rupture of the sublingual gland. Yes, if the sublingual gland ruptures, all the mucus leaks and collects in the floor of mouth, forming a ranula. We know in cases of ranula, when you do the trans-elimination test, that trans-elimination test will be brilliantly positive. That means the whole swelling glows with light beta. Okay, when you try to flash the light on the swelling. So the trans-elimination test is brilliantly positive in a patient of ranula. That is what is important to be remembered. Hopefully clear. That is what is important. Okay, if they ask you what is the best treatment for a case of ranula, so do remember the best treatment for a case of ranula is surgical excision beta. Yes. Okay, marsupialization can be done, but even after marsupialization beta, we see few cases of recurrence. So essentially the best treatment for the ranula is nothing else but surgical excision. And we don't only have to do a surgical excision of ranula. That is, we don't only have to do a surgical excision of cyst, but along with that, we have to do a surgical excision of the sublingual gland as well. You also need to do a surgical excision of the sublingual gland. Hopefully clear. So that is what is important. So surgical excision of the cyst and the sublingual gland. Now a question that comes commonly in the FMGE exam. Which is the most common nerve injured bache in the ranula surgery? Whenever you do a surgery in the floor of mouth beta, which is the most common nerve injured? Let me know in the chat box. Yes, the brilliantly transillumination swellings that we have are also cystic hygroma, hydrocele, meningocele and ranula beta. Shabash, very good. Not always beta, not always. Sometimes it may increase the risk, but not always. Yes, it is the lingual nerve, not facial, not anything else. Though do remember, the most common nerve injury that is seen in cases of ranula surgery or in any surgery that we do in floor of mouth is basically called as a lingual nerve beta. The most common nerve injured in a case of ranula surgery is nothing else but the lingual nerve injury, which will cause loss of general sensations in the anterior two-third of tongue. That will cause loss of general sensations in the anterior two-third of the tongue beta. Hopefully clear to all of you now. So next important is a question, that is question number 9. It says we are having a 65-year-old woman who presents to us with complaints of a large 5 centimeter mass beta inside her right breast. On physical examination, there is an overlying ulceration of the skin and the concern for fixation of the underlying pectoralis muscle as well. So underlying pectoralis muscle which is there, that has also got fixed over here. She is noted to have several enlarged and matted axillary lymph nodes beta. And core biopsy reveals it is a ER negative, PR negative and even a HER2 negative, that is triple negative, invasive ductal carcinoma of the breast. After staging scans, they demonstrate there is no evidence of distant metastasis. So no evidence of distant mets, they have said. Her management should begin with, the management of the patient should begin with which among the following they are asking you beta. Clear? So that is important. I have told you it might increase, not always. Next important, the provisional diagnosis of this case which is there beta. We know it is definitely a case of a, not provisional, but the confirmed diagnosis has been made, and that diagnosis is nothing else but IDC or an invasive ductal carcinoma of the breast beta. Right? It is nothing else but a case of breast cancer and it is an invasive ductal carcinoma of the breast. Now, when I talk about invasive ductal carcinoma of the breast, do remember we have to do a staging. Now, for staging, they have said that the mass is usually 5 centimeter and there is overlying ulceration of the skin beta which is seen. Fixation of the underlying pectoralis muscle is there. Okay? There are several enlarged and matted axillary lymph nodes beta, but there is no evidence of distant metastasis. Okay? So this is the question that they have asked. Now, please tell me the staging. Thank you so much, beta. Means a lot. Shatija, thank you. So, do remember the stage. If I talk about bache, the stage is nothing else but here. You have to go for the staging. Please tell me the stage. I'll tell you the stages. You will tell me the stage of the question. So, we know T1 is nothing else but when the size of the cancer is less than equal to 2 centimeter. T2 is when the size of cancer is less than 2 centimeter. Sorry, more than 2 centimeter but less than equal to 5 centimeter. To 2 to 5 centimeter is T2. T3 is when the size of cancer is more than 5 centimeter. T3 is when the size of cancer is more than 5 centimeter. We all know T4A is involvement of chest wall beta. So whenever there is chest wall involvement, like involvement of ribs, involvement of intercostal muscles or involvement of serratus anterior muscle. T4B is involvement of skin, that is ulceration of skin, satellite nodules or pudi orange involving less than 1/3 surface area beta. Next is T4C, that is T4A plus T4B, that is involvement of chest wall as well as skin. And T4D is nothing else but the inflammatory breast cancer beta. T4D is nothing else but inflammatory breast cancer. So now please tell me first of all, what is going to be the T stage of the patient? Yes, very good. So the T stage of the patient, if they ask you, answer is going to be T4B beta. Why? Reason, yes, the size of mass was 5 centimeter beta, but it is not T2. Reason, they have also mentioned there is ulceration of skin. As soon as they mention ulceration of skin beta, we know that is suggestive of skin involvement. And as there was a skin involvement, we know the T staging has to be T4B beta. Next, if I talk about end staging, so do remember if I talk about the end stage, which is, so end stage is nothing else but N2A. Reason is, we all know, see, involvement of axillary lymph nodes which are mobile is N1. Involvement of axillary lymph nodes which are fixed or matted is N2A. Involvement of only the internal mammary lymph nodes is N2B. Involvement of supraclavicular lymph nodes is N3A. Involvement of both axillary plus internal mammary lymph nodes is N3B. And involvement of only the supraclavicular lymph nodes is N3C. So N3A was infraclavicular, N3C is supraclavicular beta. Hopefully clear. So do remember it is N2A. The only reason being they have said axillary lymph nodes are involved, but they are matted. That means they are stuck to each other. Fixed or matted axillary lymph nodes will be N2A stage. And last important is M0, because they did not say there is any kind of distant metastasis. If this is the stage beta, we know whenever it is usually the stage T4B N2A, we know it comes under the stage nothing else but beta, the stage 3B. Right? It comes under the stage 3B. That is what is important. And we know whenever it is a stage 3A, stage 3B or a stage 3C, that means we have to consider it as a locally advanced breast cancer. And in cases of locally advanced breast cancer beta, the treatment is nothing else but you have to start the management by neoadjuvant chemotherapy. Why? Because in locally advanced breast cancer beta, the size of the cancer is very large. Therefore, first of all, you try to decrease the size of cancer or you try to downstage the cancer by giving a neoadjuvant chemotherapy before surgery. Once the size of the cancer is decreased, then you perform a MRM, that is a modified radical mastectomy. That is removal of the breast tissue along with the level 1, 2 and 3 axillary lymph nodes beta. That also has to be done. That is MRM or modified radical mastectomy. And followed by the surgery, give radiotherapy to the patient beta just to decrease the risk of recurrence. That is basically the management in a case of a stage 3B or a locally advanced breast cancer, right? So here obviously they have asked that the management of the patient should begin with, obviously as it is a locally advanced breast cancer and as the size of the cancer is large, the first step is to downstage the cancer or to decrease the size of cancer. And to do that, we have to start the management by neoadjuvant chemotherapy beta. That is what is important to be remembered. Hopefully clear. Mastectomy with axillary clearance, yes, mastectomy with axillary clearance is definitely done. That is modified radical mastectomy. But that is done after giving the chemotherapy or after downstaging of the cancer. Next, radiation therapy beta. Radiation therapy is given even after surgery. At last, you have to give the radiation therapy beta because radiation therapy is only given to prevent the recurrence of the cancer. Aromatase inhibitors are the hormonal therapy beta. Aromatase inhibitors are hormonal therapy. So in premenopausal females or young females, the hormonal therapy of choice are some like tamoxifen. And in postmenopausal females or older females, the hormonal therapy of choice is basically the aromatase inhibitors like letrozole or anastrozole beta. So, but we know hormonal therapy is only possible if they would have said beta it is ERPR positive breast cancer. If it is ERPR negative breast cancer beta, hormonal therapy is not possible only. Clear? So that is what is important. Hopefully clear to all of you. Sure. Next is question number 10 now. Just a minute. Hopefully clear. Question 10 says, we are having a young patient beta who was diagnosed as a case of acute cholecystitis and he was a known case of gallstones beta. The patient was managed conservatively. As the patient was having acute cholecystitis, we did not go for an immediate surgery because of risk of adhesions. We managed the patient conservatively. And then after 6 weeks, the patient was planned for an interval cholecystectomy. We all know whenever there is a inflammation or adhesions, we don't go for an immediate surgery. We go for an interval surgery after 6 weeks. So the patient was planned for interval cholecystectomy. After 6 weeks, the patient has undergone a laparoscopic cholecystectomy now. He started developing pain in the right hypochondrium along with fever beta. Ultrasound was done and that reveals there is a 5 by 4 centimeter of fluid collection under the liver. That means in the subhepatic space, there is some fluid collection after the lap chole surgery. What shall be done next in this scenario is the question. Very good. Yes. So the diagnosis in this condition is what? After a laparoscopic cholecystectomy, The patient is coming to us with pain in the right hypochondrium along with fever. And when we did an ultrasound beta, it shows there is a 5 by 4 centimeter of fluid collection. So a fluid collection after a cholecystectomy can be due to a bile duct injury or due to bile leakage beta, right? So this is nothing else but a case of post-operative bile duct injury. Yes. So after the surgery beta, it was diagnosed the patient was having a bile duct injury. So it is nothing else but a case of a post-op bile duct injury, and we know due to this post-operative bile duct injury, the patient is going to have a bile leakage. And as there is going to be a bile leak beta, all that bile is collecting below the liver, and that leads to a condition known as bilioma. All that bile leakage leads to collection below the liver. That is classically known as nothing else but bilioma beta. That is what is important. And we know whenever a patient comes to us with bile leakage or with a bilioma, what has to be done in this scenario now? Do you remember first point beta? We know as there is a bile leakage of bilioma, we are suspecting. Okay. Therefore, the first step has to be an ultrasound abdomen itself. Reason? You want to see whether there is any kind of fluid collection or not. We are not sure whether it is bilioma or not. So first do an ultrasound abdomen beta and confirm whether a bilioma is present or fluid collection is present or not. Once you have confirmed, yes, bilioma or bile leakage is there, then you have to insert which catheter? Then you have to insert the pigtail catheter beta and do a drainage of all the bile collection or all the bilioma. So then go for a pigtail catheter insertion beta and a drainage. Pigtail catheter insertion and drainage has to be done. Okay? And after this, then definitely once you have drained all the bilioma, then you will like to investigate beta. Investigation can be done. That means you want to see where is the bile duct injury, how big is the bile duct injury and everything. To see that, the investigation of choice for bile duct injury is MRCP, that is magnetic resonance cholangiopancreatography. But if the investigation of choice for MRCP does not help, you go for a gold standard investigation, and that is ERCP, that is endoscopic retrograde cholangiopancreatography. And by the MRCP or the ERCP beta, you will confirm the diagnosis of the bile duct injury, you will confirm the site of the bile duct injury. And once you have confirmed everything, then you will go for treatment. And treatment completely depends on whether the patient is presented to you early or late. If the patient is presented to you within 48 hours of surgery, then the infection or inflammation will be less. And as the infection or the inflammation will be less beta, therefore, we'll take the patient back to the OT and we'll go for a re-exploration and repair. Take the patient back in the operation theater beta and go for re-exploration and repair of that bile duct injury. But if the patient is presented to me after 48 hours beta, that means if the patient is presented to me late, then the risk of infection or inflammation will be more, or the patient might come to me in sepsis. In this condition, I don't go for a surgery then. In this condition, we just go for a temporary management, and that is an ERCP with stenting beta. In this condition, we have to put a stent beta by performing an ERCP. At the site of leak, just perform a stenting so that the bile will flow via the stent and it is not going to leak out inside the abdominal or the peritoneal cavity. Samjhe baat? That is what is important. So this is going to be the proper scenario or a proper stepwise protocol. How to manage a case of post-operative bile duct injury or how to manage a case of bile leak after a case of cholecystectomy beta. That is what is important. Hopefully clear. In the same scenario you have to go. Clear? Now here they have said beta. It was a case of bile duct injury because after lap chole, the patient came to us in fever and right hypochondrium pain. So therefore, the next step was ultrasound abdomen. In the question, they are saying ultrasound abdomen was done and it reveals basically there is a fluid collection of around 5 by 4 centimeter. So we know the next step has to be nothing else but insert a pigtail catheter and do the drainage of all the bile collection. So they have asked you that what shall be done next. Okay, what shall be done next? So answer has to be nothing else but option D, that is pigtail catheter insertion and drainage of the fluid which is collected. Once that is done, then you can go for option C, that is MRCP, to see the bile duct injury. Okay, and then you can go for a ERCP with stenting. Anastomosis over a T-tube is done in cases of the repair. So whenever we do a repair of the bile duct injury, here you can definitely go for anastomosis with the T-tube beta. And this is nothing else but this is how the bile leak or the bilioma is going to be seen on the CT scan beta if you do it. ठीक है, चलो. Next is question number 11 beta, and that question clearly states that we are having a young female and she was diagnosed with migraine beta and she has been started on medications for a symptomatic relief. Now we know migraine is nothing else but headache, and the medication started for migraine would be NSAIDs, right? We know for symptomatic relief of migraine or symptomatic relief of headache, we can start the painkillers or the analgesics like NSAIDs beta, that is non-steroidal anti-inflammatory drugs, usually naproxen. Now the patient was brought to the emergency and the patient is having a sudden onset severe epigastric pain along with dyspepsia like nausea, vomiting, bloating, and per abdominal examination reveals there is guarding along with a board-like rigidity. What is the most likely diagnosis of the case? And the X-ray is also given definitely beta. Okay, I'll discuss it in a question beta. ERCP and MRCP differences. Don't worry, there's a question further. Very good. So we know as she was a case of migraine beta and she was started on a drug or she was started on medications for symptomatic relief. Matlab, she was actually started on NSAIDs for the symptomatic relief beta, non-steroidal anti-inflammatory drugs. And we all know that NSAIDs are basically known to increase the risk of erosive gastritis beta, right? We all know that NSAIDs is basically known to cause erosive gastritis. Due to erosive gastritis, it can lead to formation of ulcers. And ultimately, beta, these ulcers which are there, those are going to cause a perforation. Very good. These ulcers will ultimately lead to perforation of the stomach or perforation of the bowel beta. Very good, all of you. Yes. So that is what is important. So yes, it's very basic. So these basic questions also come in the FMG exam. FMG exam is not always about the difficult questions beta. Do remember that. Clear about? And these basic questions are the ones where you have to mark the answers right. But still people do a mistake, still people do blunders. And that is not intentional, but due to the anxiety of the examination. And this is just to tell you that it is the anxiety of the exam that you have to manage properly so that you don't mark such easy questions wrong. Clear? So that is what is important. So if I talk about the condition is having epigastric pain along with dyspepsia, along with guarding and rigidity. We all know that guarding and board-like rigidity are the classical signs of nothing else but peritonitis beta. We know due to perforation, the patient is going to develop two problems beta. One, definitely, the patient is going to have pneumoperitoneum. Okay, the patient is going to have pneumoperitoneum. That is nothing else but the air or gas inside the peritoneal cavity beta. Okay, there is going to be an air or gas inside the peritoneal cavity. And second, the patient will develop peritonitis. And due to peritonitis, the patient is having sudden and a severe abdominal pain along with guarding and board-like rigidity. So these are the signs of peritonitis that has to be remembered. And due to pneumoperitoneum, you are able to see a classical sign on X-ray abdo, and that is this one over here. That is nothing else but gas under diaphragm beta. That is a classical picture of gas under diaphragm, also called as the cupula sign, also known as the mustache sign. You are able to see the classical gas under diaphragm beta, also called as the cupula sign, also known as the mustache sign. Hopefully clear. So that is what is important. And as soon as they say gas under diaphragm, we know it is definitely a case of pneumoperitoneum. That means it is definitely a case of option C. That is nothing else but hollow viscous perforation beta. That has to be remembered. Now, do remember, in this condition, what should be the treatment? So again, X-ray would be my first line investigation in cases of perforation. Then I can go for a CECT. But before doing a CECT beta, always remember, I have to do a basic resuscitation and I need to stabilize my patient, because a lot of times people of hollow viscous perforation can come to you in shock or they may be hemodynamically unstable. So do a basic resuscitation and manage their ABC beta. After that, if they ask you what is going to be their definitive treatment, so do remember beta, definitive treatment in this patient is nothing else but you have to do an exploratory laparotomy. Definitive treatment is nothing else but you have to do an exploratory laparotomy. Along with that, you have to do a peritoneal lavage. That is, cleaning of the peritoneum has to be done. You have to do a peritoneal lavage. And followed by that, see, if the patient presents to you early beta, then you go for a Graham's omental patch repair. Okay? If the patient presents to you early after a perforation, then you go for a Graham's omental patch repair. But if the patient presents to you late, then you go for a delayed repair. Then you just leave a drain inside the abdomen and then we go for a delayed repair. Then we don't aim for an immediate repair. Okay? So that is what is important to be remembered. Okay? Chalo. Reason is why the Graham's omental patch repair has to be done. Reason is beta, we know. As the bowel is perforated, you have to close the bowel, and to close the bowel, the easiest one is to patch the bowel with the help of omentum, and that is known as Graham's omental patch repair. That was also a PYQ in the FMGE exam. Now, when the patient presents early, we know the infection in the peritoneal cavity will be less, and therefore you can go for an immediate surgery or an immediate repair beta called as Graham's omental patch repair. But if the patient presents to you late, then the infection is going to be more. And if infection is more beta, we don't go for an immediate surgery or an immediate repair or immediate anastomosis. Reason, the tissues are going to be very fragile in infection and therefore they will not be able to hold on the sutures and therefore there will be a high risk of anastomotic leak beta or leakage from the site of repair. Hopefully clear. Thank you so much, Bacho. Thank you so much. My pleasure it is. Clear? So yaad rakhna. Done? So that is the treatment. Now if I talk about option A beta, that is Boerhaave syndrome. We know Boerhaave syndrome is also perforation, but it is an perforation of the esophagus beta. And if there is an esophageal perforation, patient will not have pneumoperitoneum or gas in the peritoneal cavity. Rather, patient will have pneumomediastinum or gas inside the mediastinal cavity beta. So that's the reason option A Boerhaave syndrome or option B pneumomediastinum both are ruled out, because in both these conditions beta, gas under diaphragm or pneumoperitoneum will not be seen. In these conditions, you can see the classical continuous diaphragm sign. Can you see this black line below the heart? And this black line below the heart is called as the continuous diaphragm sign. And do remember, this continuous diaphragm sign is a chest X-ray finding in patients of pneumomediastinum beta. It is a chest X-ray finding in patients of pneumomediastinum that can also be seen if a person is suffering from Boerhaave syndrome, that is esophageal perforation beta. So if there is pneumomediastinum, then this is the chest X-ray finding and not the gas under diaphragm. Hopefully I have made myself clear in both the conditions what will be the chest X-ray finding. Samjhe baat? So do remember basically beta that Boerhaave syndrome or pneumomediastinum mein the patient would not present to us with abdominal pain or epigastric pain. Patient will rather present to us with chest pain beta. Second, the patient will not have any guarding or board-like rigidity. And third, the X-ray will not show gas under diaphragm, rather it will show the continuous diaphragm sign beta. That is a sign of pneumomediastinum. Acute pancreatitis, yes, it can present to us with complaints of severe epigastric pain along with dyspepsia. Okay, guarding and rigidity can be seen in cases of pancreatitis due to peritonitis. Sometimes definitely the patient may develop sepsis, peritonitis like complication, but less likely. So again, guarding and board-like rigidity, not very common in acute pancreatitis always. And gas under diaphragm is never seen in cases of acute pancreatitis. So it was very clear. Clear? Chalo. Next important beta. My pleasure completely. Next is question number 12 bache. Here there is a question which says a 33-year-old patient beta comes to the surgery OPD with complaints of an inguinoscrotal swelling as shown below. They are saying that the swelling is painless completely and examination reveals there is a cough impulse which is present. Swelling is reducible, they are saying beta. The swelling is reducible. The patient was planned for a laparoscopic corrective surgery. Which among the following nerve will be most commonly injured beta during this surgery, they are asking you. Very easy and a direct question beta. Thank you so much, Seema. Means a lot. Oh, chalo. What is the provisional diagnosis in this condition beta? What is the provisional diagnosis? We all know which. Here the patient comes to us with inguinoscrotal swelling and the swelling is painless beta and the cough impulse is also present. So we all know this is most likely a case of a hernia and therefore we see the reducibility. The swelling is also reducible. So it is not an obstructed hernia or not an emergency case of hernia beta, right? So do remember, as the cough impulse is also found and as the swelling is also reducible, it is not an obstructed hernia beta. And we know any condition which presents to you with inguinoscrotal swelling could be a probable diagnosis of inguinal hernia. Now we are not very sure whether it is a direct or indirect inguinal hernia, but more commonly it seems to be an indirect inguinal hernia. Now you'll be like, why? Reason is bache, this patient presented to me basically beta with this kind of a swelling, as you are able to see. There was an inguinoscrotal swelling in this patient. Clear? So that's the reason this is more likely to be a case of a indirect inguinal hernia, because the patient was young, and second important beta, that the swelling was extending up to the scrotal sac. More commonly, the indirect inguinal hernias are the one which extend up to the scrotal sac. Direct can go up to the scrotal sac, but less commonly. Okay? And direct inguinal hernias are more common in the elderly patient beta. Here the patient was young and there was a scrotal extension. So more commonly, I'm thinking about the most common type of hernia overall, called as indirect inguinal hernia, which is lateral to the inferior epigastric vessel beta. Now they have said that the patient is undergoing a laparoscopic corrective surgery, and we know whenever we do a laparoscopic inguinal hernia surgery, in laparoscopic inguinal hernia surgery beta, the most common nerve that is injured is nothing else but the option C, all of you are right, that is called as the lateral cutaneous nerve of thigh. Laparoscopic inguinal hernia surgeries में the most common nerve injured is the lateral cutaneous nerve of thigh beta, and when lateral cutaneous nerve of thigh is injured, there is loss of sensations in the upper lateral aspect of thigh, classically known as meralgia paresthetica or meralgia paresthesia beta. A condition classically known as meralgia paresthetica, also known as meralgia paresthesia. That is the complication beta due to the lateral cutaneous nerve of thigh injury. That has to be kept in mind. No issues with this. Option A basically says ilioinguinal nerve. Do you remember ilioinguinal nerve? Yes, it is the most common nerve injured beta in a inguinal hernia surgery. But which one? In the open inguinal hernia surgery. Yes. So if they would have said the patient has undergone a open inguinal hernia surgery beta, then the most common nerve injured would have been option A, that is the ilioinguinal nerve beta. So laparoscopic surgery, mark lateral cutaneous nerve of thigh. Open surgery, mark ilioinguinal nerve. Hopefully clear to all of you now. No doubts at all? Clear. Iliohypogastric nerve beta is the most common nerve entrapped below the mesh. If you are doing a mesh repair surgery, or if you are doing a mesh hernioplasty for the hernia, then definitely beta, the most common nerve that gets entrapped below the mesh is the iliohypogastric nerve beta. That is what is important to be remembered. No issues with this? Anybody? Clear? Just remember about the surgeries for inguinal hernia. I hope all of you are quite aware about that though. Do remember, inguinal hernia presents as a painless swelling in the inguinal region or the inguinoscrotal region beta. Usually the cuff impulse and the reducibility has to be checked, and a clinical diagnosis of the hernia has to be confirmed. After that, if I talk about treatment, we know if it is a case of congenital hernia is going to be present in a child beta. So if it is a case of congenital hernia, you don't do any treatment up to 3 years of age, because majority congenital hernias are spontaneously going to resolve. अपने आप ठीक हो जाएंगे up to 3 years of age. In case beta, if the congenital hernia, if it is not going to resolve even after 3 years of age, bache, then we go for a surgery called as an herniotomy surgery. Now what do I mean by herniotomy surgery? Herniotomy means you just have to push back the sac of hernia, but you don't have to close the defect. You will just push back the sac inside, but you are not going to close the defect, because it is a child. As the child will grow, the defect is going to close automatically or on its own bit. Thank you so much, Vijay. So therefore, congenital hernia mein the treatment is going to be herniotomy, and it is only done after 3 years of age, not before 3 years of age beta. Okay, so that is what is important. Next, if I talk about, is nothing else but if they ask you for the open surgeries for inguinal hernia. The open surgery that we do for inguinal hernia beta, okay, if it is a small defect, if it is going to be a small defect beta, then you go for a herniorrhaphy surgery. Okay, then you basically go for the herniorrhaphy surgery. What is herniorrhaphy? When you push back the sac of hernia, and after pushing back the sac of hernia, you close the defect by suturing the layers. When you push back the sac of hernia, then you close the defect by suturing the defect, suturing the layers together. That is herniorrhaphy. And the herniorrhaphy that we basically do for a inguinal hernia beta can be either my Basini's repair or the Shouldice repair. It can be the Basini's repair, Shouldice repair, modified Shouldice repair. But the problem is, Basini's, Shouldice or modified Shouldice repair, as these are herniorrhaphy surgeries beta, there is tension at the suture site, or there is tension at the repair site beta. Okay. Next important, if I talk about, if there are large defects in cases of hernia beta, large defects of inguinal hernia can be closed by hernioplasty surgery. Hernioplasty means closing the defect of hernia by putting a mesh over it. When you are going to close the defect of hernia beta by placing a mesh over it, that is known as hernioplasty surgery. And the most common hernioplasty that we do for a case of inguinal hernia is classically known as the Lichtenstein's repair beta. The most common hernioplasty that we do is basically called as the Lichtenstein's repair. Do you remember hernioplasty surgery are the mesh repair surgeries beta? So here there is no tension at the suture, there is no tension at the repair site beta, or no tension at the surgical site. So therefore the best surgery for large defects in inguinal hernia is always the hernioplasty surgery called as a tension-free Lichtenstein's repair. And the laparoscopic surgery beta could be a TAP surgery or a TEP surgery. Okay, TAP is trans-abdominal pre-peritoneal repair, or TEP is a total extraperitoneal repair. Hopefully clear? Chalo. Next is question number 13. That is a common question from surgery or even medicine. We are having a question number 13 which says a 65-year-old female comes to the OPD complaining of pain and swelling in the calf region, and she also gives history of total arthroplasty beta, or a total hip replacement basically, okay, few days ago. Examination reveals tenderness in the calf region. What shall be the next step in this case? What is your provisional diagnosis of this case? Please tell me beta. What is the provisional diagnosis of this condition? Please tell me in the chat box. I hope all of you are quite aware. In this condition, the provisional diagnosis that you are thinking about is nothing else but anybody. So the patient has undergone a major surgery beta, like a total arthroplasty or a total hip replacement few days ago beta. So obviously after such a major surgery, the patient would be advised prolonged bed rest beta, and that will cause prolonged immobilization. And due to prolonged immobilization beta, definitely there will be stasis of blood in the deep veins of the leg beta, which will increase the risk of, very good all of you, DVT, that is deep venous thrombosis. We all know the most common cause for DVT or deep venous thrombosis is nothing else but a prolonged immobilization. That is what is important. And therefore they can mention a history of a prolonged, therefore they can give you a history of a major surgery or a spine fracture, lower limb fracture, or a long flight, due to which they are trying to tell you that a patient had a prolonged bed rest or a prolonged immobilization. And due to that, we know in DVT the most common veins affected are going to be the soleal veins, and these soleal veins are usually found in the calf region beta. These soleal veins are usually found in the calf region. That's the reason in patients of DVT, you will definitely get a sign like pain and swelling in the calf region. So patient of DVT beta, they present to you with pain, swelling, tenderness in the calf region. Matlab the patient is already having basically beta a case of nothing else but DVT. So you have to do a diagnosis and then start the treatment beta. That is what is important. Okay? That is what is important beta. Clear? So here if I talk about in this condition, then please remember, as I'm thinking about DVT, the first step is I will go for screening of DVT. We know screening test of DVT or screening test for any thromboembolism condition are D-dimers beta. So if I want to do a screening for DVT, or if I want to do screening for a case of thromboembolism, the best test is D-dimers. But investigation of choice to confirm the diagnosis of DVT will be duplex scan or a color Doppler. Investigation of choice to confirm the diagnosis of DVT is duplex scan or color Doppler, because it is a peripheral vessel or lower limb vessels beta. And once you have confirmed the diagnosis, then the treatment is low molecular weight heparin along with oral warfarin beta. So you will start the injection of low molecular weight heparin and oral warfarin for anticoagulation of the patient. After 5 days, then you will stop giving low molecular weight heparin. You will only continue the patient on oral warfarin only beta. You will only continue the patient on oral warfarin. Do remember. Now please tell me what should be your next step in this condition then. Very good. All of you are right. The next step which is there in this condition has to be nothing else but option. I said all of you are right and then you are making a mistake. So the answer has to be option D beta. Send a blood sample of the patient to check the levels of D dimers. If the D dimers are high beta, then my suspicion for DVT will increase, or suspicion for DVT will become more stronger. Okay, मतलब मेरा doubt और ज़्यादा पक्का हो जाएगा. And then if the D dimers are high, I can definitely go for duplex scan to confirm my diagnosis without color Doppler to confirm my diagnosis, and then I can start the patient on treatment. This is a case where patient was already having a DVT. If the person is already having DVT, why are we talking about a prophylaxis? Prophylaxis is done when condition has not developed. If the patient was not having DVT, if they would have said that the person has undergone total arthroplasty, now what should be the advice given by the doctor or the surgeon to the patient to prevent the risk of DVT? Then the answer would have been option C, that is apply pneumatic compression stockings beta. So pneumatic compression stockings bache, they are used for prophylaxis or prevention of DVT, not for treatment. They are not used once DVT is developed, because if you use these pneumatic compression stockings beta, once the patient has developed DVT, what will happen? Due to that compression by the stockings, the clot or the thrombus will get dislodged from the deep veins of the leg, will go all the way up to the pulmonary blood vessels, causing a pulmonary embolism. Clear? So never use pneumatic compression stockings when the patient is already having DVT. Okay, pneumatic compression stockings are used for the prevention on the prophylaxis of DVT beta. Clear? So that is what is important to be remembered. Hopefully clear about that is what is important. Screening is done first, followed by the investigation of choice, followed by the gold standard investigation. Yeah, screening is done, followed by that you can do the investigation of choice. If investigation of choice is not able to confirm the diagnosis, then you go for gold standard investigation. Not necessary that you have to go do a gold standard investigation in each and every case. If investigation of choice is able to confirm the diagnosis, you don't need to perform the gold standard investigation beta. Hopefully clear, that is important. If they would have mentioned same question, but if they have mentioned patient is having chest pain and dyspnea, then I would have thought it is a case of pulmonary embolism. Okay? Still my answer remains the same. Okay? Do remember beta, instead of writing pain and swelling in calf, if they would have written that the patient was having chest pain and dyspnea, then my provisional diagnosis would have been nothing else but pulmonary embolism, which is again due to DVT only. Clear? Fat embolism syndrome is not due to arthroplasty. Fat embolism syndrome is basically due to a long bone fracture or due to polytrauma case beta. And in fat embolism, along with chest pain, there will be respiratory distress, there is going to be CNS symptoms, and there will be petechiae also. So CNS symptoms, petechiae, respiratory symptoms, if these features are there, then you think about fat embolism syndrome, not after a prolonged immobilization. Clear about? Question number 14 says, a patient has been brought to the casualty beta with a complaint of stab wound in the abdomen. We know stab wound means there is a penetrating trauma in the patient's abdomen beta, and there was a bruising which was noted on the abdomen of the patient along with the chest wall. So there was a bruising on the abdomen as well as the chest wall beta. So it is a case of an abdominal trauma as well as the thoracic trauma. On examination, the patient's blood pressure is found out to be 114 by 70 millimeters of mercury, that is normal. Pulse rate is 90 beats per minute, again normal. Respiratory rate is 24 breaths per minute, slightly high, so there is tachypnea or fast breathing, you can say. E-fast was done, that is extended fast was done. Why? As the person was having abdominal plus thoracic trauma, we have to do first investigation as E-fast or an extended fast, where you do a rapid ultrasound to check for any blood collection in the abdominal cavity and the thoracic cavity. Now they are saying beta, in the E-fast you are able to see fluid collection inside the Morrison's pouch beta. So if there is fluid collection on the E-fast, that is more likely to be a blood collection beta, which is seen in the Morrison's pouch or the hepatorenal pouch. What is the definitive management they are asking you in this scenario? Clear? Now if I talk about a case of penetrating abdominal trauma, why I am saying penetrating? Because the patient had a stab wound in the abdomen. Someone has stabbed the patient in the abdomen beta with a sharp weapon or with a knife. Clear? So in this condition, definitely beta, we know it is a classical case of penetrating abdominal trauma. It is nothing else but a classical case of penetrating abdominal trauma. I hope all of you are quite aware that the first line investigation in abdominal trauma is always a fast. And the best investigation in abdominal trauma is a CECT abdomen. But the condition is CECT abdomen is only done if the person is hemodynamically stable. If the person is hemodynamically unstable, you don't do a CECT abdomen. Clear? Now here if I talk about beta, penetrating abdominal trauma if the patient is hemodynamically stable or unstable. Understand? Let's say when the person is hemodynamically unstable, that means the patient comes to us in shock. Then we directly go for a surgery beta, that is known as an exploratory laparotomy. Why? Reason, if there is a penetrating abdominal trauma and the patient is also unstable, that means definitely there is an internal injury and there is some bleeding happening. So you don't need to do a fast, you don't need to do a e-fast, you don't need to do a CCD, nothing. You directly go for a surgery known as an exploratory laparotomy beta. Second important is if the patient is hemodynamically stable beta. Now if the patient is hemodynamically stable, then my first line investigation is a fast or a e-fast. When I do a fast or a e-fast beta, there are two possibilities. Either the fast comes out to be positive or negative beta. Either the fast is positive or negative. If my fast is negative, I'll just go for observation in the patient. If the fast is negative, it does not show any blood collection and my patient is also hemodynamically stable, just observe the patient beta. But in case if the fast is positive, if the fast shows blood collection, then you go for a better investigation beta called as the CECT abdomen. Okay, then you go for a better investigation bache called as CECT abdomen beta. Okay, and why? Because my patient is hemodynamically stable, I can definitely do a CECT abdomen. Koi issue nahi hai. Clear? Now, once you do a CECT abdomen, in a case of penetrating abdominal trauma, your aim is to look out for the peritoneal breach. Yes, you have to see beta if a peritoneal breach is present or not. मतलब peritoneum injured है या नहीं है. Reason, because depending on the peritoneal breach, I will decide beta whether my treatment should be a surgery or my treatment should be a local wound exploration and suturing. If they say peritoneal breach is present, peritoneal breach is absent beta. If they say that peritoneal breach is absent, that means the injury is very superficial, peritoneum is not breached, so there is no risk of peritonitis. I can just go for a local wound exploration and suturing. अगर peritoneal breach नहीं है मतलब peritonitis का risk नहीं है. So in this condition, you can just go for a local wound exploration and suturing in the patient beta. But in case if they say that peritoneal breach is present, in case if they say peritoneal breach is present, there is a high risk of peritonitis, so it's better to go for a surgery known as an exploratory laparotomy. तो abdomen open करना ही पड़ेगा. If in case peritoneal breach is there and there is a high risk of peritonitis, you have to open the abdomen, you have to go for a exploratory laparotomy surgery. Clear? So that is what is important. No issues with this. So these are the points beta that you have to remember for the management of a case of a penetrating abdominal trauma. Clear? Now here they have saying that the patient had a penetrating abdominal trauma and the patient was hemodynamically stable because they have said that the BP is also normal and the pulse rate is also normal. Okay? So we have to follow this protocol. But now in this protocol they are saying first line investigation is fast. So they have already done the fast and they are saying there is definitely a blood collection which is visible in the Morrison's pouch beta. Okay? So obviously that means the fast is positive. If fast is positive, my next step should be CCD abdomen. But did they ask you the next step as the answer? If next step was the question, my answer would have been definitely CCD abdomen. But they did not ask you next step beta. They basically asked you what is the definitive management or what is the final management. Now final management would be either a local wound exploration or a exploratory laparotomy beta. But that basically depends on CCD, but not in few conditions. There are few conditions basically beta where even without a CCT, you are able to tell what is the definitive management or what has to be the final management. And why? Here can you see from the penetrating wound beta, the bowel is hanging outside. Okay, if the bowel itself is hanging outside bache, that means definitely there is an evisceration. And I've always told you in my classes bache that whenever there is going to be 5 conditions of penetrating abdominal trauma, then you have to always go for a exploratory laparotomy or surgery, irrespective whether the patient is hemodynamically stable or unstable. ऐसी 5 condition जहाँ पे patient हमेशा exploratory laparotomy के लिए दिया जाएगा, does not matter whether the patient is stable or unstable beta. Hopefully clear to all of you now. That is important. What are the 5 conditions I've always told you? 1, evisceration, where the abdominal organs or the internal organs are hanging out from the wound. Second important, impaled object, when the weapon or the object is still inside the patient's abdominal wall. Third, peritonitis beta. Third is peritonitis. Fourth important is nothing else but bleeding from natural orifices or bleeding from natural openings like nose, mouth and anal canal se there is bleeding. And fifth, there is going to be gunshot injury or gunshot wound. So evisceration, impaled object, peritonitis, bleeding from natural orifices and impaled object and gunshot wound. We always go for a surgery or an exploratory laparotomy in this condition beta, because obviously evisceration, if the organ is hanging out, you have to do an exploratory laparotomy and you have to push back the organ, close the peritoneum properly beta. So if there is evisceration, we definitely know beta peritoneal breach has to be there, because without a peritoneal breach it is not possible only that a evisceration can happen. Okay, as evisceration was there, we knew that a peritoneal breach is present even without a CCD abdomen, and therefore the treatment has to be nothing else but beta option C, right? Exploratory laparotomy, also called as surgical exploration beta. Clear है बात? Next step अगर पूछा होता, then my answer would have been definitely the CCD abdomen. Next best step, if they would have asked me, my answer would have been option A, that is CCD abdomen beta. Observation and monitoring can never be done in this scenario, because here there is evisceration or there is a peritoneal breach which is present beta. Local wound exploration and suturing would have been done if evisceration was not there or if the peritoneal breach was not present. Hopefully clear है सबको? So answer has to be option C. All of you are right. Question number 15, if I talk about beta. Question number 15 is 56-year-old was brought to you with complaints like intermittent pain, fever and jaundice. I hope all of you are quite aware. What is this classical triad known as? Intermittent pain, intermittent fever and intermittent jaundice. It is known as which triad and it is seen in which condition? Let me know in the chat box. The patient is having a classical triad of intermittent pain, fever and jaundice, and history taking reveals the patient had pale stools and dark urine since the last few days. हमें पता है pale stools and dark urine are always the feature of an obstructive jaundice or a post-hepatic jaundice. Yes. Reason, whenever there is obstructive or a post-hepatic jaundice beta, bile cannot go in the intestine and therefore the patient has pale stools or clay colored stools, and excess bile pigments will therefore get excreted out from the urine, causing a dark urine. Now ultrasound and CCD abdomen confirms both of them were done. Ultrasound as well as CCD abdomen is done, which confirmed a surgically obstructed jaundice. I've already told you, pale stools and dark urine is definitely suggestive of an obstructed jaundice. That means obstruction in the bile duct, and due to obstruction there were dilated intrahepatic biliary radicals beta. Due to obstruction in the bile duct, there was dilatation of the intrahepatic biliary radicals. They are asking you which among the following will be the most useful investigation beta to localize the cause. Which among the following is the most useful investigation only to localize the cause? Understand, I have not asked you which is the most useful investigation to localize and treat the cause. I am just asking you for localizing the cause. याद रखना और फिर आंसर करना. Very good. All of you are quite aware. Charcot's triad it is. The classical pain, fever and jaundice is known as Charcot's triad, and we all know Charcot's triad is usually seen in cases of cholangitis beta. The classical pain, fever and jaundice is known as Charcot's triad, and that is seen in cholangitis. Cholangitis is infection or inflammation of the bile duct beta. And why there is infection or inflammation of bile duct? Basically due to an obstructed jaundice, right? As the patient had a obstructed jaundice beta or a post-hepatic jaundice. So due to an obstructive jaundice or a post-hepatic jaundice beta, the patient is going to have cholangitis because the bile was not able to drain. So ultimately the bile ducts got infected. Hopefully clear, and that was seen on ultrasound also or CCT also beta. Clear about? Now in this condition we all know bile duct obstruction agar hai. Obstructive jaundice means bile duct obstruction. And we know for bile duct you have to remember one thing. The investigation of choice for a case of bile duct obstruction beta is always nothing else but the MRCP. Yes, investigation of choice for a case of bile duct pathology is nothing else but MRCP, that is a magnetic resonance cholangiopancreatography beta. So magnetic resonance cholangiopancreatography or MRCP is a T2 weighted MR of the bile duct, where the bile duct and the pancreatic duct will appear white and you can easily confirm the problem beta. So here you can see this is C1 is the main pancreatic duct beta that you can see. This B1 is the common bile duct that you can see. This is the cystic duct. The A1 is the gallbladder. This is the common hepatic duct. These are the right and the left hepatic duct beta. So this is the MRCP picture that can confirm any obstruction in the bile duct beta. And mostly the cause for obstruction is nothing else but stones inside the bile duct or adhesions inside the bile duct beta. Next is this, that is a gold standard investigation. If MRCP fails to make a diagnosis, then the gold standard investigation is ERCP, that is endoscopic retrograde cholangiopancreatography. And we know ERCP which is there, it is not only diagnostic in nature, but it is also therapeutic in nature beta. That means it will not only help you to diagnose the cause of obstruction, it will also help you to treat the cause of obstruction. Like if it is a stone, then it will help you to remove the CBD stone as well beta. That is important. ERCP mein we always know that the endoscope is going to be visible. These are the right and the left hepatic duct which combine to form the common hepatic duct, where there is basically the main pancreatic duct. Okay, that is important. Clear? So that is important. Shabash. HIDA is the most sensitive investigation beta, but HIDA is not very commonly done in clinical practice. Better is we use the MRCP or ERCPs in the condition beta. Okay? HIDA can be done for conditions like biliary atresia or in some cases like acute cholecystitis, but not for CBD stones usually, or not for CBD obstruction commonly beta. Okay? So we can go for the cheaper investigations like MRCP or ERCP as compared to HIDA. Okay? So do remember here, if they ask you what is the most useful investigation to localize the cause. So we know MRCP, and MRCP is nothing else but it is a T2 weighted MRI. So therefore the answer has to be option B for this question beta. So we know T2 weighted MRI or MRCP is the investigation of choice, and it can definitely help me to localize the cause. Yes, it will not help me in treatment, but it will at least help me in diagnosis. If they would have asked you which is the best investigation to localize as well as treat the cause, then definitely beta, my answer would have been option D, that is ERCP. Localize and treat the cause if they would have asked me, then my answer would have been option D, that is ERCP beta. HIDA scan, I've told you, it is the most sensitive investigation for bile duct, but not very common in practice beta. And especially for the bile duct obstruction or bile duct stone, we don't commonly do a HIDA scan. That is a hepatic immunodiacetic acid scan. Endoscopic ultrasound can be done for a CBD stone or a CBD obstruction, especially whenever there are CBD microliths and that is very small stones inside the common bile duct, and if the MRCP fails to make a diagnosis, then you can go for endoscopic ultrasound in only those conditions beta. And treatment, so we all know, if there is a stone, you have to do a ERCP with sphincterotomy and a stone removal, and the stone removal is done with the help of the special Dormia basket beta. Stone removal is done with the help of special Dormia basket. Clear? Next is question number 16. Answer the question now. You can see a question that says a young patient has been brought to the casualty with complaints of severe headache beta. His blood pressure is found out to be 180 by 100 millimeters of mercury, very high. On examination, nuchal rigidity, that is neck stiffness, was elicited. NCCT head has been given. I forgot to add a NCCT head, but the NCCT head basically beta was having a hyperdensity in the ventricles, that is whitish appearance in the ventricles beta. So there is hyperdensity in the ventricles or whitish appearance in the ventricles, and that gives you a very classical appearance called as star of death appearance beta. That gives you a very classical appearance called as the star of death appearance. Okay? That is going to be the NCCT finding. Let's say I've given the NCCT finding in writing, not in image this time. Chalo. Now they are asking you what shall be the next best step in managing the patient's condition beta. Okay, what shall be the next best step? What is your provisional diagnosis, anybody beta? What is the provisional diagnosis? Very good, shabash. So we know whenever a patient comes to us with complaints of severe headache along with nuchal rigidity beta, okay, and NCCT head is showing you the classical hyperdensity in the ventricles or star of death appearance, we know the provisional diagnosis has to be nothing else but SAH, that is subarachnoid hemorrhage beta. Right, it is SAH, also called as a subarachnoid hemorrhage. And if I talk about the case of subarachnoid hemorrhage, so please tell me in this condition then, in cases of subarachnoid hemorrhage beta, okay, in cases of subarachnoid hemorrhage, then please tell me beta, what shall be the next best step in this scenario? What shall be the next best step in this scenario? ठीक है. See, the PYQ has come in a similar manner beta. See, headache and nuchal rigidity is a feature of subarachnoid hemorrhage, and that severe headache is known as thunderclap headache, also called as the worst headache of life. So only headache and nuchal rigidity is seen in subarachnoid hemorrhage. But if they say headache, fever and nuchal rigidity, headache, fever and nuchal rigidity, then it is a diagnosis of meningitis beta. Do remember that. So here, this same question has been asked in a previous year NEET PG examination. But in that PYQ of NEET PG beta, the patient's BP was low. Okay, the patient's BP was not very high. The patient's BP was usually around the normal range itself, around 140, 150 it was. Okay, and therefore, in that question, beta, the answer was option A, that is nothing else but angiography. Why? Because we know here, did they give you any history of trauma? No, they did not give us any history of trauma. That means it is a non-traumatic subarachnoid hemorrhage. And I hope all of you are quite aware. Whenever it is a case of non-traumatic subarachnoid hemorrhage, beta, then definitely the cause is spontaneous rupture of berry aneurysm. If it is a non-traumatic subarachnoid hemorrhage, that means the cause is nothing else but the spontaneous rupture of berry aneurysms, most commonly found inside the anterior communicating artery beta. Okay, the cause is mostly spontaneous rupture of berry aneurysms beta, and most commonly found inside the anterior communicating artery. Hopefully clear to all of you now. So rupture of berry aneurysms is the leading cause in cases of non-traumatic subarachnoid hemorrhage beta. Okay, that has to be kept in mind. And therefore the next step was angiography in that previous year question beta. Why? Because if it is due to berry aneurysm, I want to see the extent of berry aneurysms, the number of berry aneurysms, and depending on all these factors, I will decide whether we should go for a conservative management or we should go for a surgical repair beta. But the problem is definitely beta, here the patient's BP is very high. As the patient's BP is very high beta, I cannot directly go for angiography. As the BP is very high, therefore my answer would be first, I will give option C, that is IV nimodipine beta, which is a calcium channel blocker. And after giving IV nimodipine to my patient, once the blood pressure has normalized, then definitely my next best step has to be angiography itself. And by angiography, we will see how many aneurysms are present, what is the site of aneurysm, what is the extent of aneurysms, okay, everything. And deciding on that, based on that, we will decide whether we should go for the conservative or the surgical management. In case if you decide to go for surgical management beta, then definitely one option is aneurysmal clipping can be done, or an interventional radiologist can also place some endovascular coils beta. The treatment for a non-traumatic subarachnoid hemorrhage due to rupture of berry aneurysms में, the treatment can be either aneurysmal clippings or endovascular coils beta if you have decided for surgical management. If you have decided for conservative management, no active intervention or no surgery to be done. Clear? That is important. Fibrinolytic therapy is rather absolutely contraindicated in patients of subarachnoid hemorrhage. Reason, it is already a case of bleeding beta. If you give fibrinolytic therapy with drugs like streptokinase, altiplase, then the patient will have more bleeding beta. Clear? So that is what is important to prepare. Chalo, hopefully clear to all of you now. Great, done. So these are the various types of intracranial hemorrhages that you are able to see in the picture beta. The first one is a picture of subdural hematoma. Why? Because here we are able to see there is a concavo-convex hyperdensity beta, or a crescent shift hyperdensity is seen in the NCCT head. Here there is blood collection between the dura mater and the arachnoid mater of the patient beta, and it is due to a tear or rupture of the bridging veins or emissary veins. It is due to tear or rupture in the bridging veins or emissary veins. More commonly seen in alcoholic patients or elderly patients or boxers beta. More commonly seen in alcoholic, elderly or boxer patients. That has to be remembered. In subarachnoid hemorrhage, once you confirm the diagnosis of once you confirm the diagnosis by NCCT head, and do remember, if the hematoma is small or if the patient is asymptomatic, we go for a conservative management or a conservative treatment beta. But if the patient is symptomatic or the hematoma is large in size, if the patient is symptomatic or the hematoma is large in size, then we definitely go for a surgery like craniotomy beta. Then we basically go for a surgery like craniotomy. Hopefully clear. Next important, if I talk about nothing else but the epidural hematoma beta. If I talk about epidural hematoma, It is also known as extradural hematoma beta. Here you are able to see a biconvex or a lenticular hyperdensity on the NCCT head. A biconvex or lenticular hyperdensity on the NCCT head. Do remember, it is the blood collection between the dura mater and the skull bone. It is due to the tear or rupture of the MMA or the middle meningeal artery. The extradural hemorrhage happens due to the tear or the rupture of the middle meningeal artery beta. That is what is important. And it is more commonly seen in the adolescent patients or young adults. So usually due to trauma or accidents, you see an extradural hemorrhage in young adults or adolescent patients. In cases of extradural hemorrhage, again, we know beta, the treatment which is there, it depends on the size. If the size of the hematoma or if the volume of the hematoma beta is going to be less than 30 cc, then we know we have to go for a conservative management. If the volume of hematoma is less than 30 cc, we go for a conservative management beta. But if the volume of hematoma is going to be more than 30 cc, volume of hematoma is more than 30 cc, then we go for surgery, preferably craniotomy beta, preferably craniotomy. But if craniotomy cannot be done, then the other option is a burr hole surgery. PYQ. When I have to do a burr hole surgery in a case of extradural hemorrhage, what is the surgical landmark for a burr hole surgery beta? Let me know in the option. What is the surgical landmark for burr hole surgery? Let me know in the option beta. Next important, I've already told you. See, this is the hyperdensity in the ventricles, giving us a very classical star of death appearance. So this is a classical diagnosis of subarachnoid hemorrhage. Subarachnoid hemorrhage is going to be seen beta due to trauma or due to spontaneous rupture of aneurysms, as I've told you beta, and there will be blood collection in the circle of Willis, cisterns and fissures. Okay, it is due to rupture of aneurysms, mainly the anterior communicating artery is ruptured, and it can be associated with the case of PCKD or polycystic kidney disease is going to be the risk factor beta in patients of subarachnoid hemorrhage. And treatment I've already told you. Clear? If it is a non-traumatic subarachnoid hemorrhage, then do a angiography once the blood pressure is normal and decide whether to go for conservative management or surgical management. Surgical management is aneurysmal clipping or endovascular coils. Very good. Pterion is the surgical landmark for a burr hole surgery. So pterion is considered as the surgical landmark beta for a case of burr hole surgery. That is important. Next important is last one, that is intracerebral hemorrhage. Intracerebral hemorrhage which is there beta, it is nothing else but bleeding inside the cerebrum or bleeding inside the brain parenchyma beta, as you are able to see. Okay, most common site is usually the putamen that you are able to see in the NCCT head beta. We know it is associated with hypertensive vasculopathy. Like if the patient is a known hypertensive beta, then there is going to be rupture of the penetrator arteries or rupture of the Charcot's artery beta. That is known to cause an intracerebral hemorrhage or a hemorrhagic stroke. And treatment is nothing else but a calcium channel blocker known as IV nicardipine. So the drug of choice for intracerebral hemorrhage or a hypertensive vasculopathy is nothing else but IV nicardipine to be given beta. Yes. Pterion is the weakest point of skull, and also beneath the pterion you have the middle meningeal artery beta. That is what is important. Clear? Chalo. Next is a common question that a lot of students have sent me over the last few days, and after this we'll take a short break. Okay? So here the question says beta, we are having a middle-aged patient who presents to you after a road traffic accident beta with no pain or no injury reported, but the patient is having inability to pass urine biche. During examination, the blood is observed at the tip of the external urethral meatus and the bladder is not palpable beta. That means the bladder is not full. Only because the bladder is not full, you are not able to palpate it per abdomen. What will be your next step in management of the patient? What is your provisional diagnosis? What are you thinking about this question? What do you think is the diagnosis? What is the diagnosis in this scenario? Let me know in the chat box. Okay, so patient had a road traffic accident, so there was a trauma beta. There was no pain or injury as such, but the patient was having inability to pass the urine beta, and there was blood which was observed at the tip of external urethral meatus beta, and bladder is also not palpable. So all these features which are there, they are usually suggestive of a diagnosis of bladder rupture. So provisional diagnosis in this condition beta seems to be a case of bladder rupture. Yes, usually we know bladder rupture is commonly associated with a pelvic fracture or a pelvic trauma. But here they are saying that there was no injury, but still it could be a case of bladder rupture depending on the symptoms which have been given in the question. As it is a case of bladder rupture now, urinary bladder rupture, we know either it could be a extraperitoneal bladder rupture or a intraperitoneal bladder rupture beta. More commonly, it usually seems to be a case of nothing else but a extraperitoneal bladder rupture. Now somebody would ask me, so why not your urethral rupture, why not urethral injury? Reason beta, I am not saying it is urethral injury, is because they have said that the bladder is not palpable beta. Okay? Yes, inability to pass urine and blood at the tip of external urethral meatus, that can definitely be seen in urethral injury or urethral rupture also. But bladder not palpable will not be a feature of urethral injury or urethral rupture. In urethral injury or urethral rupture beta, the patient will have inability to pass urine, but bladder will be full. But rather there will be urine retention, so bladder will be more palpable beta. Yeah. So here it most likely seems to be a case of an extraperitoneal bladder rupture beta. Could be a case of urethral injury or urethral rupture. I'm not completely ruling out the case. It could be a case of a urethral rupture or a urethral injury also. I'm not completely ruling out, because without investigations, I'll not be able to say confirm whether it is a bladder rupture or a urethral rupture. Chalo, let's take urethral rupture also as a differential. But whether it is an extraperitoneal bladder rupture beta or a urethral rupture, in both the conditions, one thing is for sure, that Foley's catheterization is not preferred. Yes, in clinical practice, we do a Foley's catheterization in some cases, but according to textbooks, it is not preferred. Reason is, in cases of bladder rupture, there is an associated posterior urethral rupture or a posterior urethral injury a lot of times. And if there is a urethral rupture or urethral injury, Foley's catheterization is not considered to be very safe beta. Because if that Foley's catheter gets misdirected and it goes inside that rupture, it may increase that rupture beta. Okay? That's the reason Foley's catheter would not be a very probable option. Option C is perform urethroplasty. If it is diagnosed as a case of urethral rupture, then in some scenarios I may do a urethroplasty, but not always. Yaad rakhna hai baat. Okay? Because majority of the urethral ruptures beta, they usually go for a conservative management. I don't need an active repair or an active urethroplasty to be done. But yes, some cases you may do a urethroplasty, but that is only done once the diagnosis has been confirmed, or if the urethral rupture is not showing a spontaneous resolution beta. Clear? Now we are left with two options. One is a suprapubic cystostomy and second is wait for the bladder to fill. Definitely the treatment that I have beta is suprapubic cystostomy. What is suprapubic cystostomy? It is nothing else but bache, you have to insert a suprapubic catheter directly into the patient's urinary bladder beta. Yes, insert a suprapubic catheter directly into the patient's urinary bladder beta. Okay, yes. So directly do a suprapubic cystostomy for a duration of 3 months, and you will find majority cases mein the bladder rupture or the urethral rupture both are going to heal beta spontaneously. But the problem is they are saying bladder is not palpable, and bladder is not palpable means one of the reason could be the bladder is empty. If let's say it is a case of urethral rupture also, then one of the reason why bladder is not palpable is the bladder is empty. Okay? If the bladder is empty, you cannot directly go for a suprapubic cystostomy or suprapubic catheterization. Otherwise, you will damage the other organs beta. Okay, you can damage the other organs. That's the reason. The better answer to this question has to be option D beta. That is nothing else but wait for bladder to fill. Reason is, as the bladder is empty beta, we wait for the bladder to fill somewhat, and once the bladder has got filled, then definitely beta we can easily insert the suprapubic catheter, or we can perform a suprapubic cystostomy, okay, without any risk of injury to the other organs in the pelvis beta. Yes, that's the reason definitely beta. If it was only a bladder rupture, they would have mentioned, but that's the reason I'm not very sure, na? That's the reason I've taken urethral rupture as a differential. We know either it could be bladder rupture or it could be urethral rupture. We are not very sure. Okay? If I say no, it is urethral rupture only, then how am I sure? Because in both the conditions, the similar symptoms can be seen. Okay? So that is the reason beta. It could be anything of them, but in both the condition, you have to remember the treatment remains same, suprapubic cystostomy. But till that time, we have to wait for the bladder to fill, then only a suprapubic cystostomy can be done safely without damaging or without injuring any part of the pelvic organs beta. So this is nothing else but the RGU or a retrograde urethrogram beta, where you can see the contrast is actually leaking out from a urethral injury or urethral rupture beta, as you are able to see. This is most commonly due to a this is more commonly to be a bulbar urethral rupture or a perineal urethral rupture. That commonly is asked in your examination from radiology. See, this is the urinary bladder. This part is the prostatic urethra. This part in front of the pubic symphysis is the membranous urethra. This part in the bulb of penis is the bulbar urethra. So that bulbar urethra has been ruptured, and this is the penile urethra. Okay, so that is what is important, beta. Now, if I talk about the urethral rupture, I hope all of you are quite aware. In this condition, the urine is going to leak out, beta, or the urine is going to extravasate at two sides. The urine is going to leak out, or the urine is going to extravasate at two sides, beta. Please tell me, if I say there is a anterior urethral rupture or there is a bulbar urethral rupture, the urine extravasation or the urine collection will never happen at which side? Let me know in the chat box. So if I say, beta, the urine collection or the urine extravasation is usually seen in the superficial perineal pouch, beta. Okay, if the urine extravasation or the urine collection is usually found at the superficial perineal pouch. Secondly, it is found inside the scrotum, it is found inside the penis, or it is found inside the abdominal wall. Okay, at all these sites, if there is a urine collection which is seen, beta, then do remember it is a case of an anterior urethral rupture, beta, or a bulbar urethral rupture. It is a case of an anterior urethral rupture or a bulbar urethral rupture. Whereas if the urine collection is usually found in the deep perineal pouch, which if the urinary collection is usually found in the deep perineal pouch and the pelvis, if the urine collection is found in the deep perineal pouch and the pelvis, then it is a classical diagnosis of posterior urethral rupture or the membranous urethral rupture. Then it is a classical diagnosis of posterior or membranous urethral rupture, beta. That is important. Yes, rightly said, beta, that the anterior urethral rupture or the bulbar urethral rupture commonly happens due to the straddle injury or due to the injury by the loose manhole covers or the bicycle accidents, beta. Whereas posterior urethral rupture or membranous urethral rupture is more commonly due to the pelvic trauma, beta, like the road traffic accidents or the pelvic fracture, beta. Clear? So that is what is important to be remembered. Hopefully clear to all of you about this question now. Okay, the common confusion that a lot of people had, I have tried to definitely uh, remove that confusion that you had. Okay, so treatment was done. No issues with this, anybody? So let's take a short break, beta, and then after the break we'll continue further. Thank you so much. 10 minutes break only, not more. Okay. Chalo bachcho, let's start the session now. Okay. Let's continue further. Now, the question number 18 says we are having a 55-year-old male who is a chronic smoker and an alcoholic presented to the OPD with complaints of a long-standing cramping pain in both the buttocks as well as the thighs, especially on walking. He also gives history of he is unable to get a penile erection since the last few months. What is the most probable diagnosis of the case? Okay. So here, what is going to be the provisional diagnosis? What you can think about? Let me know in the chat box. What is the provisional diagnosis of this scenario? Let me know. So here, definitely, beta, they are saying we are having a elderly patient that is around 55 years of age who is a chronic smoker and an alcoholic both. Okay, presenting to you with complaints of a long standing cramping pain beta in both the buttocks as well as the thighs, especially on walking. That means it could be a case of claudication beta, intermittent claudication, and the person is not able to get a penile erection. Why? Because definitely the patient will have impotence, or there is blood flow which is not going to the penile vessels beta, and therefore the patient is not able to get the penile erection. So what is the most probable diagnosis? So we know this condition has developed over a period of time. They are saying it is a long standing condition beta. That means it can be a case of gradual arterial obstruction, right? We know it is a case of a gradual arterial obstruction, or we can even call it as a case of a chronic arterial occlusion. So either it is a gradual arterial obstruction, or we can call it as a case of a chronic arterial occlusion as well. And in this case of gradual arterial obstruction or chronic arterial occlusion, do remember there are two possibilities, or there are two differentials. The most common cause of gradual arterial obstruction or a chronic arterial occlusion has to be atherosclerosis beta, right? Where atherosclerotic plaque is going to cause blockage in the artery. And second one is basically going to be Buerger's disease beta, right? Second one is a case of Buerger's disease, which is thromboangiitis obliterans. Now do remember, both of them are causes of gradual arterial obstruction, but more common cause is definitely atherosclerosis over Buerger's disease. Now, do remember the basic difference. Atherosclerosis is more common in elderly patients who are more than 50 years of age, whereas Buerger's is always seen in younger patients who are less than 40 to 45 years of age beta. Okay, whereas we all know that atherosclerosis is mainly going to involve the large vessels of the body beta, especially the abdominal aorta. Okay, large vessels of the body, especially the abdominal aorta. But Buerger's disease involves the medium to small sized vessels of the body. Buerger's commonly involves the medium to small sized vessels of the body's beta. That has to be remembered. Clear about? Now, in this condition, please tell me the diagnosis more likely seems to be atherosclerosis or Buerger's disease. So do remember beta, here the diagnosis is more likely to be a case of atherosclerosis. Why? Because do remember, though the patient is a smoker, the age of the patient is going to be more than 50 years of age, which is more likely in the favor of atherosclerosis. Yaad rakhna, smoking is not a risk factor only for Buerger's disease. Smoking is a common risk factor for atherosclerosis as well as Buerger's disease beta. Yaad rakhna, smoking can be a risk factor for both the conditions, atherosclerosis as well as Buerger's disease. That is what is important to be remembered. No issues with this, anybody? That is important to be kept in mind beta. Now they are saying what? The patient is not only having a cramping pain in buttocks and the thighs, but the patient is also having beta inability to get penile erection or impotence. Why? Because here there is an atherosclerosis, or here basically there is a blockage beta at the level of the at the level of the aortoiliac bifurcation. I hope all of you are quite aware that the abdominal aorta which is there, it is going to divide, or it is going to bifurcate beta into the common iliac arteries, right? So these are your common iliac arteries which are actually formed after the division or the bifurcation of the abdominal aorta beta. Clear? Then this common iliac arteries which are there, those are going to further divide into the external iliac artery and internal iliac artery. Let's say this is the internal iliac artery and this is the external iliac artery beta. We all know that the external iliac artery which is there, it is going to supply the lower limb of the patient, whereas internal iliac artery which is there, it is going to supply the buttocks and the genitalia of the patient, like buttocks and the penis of the patient, beta. Clear about? As definitely, beta, what happened over here in this condition was there was an atherosclerosis and there was a blockage, beta, at the level of the at the level of the aortoiliac bifurcation. As the blockage was at the level of aortoiliac bifurcation, beta, obviously there was no blood supply going to the common iliac arteries, so there was no blood supply going to the external iliac artery, beta, and therefore there was a pain or claudication in the lower limb. As there was no blood supply going to the internal iliac artery, there was no blood supply to the buttocks, causing a cramping pain in the buttocks. And as there was no blood supply to the genitalia or the penis, patient was not able to get a penile erection, or the patient was having an impotence, beta. Clear? So here definitely we know the obstruction due to atherosclerosis is basically at the level of nothing else but the aortoiliac bifurcation. The obstruction is basically at the level of aortoiliac bifurcation, and we know it is a classical diagnosis of nothing else but Leydig syndrome, beta. It is a classical diagnosis of nothing else but Leydig syndrome. Hopefully clear. The answer to this question is option C, that is Leydig syndrome, which is nothing else but atherosclerosis or an obstruction at the level of the aortoiliac bifurcation. That is what is important to be remembered, beta. Treatment of Leydig syndrome is nothing else but if there is an aortoiliac bifurcation, beta, we obviously have to go for a Dacron graft repair. Here we know, beta, that graft repairs have to be done. Either you can use an autologous graft from the patient's body. Autologous graft from the patient's body can be either the lima or rima. Lima or rima is nothing else but the left or the right internal mammary artery, beta. So lima or rima is definitely considered as the best autologous graft in cases of arterial obstruction or arterial blockage. But the most commonly used graft, or the most commonly used autologous graft, is GSV, that is great saphenous vein, beta. So GSV or the great saphenous vein is the most commonly used autologous graft. But if they ask you if there is a larger vessel, we know these autologous grafts are not very good for the larger vessels, beta, like abdominal aorta. So if there is an obstruction of the larger vessels like aorta and the iliac vessels, then we better use synthetic graft. And the synthetic graft that we use, beta, for the larger vessels like aorta and iliac vessel is the Dacron graft. Whereas the synthetic graft that we use for smaller vessels like the femoral or the popliteal artery is the PTFE graft or the polytetrafluoroethylene graft. Okay? So larger vessels के लिए we use the Dacron graft, but for smaller vessels we use the PTFE graft, that is polytetrafluoroethylene graft, beta. Clear? This is definitely not a case of a femoral venous insufficiency, because if there is a venous insufficiency, beta, there is pooling up of deoxygenated blood in the lower limbs of the patient. Okay, the patient will not have problems like inability to get a penile erection, okay, or a cramping pain like features. Okay, next important if I talk about is Berger's disease. I've told you why not Berger's disease, because here the larger vessels like the aortoiliac bifurcation is blocked, and that is not seen with Berger's disease. Secondly, Berger's disease is common in younger patients less than 40 to 45 years of age, not in older or elderly patients above 50, beta. Clear? An abdominal aortic aneurysm, do remember one point, beta, that aneurysm which is there, it is going to present to you with an abdominal discomfort or an abdominal lump or a pulsatile swelling. These kind of features will be present in an abdominal aortic aneurysm. It is not going to cause any kind of cramping pain in buttocks vagara or a penile impotence and these kind of findings. Hopefully clear. We know the treatment in cases of gradual arterial obstruction like atherosclerosis and Berger's disease. First line management has to be lifestyle modifications, beta, that is quit smoking and alcohol. Okay? Second important is going to be medical management with drugs like vasodilators, antiplatelets and statins. The vasodilators, antiplatelets and statins are given for medical management. If that fails, then in patients of atherosclerosis, we either go for a percutaneous transfemoral angioplasty. Either you can do a balloon angioplasty or you can do a stent angioplasty, beta. Balloon angioplasty or stent angioplasty. Or the other option is a bypass grafting, beta. The last option is a bypass grafting usually. But we know whether angioplasty or bypass grafting, they are never possible for Berger's disease, beta, because Berger's disease means smaller vessels are obstructed. Therefore, bypass grafting or angioplasty is not possible. In Berger's disease, if medical management fails, we directly go for a lumbar sympathectomy beta. We directly go for a procedure known as lumbar sympathectomy. Clear? Chalo. Next important is question number 19. Recent question in the FMG exam. There was a 40-year-old female beta who is a housemaker or a housewife basically, who presents to the hospital with complaints of a dull aching discomfort beta in the legs from the past few months. Below given finding was observed according to the CAP classification or the CEP classification. What shall be the most appropriate stage in this given scenario beta? Okay? So we know they have said that the female is a housemaker. So that means they are trying to tell you the female may have prolonged standing beta. And due to prolonged standing, there is pooling up of deoxygenated blood in the superficial veins of the leg beta, causing a condition where the superficial veins of the leg are dilated and they're tortuous, called as varicose veins. Now here, they are saying the female is having a dull aching discomfort in the legs, okay? And the below given finding. If you see the below given finding, you can see the vessels which are there, they are dilated. But these veins, these superficial veins which are dilated beta, they are usually less than 1 mm dilated. And when the veins are usually less than 1 mm dilated, we call it as telangiectasia beta. Whenever the veins are usually less than 1 mm dilated, we call it as telangiectasia. This was the recent question in the FMG exam in Jan. Okay? And telangiectasia is nothing else but beta. Here, you are going to have dilatation of less than 1 millimeter. Telangiectasia is nothing else but you will have a dilatation of less than 1 mm. So please tell me if telangiectasia is seen in the picture, then according to the CAP classification of varicose veins, what is going to be the stage of this patient beta? Very good all of you. Shabash. The stage of this condition which is there has to be option A beta. That is nothing else but stage C1. We all know the CAP classification of varicose veins basically beta is going to be nothing else but C stands for clinical manifestations. That means the classification that we do based on the signs and symptoms or the clinical manifestations beta. E stands for etiology. That is the classification that we do based on the cause or the etiology of the case. Third, A stands for anatomy. The classification done based on the anatomy or the location of the varicose veins beta. And last, P stands for pathophysiology. Pathophysiology means the classification that is usually done based on the mechanism of the varicose veins beta, how they develop. That is basically the CAP or the CEP classification of varicose veins. Remember the full form for sure. Clear? Now, according to the CAP classification, the most important is the clinical manifestation based classification, which is basically C0 literally says beta that there is no visible sign or no palpable sign of any venous disease. So if there is no visible or palpable sign of venous disease, we call it as C0. Next important, C1 is when the veins are less than 1 mm dilated, called as telangiectasias, or when the veins are 1 to 3 mm dilated, called as reticular veins. Yes, reticular veins means when the veins are 1 to 3 millimeters dilated. Next is C2. C2 is when the veins are more than 3 millimeter dilated, called as varicose veins. So yaad rakhna, varicose vein is basically C2, and that is when the veins are more than 3 mm dilated beta. Next is C3. C3 is when there is edema beta. Next is going to be C4. Now there are various stages in C4. C4A is going to be pigmentation and venous eczema. C4A is going to be pigmentation and venous eczema. C4B is a classical case of lipodermatosclerosis. Yes, lipodermatosclerosis means fibrosis of the skin and the fat in the leg, and that lipodermatosclerosis gives you a very classical appearance beta called as the inverted champagne bottle appearance, and that lipodermatosclerosis is going to be C4B. That has been a repeated PYQ in FMG exam. So lipodermatosclerosis is C4B beta, and corona phlebitictia is C4C. Corona phlebitictia is going to be C4C. Next important is C5. C5 is basically beta whenever the patient is going to have a healed venous ulcer. Varicose veins will lead to formation of a venous ulcer. So C5 is going to be a healed venous ulcer beta. And last is C6. C6 is going to be an active venous ulcer. C6 is going to be an active venous ulcer. So C1 is telangiectasia or reticular veins. C2 is varicose veins. C3 is edema. C4A pigmentation and eczema. C4B lipodermatosclerosis. C4C corona phlebitictia. C5 healed ulcer, and C6 active venous ulcer beta. That is what is important to be remembered. Always remember that lipodermatosclerosis was a PYQ, and we all know that lipodermatosclerosis which is there, it is actually going to be the stage C4B according to the CAP classification, and it gives us the very classical inverted champagne bottle appearance beta. It gives us the very classical inverted champagne bottle appearance. Hopefully clear to all of you now. So these are the important features that you have to remember about the lipodermatosclerosis beta. We know in cases of varicose veins, the investigation of choice will be the duplex scan or the Doppler because it is a peripheral vessel. So investigation of choice will be the duplex scan or the color Doppler beta. And treatment nowadays, usually we go for a EVLT, that is an endovenous laser therapy, or a RFA, that is radio frequency ablation beta. Okay? So do remember, in cases of varicose veins, investigation of choice has to be the duplex scan, that is nothing else but the color Doppler. And if they ask you the treatment, so in the early stages, you only do lifestyle modifications, that is ask the patient to elevate the limb, ask the patient to wear the elastic compression stockings. But in advanced stages, we have to go for surgery. Surgery is like either EVLT, that is endovenous laser therapy, or RFA, that is radio frequency ablation beta. Hopefully clear to all of you. Next important is question number 20. Let's talk about that. A patient has been brought to the casualty following a RTA or following a road traffic accident beta. Now they are saying head injury was suspected in the patient. He does not give any history of loss of consciousness. The patient was not having any history of loss of consciousness beta. Patient was not having any kind of vomiting, no history of ENT bleed after the accident. You assess the GCS or you assess the Glasgow Coma scale of the patient. We know whenever a patient of head injury is brought to us, we have to assess the severity of head injury. Therefore, we have to check the patient's GCS or the Glasgow Coma scale. Now they are saying the patient opens the eyes spontaneously. Patient is opening the eyes on his own. Okay. Next, he is oriented to time, place and person. That means patient answers all the questions correctly. He is oriented to time, place and person. And the patient is able to obey all the commands beta. He can follow all your commands, whatever you are giving him. They are asking you what is the grade of head injury in the patient. Now we all know definitely beta. Yes, definitely. Okay. If I talk about in this condition, okay, in this condition, it is a classical case of head injury, and we know whenever a case of head injury is brought, we have to do a GCS assessment, that is Glasgow Coma scale. Now, whenever I talk about the Glasgow Coma scale, do remember there are three important parameters of Glasgow Coma scale. First one is the eye opening response. Second one is the best verbal response. And third one is the best motor response beta. Okay, so the first one is eye opening response, second one is best verbal response, and third one is the best motor response. Do remember, if the patient opens the eyes spontaneously, then give a score of E4. If the patient is not opening the eyes spontaneously, and if the patient is opening the eyes to speech or the patient is opening the eyes to voice command, then give a score of E3. If the patient is opening the eyes to pain or to a pressure, if the patient does not open the eyes on voice command, but rather patient opens the eyes on pressure or a painful stimulus, then give a score of E2. And if the patient is showing no response at all, give a score of E1 beta. Next is best verbal response. In verbal response, if the patient appears oriented to time, place and person, that means the patient is able to answer all your questions correctly beta, then you have to give a score of 5. Second, if the patient is confused or the patient appears disoriented with time, place and person, give a score of V4. So if the patient is not able to answer the questions correctly or the patient appears confused, give a score of V4. Next, if the patient speaks some inappropriate words or the patient abuses beta, so patient is abusing the doctor or speaking some inappropriate words, then give a score of V3. If the patient is making some incomprehensible sounds, the patient is making some sounds and we are not able to understand what, then it is a score of V2. And if the patient does not make any sound itself, then give a score of V1 beta. Next is motor response. The best motor response is when the patient is able to obey the command. If the patient obeys all the commands beta, give a score of M6. If the patient is not able to obey the command, but at least he is able to localize the pain, that means you give a painful stimulus to the patient and then ask, where was the pain? And if the patient is able to localize the pain or tell you the pain, then definitely beta we give a score of M5. Next, If the patient is not able to tell you or not able to localize the pain, then definitely you give a painful stimulus and then you see whether the patient withdraws on pain or not. If the patient withdraws on pain or if the patient performs a normal flexion, then we give a score of M4. So if the person does a flexion withdrawal from plane beta, then definitely it is given a score of M4. If the person is having an abnormal flexion, also called as a decorticate posture, then we give a score of M3. Abnormal flexion, also called as decorticate posture, is M3. If the patient performs an abnormal extension, also known as decerebrate posture, then we give a score of M2. So if there is an abnormal extension or decerebrate posture, then M2. And if there is no motor response at all, then M1. We all know the best GCS or the best Glasgow Coma scale will be a score of 15 beta. Whereas if the patient is totally unresponsive, or the worst GCS or the worst Glasgow Coma scale score will be 3 beta. The maximum score is 15, minimum score is going to be 3. And whenever the patient score is usually between 3 to 8 beta, or whenever the patient score is less than equal to 8, then the patient will be usually in the comatose state, where the patient has a very high risk of aspiration or airway blockage. Therefore, whenever the patient is having a GCS of 3 to 8, we usually tend to do an endotracheal intubation, or we intubate the patient beta. Samjhe baat? That is important. Now, if I talk about the grades of head injury, just remember one point. If the patient is having a score of 3 to 8 beta, then we know it is definitely a case of severe head injury. And in the severe head injury, the patient has a very high risk of aspiration beta, and that's the reason a lot of times you tend to intubate these patients. Second important is when the patient score is 9 to 12 basically beta, then in this condition we know it is a case of moderate head injury beta. Whenever the score is 9 to 12, it is a classical case of moderate head injury. And whenever the patient score is basically 13 to 15 beta, whenever the patient score is 13 to 15, we know it is a classical case of mild head injury. But do remember beta, when the patient is having 13 to 15 ka score with loss of consciousness, then we basically call it as a case of mild head injury beta. But whenever the patient is having a score of 15 on 15 without any loss of consciousness, please remember, if there was a score of 15 on 15 and there was definitely a loss of consciousness, you will definitely call it as a mild head injury beta. But in this condition beta, please remember, if there is going to be a score of 15 on 15 without any loss of consciousness, it is considered as a case of minor head injury beta. Clear about that? Is important. And do remember one more point. I've told you already in verbal response that whenever the patient is intubated beta, obviously you're not going to remove the endotracheal tube and check the verbal response. So whenever the patient is intubated, we usually write the score as VNT. That is nothing else but not testable beta. The verbal response is not testable in the patient. Clear? So now here they have said the patient opens the eye spontaneously. That is nothing else but a maximum score of E4 beta. Second important, they are saying that the patient appears oriented to time, place and person. That is again a maximum score of V5 beta. And third, they have said the patient is able to obey all the command. That is a maximum score of again M6 beta. That means the patient score is 15 on 15 beta in the GCS. And they are saying the patient does not give any history of loss of consciousness beta. As soon as they say patient is having a score of 15 on 15 without any loss of consciousness, we know it is a classical case of option A, that is nothing else but the minor head injury. So in case if they go in somewhat depth, be aware of this. Okay? That is what is important. Pupils, if both the pupils are non-reactive, then you give a score of 2. If one pupil is non-reactive, we give a score of 1. And if both the pupils are normal or if both the pupils are reactive, we give a score of 0. Hopefully clear. Burgess and atherosclerosis have explained the difference properly. Both the conditions mein, athero is more common in older patients, Burgess is more common in younger. Athero is commonly involving the larger vessels, Burgess is commonly involving the medium to small sized vessels. Samjhe baat? That is important. Hopefully clear. Chalo. Next important is a question number 21 beta. A patient was admitted in the ICU with a history of high grade fever along with malaise, that is generalized weakness, and severe abdominal pain. The BP of the patient was 90 by 50 millimeters of mercury. Pulse rate was 120 beats per minute. We know if BP is 90 by 50 and pulse rate is 120, that means the patient is hemodynamically unstable or the patient might be in shock. Respiratory rate of the patient is 26 breaths per minute. That means there is tachypnea or respiratory distress. GCS of the patient is 12. So again, just now we have discussed, if the GCS of the Glasgow Coma Scale is 12 beta, that means the patient is having a moderate head injury. They are saying lab investigations reveal a total leukocyte count of 26,000 cells per cubic millimeter, and the patient is having a predominant neutrophilia beta. So you can see, one, the total leukocyte count is high beta. That means there is leukocytosis, suggestive of an infection or sepsis. And obviously predominant neutrophilia, so it is some acute bacterial infection due to which the patient might have landed up in sepsis beta. Serum creatinine is also high. Serum creatinine of the patient is somewhere near 3.4 milligrams per deciliter. That means the kidneys of the patient have been damaged beta. So now the organs have started getting damaged. It is definitely a case of sepsis. You had to assess the Q-SOFA score. We all know, whenever a patient of sepsis comes to us beta, you check the severity of sepsis with the help of a quick SOFA score or a Q-SOFA score. And this has to be done to predict the prognosis of the patient, right? Whenever a patient of sepsis comes and you have to assess the severity of sepsis or you have to predict the prognosis, that means patient will have a better outcome or a poor outcome. In this condition beta, we have to use the Q-SOFA score for assessment. They are asking you which among the following given parameters are comprised in the Q-SOFA score. That is the question. We know, so if all these features are given, all of these features are suggestive of a very severe infection causing organ damage now. The provisional diagnosis of the patient is nothing else but sepsis for sure. We all know the definition of sepsis. I've always told you. Previously, the definition of sepsis was whenever there is a known foci of infection along with the SIRS, that is systemic inflammatory response syndrome. But nowadays in Bailey, the new definition of sepsis is whenever there is any documented infection with minimum 2 parameters of the SOFA score beta. So do remember, documented infection along with SOFA features. And we know, when do we say septic shock? We know whenever a patient is having sepsis, along with that, if the patient is having hypotension or the patient is hemodynamically unstable, then we say that the patient is suffering from septic shock beta. In cases of sepsis, you have to check the patient's Q-SOFA or the quick SOFA score. And we all know Q-SOFA or quick SOFA is nothing else but quick sequential organ failure assessment score beta. In a PYQ, they have just asked full form once. So don't get confused. So do remember, it is nothing else but quick sequential organ failure assessment score is classically called as the Q-SOFA score. In emergency, whenever a patient of sepsis comes to you, check the severity or assess the prognosis with the help of this Q-SOFA score itself. And the Q-SOFA score has 3 parameters beta. Very good. It is going to be remembered by the mnemonic, that is nothing else but bar or GB road beta. It is remembered by the mnemonic, that is nothing else but bar or GB road. And we know what is bar or GB road. So do remember the 3 parameters bar or GB road will be. If I say the mnemonic bar, let's say, then we know the 3 parameters will be systolic blood pressure less than 100 millimeters of mercury beta. Second, A stands for altered mental status. And we all know beta, altered mental status can be assessed with the help of GCS, that is your Glasgow Coma scale basically. The altered mental status can be assessed with the help of GCS or the Glasgow Coma scale. And R stands for respiratory rate more than 22 breaths per minute beta. Respiratory rate more than 22 breaths per minute. So bar mnemonic can be remembered, or you can remember GB road beta. Okay, any of the mnemonic is fine, whatever is close to your heart. And we all know the 3 parameters now, and the diagnosis, the answer has to be nothing else but beta, option D for this question. Blood pressure, respiratory rate and GCS. Do remember, creatinine is not a part of the GCS. Pulse rate is not a part of GCS. Pulse rate is not a part of Q-SOFA. Temperature is not a part of Q-SOFA again beta. Clear? So therefore this has to be the answer, option D. Hopefully clear? Chalo. No issues with this. Next is question number 22 beta. A patient was brought to you with complaints of colicky abdominal pain and constipation, that is decreased GI motility. Since the last few months beta, he gives history of renal stones and was incidentally diagnosed and managed conservatively beta. Okay? His lab workup shows the serum sodium level is 137 milliequivalents per liter. serum potassium is 4 milliequivalents per liter beta, and serum calcium is 13 milligrams per deciliter. See, sodium appears normal, it is 135 to 145 milliequivalents per liter. Potassium appears normal, it is 3.5 to maximum 5.5 milliequivalents per liter. But calcium appears to be high because the normal calcium level is 9 to 11 milligrams per deciliter. But here the serum calcium is 13 milligrams per deciliter, so there is hypercalcemia. And then you can understand all the features, because hypercalcemia is known to cause a colicky abdominal pain along with constipation along with renal stones beta. So we know whenever the patient is going to suffer from hypercalcemia beta, whenever the patient is going to have a features of hypercalcemia, so you might have heard about, in cases of hypercalcemia, the patient is going to have nothing else but, okay, groans, that is abdominal groans, moans, okay, and stones. So groans, moans, stones, basically they are the features of hypercalcemia. That is nothing else but beta, the patient is actually going to have abdominal cramps basically, or the patient is going to have abdominal pains due to the renal stones beta, and the patient is going to have renal stones. So these are usually features of hypercalcemia that we have. Okay, so hypercalcemia to hai, that's for sure. And we know the hypercalcemia can be due to which reason beta? So they're asking you which is the investigation that you will use to confirm the diagnosis of this scenario. Now we know this hypercalcemia with renal stones can be due to a condition that is nothing else but hyperparathyroidism. And I hope all of you are quite aware beta that hyperparathyroidism mein there is excess amount of parathyroid hormone, and due to this excess parathyroid hormone beta, the patient is definitely going to have hypercalcemia. And we all know the most common cause of primary hyperparathyroidism is a parathyroid gland adenoma. The most common cause of a hyperparathyroidism case is usually a parathyroid gland adenoma beta. That is what is important to be remembered. Hopefully clear. So now please tell me, what is the investigation that will actually help you to confirm the diagnosis of hyperparathyroidism or a parathyroid gland adenoma beta? Let me know in the chat box. Anybody? What is going to be the likely investigation? This was a PYQ repeated twice in the FMGE examination beta. What is the likely investigation which can confirm your diagnosis of hyperparathyroidism or parathyroid gland adenoma? So the answer to this question is nothing else but option B, bache, that is your system AB scan. So we know we have to do a system AB scan beta. So the best investigation is a SPECT system AB scan. In case if SPECT system AB scan is not available, then mark it as technetium 99 system AB scan. But yes, system AB scan has to be the investigation of choice to confirm the diagnosis of parathyroid gland adenoma or parathyroid gland pathologies beta. That is what is important. Yes, right. All of you are right. Very good. So that is important beta. And once you diagnose a parathyroid gland adenoma, you can manage it surgically beta. Surgical removal has to be done. NCCT KUB, yes, it can be done for a case of renal stones beta. Okay. The NCCT KUB can be done for renal stones, but that is not going to confirm the diagnosis beta. It can only tell you whether the patient is having renal stones or not. Okay. But the other features, they are not only the other features are not only due to renal stones. There is something big behind these renal stones beta, and that bigger picture is hyperparathyroidism. Clear? CCT abdomen, again, it can be done for that colicky abdominal pain, but it is not going to help you in confirming the diagnosis as such. Bone marrow biopsy, no. Bone marrow biopsy is not required in this condition at all. Clear? So bone marrow biopsy, I would have thought in cases of multiple myeloma, when an elderly patient comes to me with features like low backache along with anemia and renal failure, then in multiple myeloma I could go for a bone marrow biopsy. But here no such picture is seen. Okay? That is important. And we know that hyperparathyroidism or a parathyroid gland adenoma is commonly associated with a syndrome classically known as MEN syndrome. We all know MEN syndrome are nothing else but beta, multiple endocrine neoplasia, when the patient is going to have multiple tumors arising from the endocrine glands beta. That is known as a multiple endocrine neoplasia. If I talk about the MEN syndrome, first of all, remember about the MEN1 syndrome. This MEN1 syndrome which is there, it is basically due to the menin gene mutation which is actually located on chromosome number 11 beta. So it is due to the menin gene mutation located on chromosome number 11. Now important is, if I talk about this, Men 1 syndrome due to meningeal mutation. It has the classical 3 P's beta. And when I talk about these classical 3 P's, do you remember the first P is nothing else but a pituitary adenoma, most likely to be a prolactinoma. Second important P is a parathyroid hyperplasia or a parathyroid adenoma causing hyperparathyroidism. And third P is the pancreatic tumor, commonly like a gastrinoma beta. A pancreatic tumor, commonly like a gastrinoma. Hopefully clear. So these are the important 3 P's. So men 1 is characterized by the 3 P's, that is pituitary adenoma, parathyroid hyperplasia or parathyroid adenoma, and the pancreatic tumors like gastrinoma. Yes, very good. You can also remember that men 1 syndrome is also called as the Werner syndrome and not the Werner syndrome. Okay? Werner syndrome is progeria beta. This is Werner syndrome, that has to be kept in mind. Hopefully clear. Next important is the classical men 2A syndrome. Do you remember beta that men 2A syndrome which is there? It is due to the red gene mutation located on chromosome number 10. So men 2A syndrome is due to the red gene mutation located on chromosome number 10, and this men 2A syndrome is also called as the Sippel syndrome beta. The men 2A syndrome is classically referred to as the Sippel syndrome, and do remember in this condition the patient is going to have the classical 1M and 2Ps beta. The patient is going to have the classical 1M and 2Ps. That is what is the classical presentation in cases of the men 2A syndrome or the Sippel syndrome. What are the 1M and 2Ps? So here you are able to see, first of all, the M is medullary thyroid carcinoma beta. The M is nothing else but medullary thyroid carcinoma. The 2Ps are parathyroid hyperplasia or the parathyroid adenoma, and second P is pheochromocytoma. So do remember, men 2A syndrome is characterized by the 1M and 2Ps. M is medullary thyroid carcinoma, 2Ps are parathyroid hyperplasia and the pheochromocytoma. Last one is basically the men 2B syndrome. Do you remember this men 2B syndrome which is there? It is also due to the red gene mutation beta located on the chromosome number 10. It is also the red gene mutation located on chromosome number 10. This is known as the men 2B syndrome, which is also known as the men 3 syndrome. Yes, the men 2B syndrome is known as the men 3 syndrome, also called as the Gorlin syndrome beta. And this men 2B or the men 3 syndrome is characterized by the 3 M's and 1 P beta. To remember that this men 3 syndrome or the men 2B syndrome is characterized by the 3 M's and 1 P. What are those now? First of all, basically beta is going to be M for mucosal neuromas. Second M for marfanoid habitus. Next important is medullary thyroid carcinoma. And last P for pheochromocytoma. So do remember the 3 M's and 1 P in cases of men 2B or men 3 syndrome is medullary thyroid carcinoma, marfanoid habitus, mucosal neuromas, and pheochromocytoma beta. That is what is important. Glucagonoma is basically a tumor arising from the alpha cells of pancreas, which is going to have diabetes mellitus along with DVT, along with depression, along with a dermatitis called as necrolytic migratory erythema. So 4 Ds are there: diabetes mellitus, DVT, depression, and dermatitis in form of necrolytic migratory erythema. Whereas if I talk about basically the gastrinoma, gastrinoma is a tumor or a malignancy arising from G cells, and that is going to cause more secretion of gastrin, leading to more secretion of HCl or hydrochloric acid, leading to multiple or giant peptic ulcers. Clear? That is the basic difference. Question number 23 beta. We are having a young male patient who presents to us with complaints of long-standing epigastric pain along with vomiting and dyspepsia. He gives history of recurrent peptic ulcers in the past, but despite the lifestyle modifications beta and the PPI therapy or the proton pump inhibitor therapy, patient does not show any improvement as such. Further workup reveals there is a mass in the duodenum in the periampullary region. What shall be the next best step in this case? Lo, aa gaya the question. So now hopefully all of you are quite aware. Please tell me the provisional diagnosis of this case, bache. Young male patient having a long-standing epigastric pain, vomiting and dyspepsia. And he was a case of recurrent peptic ulcers. But even after lifestyle modifications and PPI therapy, the patient's condition did not improve. Further workup reveals there is a mass in the periampullary region. What was the provisional diagnosis? Anybody provisional diagnosis batao? I have told you recurrent peptic ulcers, giant peptic ulcers, multiple peptic ulcers, which are not even responding to PPI therapy, and they are due to a mass in the duodenum, which is found in the periampullary region, has to be a provisional diagnosis of gastrinoma. Just now I've told you it is basically due to a provisional diagnosis of gastrinoma beta. Gastrinoma is the most common malignant neuroendocrine tumor of pancreas. Yes, the most common malignant neuroendocrine tumor of pancreas is known as gastrinoma. We all know gastrinoma usually is a tumor arising from the G cells of the pancreas or G cells of the duodenum beta, and therefore the patient is going to have hypergastrinemia. In this condition, yaad rakhna, the most common site is the Passaro triangle, also called as the gastrinoma triangle. The most common site in cases of gastrinoma is the Passaro triangle or gastrinoma triangle. Can you see? So this is the classical picture of the Passaro triangle or the gastrinoma triangle beta, which usually extends from the junction of the gallbladder neck and the cystic duct to the second and third part of duodenum. Clear? So in this triangle basically beta, you are able to see the gastrinoma basically. Okay? Now it can arise from the pancreas, it can arise from the duodenum also. So more common site for gastrinoma, if they ask you, answer is nothing else but duodenum, not the pancreas. Yes, the most common site of gastrinoma is not the pancreas, it is more commonly the duodenum. That has to be remembered. Here I have told you already, the patient will have excess gastrin secretion or hypergastrinemia. This gastrin is actually caused, this gastrin is known to cause the stimulation of parietal cells, and as it is known to cause stimulation of parietal cells, it is known to increase the HCl or the hydrochloric acid secretion. And as it increases the HCl or hydrochloric acid secretion beta, the patient is actually going to develop recurrent peptic ulcers, multiple peptic ulcers, or giant peptic ulcers beta. So recurrent peptic ulcers, multiple peptic ulcers, or giant peptic ulcers along with a mass in the duodenum or pancreas, if they say, think about the diagnosis of nothing else but gastrinoma beta. That is what is important to be remembered. Hopefully clear to all of you. Now, in cases of gastrinoma, what should be the next best step to confirm the diagnosis? Let me know in the chat box. What do you think should be the answer for this case now? Let me know in the chat box. Next best step I'm asking, and not the definitive step or not the final step in management. So practically speaking, if the patient is coming to us and you are able to find a mass in the duodenum, what is the next best step? Very good. We know the investigation of choice to confirm the diagnosis of gastrinoma beta is nothing else but the serum gastrin levels. And we all know beta, if the serum gastrin levels are found to be more than 1000 picograms per ml beta, whenever the serum gastrin levels are found to be more than 1000 picograms per ml, then we confirm a diagnosis of gastrinoma beta. Then after confirming that, then we can do a SRS, also called as somatostatin receptor scintigraphy. That somatostatin receptor scintigraphy will actually help us to localize the tumor. So once you have confirmed the diagnosis, yes, it looks like a gastrinoma, then definitely to localize the tumor, we do a SRS. And once we have done a SRS and we have confirmed the diagnosis also, then we will go for a modified Whipple surgery, which is the treatment for a case of gastrinoma. And do remember, this modified Whipple surgery is also called as the duodenum preserving pancreaticoduodenectomy beta. And this duodenum preserving pancreaticoduodenectomy or modified Whipples is the treatment for gastrinoma. But here, as they have asked you next best step, answer has to be option D, that is send a sample for the serum gastrin levels, and if they are more than 1000, it confirms the diagnosis of a gastrinoma beta. After that, option C, that is somatostatin receptor scintigraphy to localize the tumor, and after that, option B, that is modified Whipple surgery beta. Check basal output. Yes, you can check the basal you can check the basal acid output of the patient, but it is not the investigation of choice or something. You want, you can check. It is not mandatory to be done. Hopefully clear to all of you now. That is what is important. Clear? So next important is question number 24 beta. It is a young patient presents to you with complaints of dysphagia, that is difficulty swallowing, and this dysphagia is more for liquids as compared to solids beta. Patient is also having regurgitation of food and he does not experience any kind of chest pain. Okay, that means the pressure is not very high. He also gives history of weight loss from the past few days. What is the initial step in this case? Please tell me, what is the provisional diagnosis you are thinking about? What is the provisional diagnosis in this case that you are thinking about? Very classical. Dysphagia more to liquids as compared to solids. That is very, very classical. Nothing else but. Why DES? Did I say chest pain is there? DES is going to have a very, very high pressure, and therefore it is going to present to you with commonly chest pain beta. More classical over here seems to be a diagnosis of achalasia in the case. Clear? The provisional diagnosis of this condition seems to be achalasia cardia, your examiner's favorite. So do remember the provisional diagnosis in this condition seems to be a diagnosis of achalasia cardia beta. Now when I talk about achalasia cardia or diffuse esophageal spasm, yes, both of them are motility disorders. Here definitely beta, your lower esophageal sphincter does not relax in cases of achalasia cardia. As the lower esophageal sphincter does not relax, the lower esophageal sphincter is contracted and the food is not able to pass through, causing dysphagia. Okay? Achalasia cardia can be due to two reasons. One is basically due to the loss of ganglionic cells beta. In which plexus? That is the PYQ. Please tell me, in case of achalasia cardia, there is loss of ganglionic cells. From which plexus of the GI tract, or what, from which plexus of the lower esophageal sphincter? Let me know in the chat box. Or it can also occur due to deficiency of nitric oxide and VIP. It also happens due to deficiency of nitric oxide and vasoactive intestinal polypeptide beta. So we know achalasia happens whenever there is loss of ganglionic cells beta, mainly from the Orbach's plexus or the Meyntrich plexus of the lower esophageal sphincter, or Orbach's plexus or the Meyntrich plexus of the GI tract. Hopefully clear to all of you now. So that is what is the cause for primary achalasia cardia beta. Clear? In cases of achalasia cardia, the patient has a very classical symptom. First is dysphagia, which is more to liquids as compared to solids. As liquids are lighter in weight, they are not able to pass through the contracted lower esophageal sphincter. But as solids are heavier in weight, they are able to pass through the contracted lower esophageal sphincter beta. Another question that I'll ask you, and that is, please tell me, dysphagia more to solids as compared to liquids is a feature of. Dysphagia more to liquids is going to be, sorry, dysphagia more to solids is a feature of. Dysphagia more to solids is a feature of which condition? Let me know in the chat box. Now, second feature over here is regurgitation of food. And third, the patient will have halitosis beta or bad breath. And as the person is not able to eat the food, obviously that is going to cause weight loss in the patient. As the patient is not able to eat the food only, that causes weight loss in the patient. Now, whenever any patient comes to you with a complaint of dysphagia, whenever any patient comes to you with dysphagia beta, the first line investigation in dysphagia is always and always option C, that is a barium swallow. So here they have asked you what is the initial step. So initial step in the diagnosis has to be option C, that is perform a barium swallow beta. If they would have asked me what is the investigation of choice in this condition, then your answer is what one? Let me know in the chat box again. Yes, very good. Dysphagia more to solids is a feature of esophageal cancer or carcinoma esophagus. But now my question is, in case if they ask you beta that what is the investigation of choice for achalasia cardia, then your answer would be what? Investigation of choice for achalasia cardia. Very good. Then, so after barium swallow is done beta, then we can go for a esophageal manometry. So once barium swallow is done, then the next step has to be option B, that is esophageal manometry, because it is the investigation of choice. And when you will do a esophageal manometry, you will find the pressure of the lower esophageal sphincter is usually between 26 to 100 millimeters of mercury, which confirms the diagnosis. And once that is done, then you can go for treatment. Treatment can be done with the help of option D, that is calcium channel blockers or nitrates. These calcium channel blockers or nitrates will relax the lower esophageal sphincter muscles, treating achalasia. Okay, but it is not always effective. You can go for endoscopic dilatation or injection of botulinum toxin or POEMs, but none of them is the treatment of choice. If they ask you what is the treatment of choice for achalasia, I hope all of you are quite aware, and it is nothing else but Heller's myotomy surgery. So do remember beta, the treatment of choice for cases of achalasia cardia is nothing else but a Heller's myotomy surgery, has to be kept in mind. No issues with this. So here, as they asked you basically the next best step or the initial step, answer was barium swallow. Okay? And whenever we do a barium swallow in patients of achalasia cardia, you can see such a smooth narrowing or a smooth tapering. And we know that smooth narrowing or smooth tapering is classically called as the bird beak appearance beta. It is classically referred to as the bird beak appearance, or we can even call it as the pencil tip sign, or we can even call it as a pencil tip sign. In case bird beak appearance is not an option, pencil tip sign is not an option, smooth tapering is not an option, then I can mark it as ragtail sign. So ragtail sign will not be my first choice if the options are like bird beak sign or pencil tip sign or smooth tapering. That will be my preferred choices, beta. Hopefully clear. No issues with this. Next important is another condition which is also motility disorder of esophagus. Here you can see spasm is there, but not only in one part, but throughout the esophagus. Whenever there is spasm throughout the esophagus, beta, we call this condition as DES, also called as the diffuse esophageal spasm. We call this condition as DES, also called as diffuse esophageal spasm. In this condition also, the patient will have dysphagia. Along with that, there will be chest pain because the pressure is high. In this condition also, my first line investigation will be barium swallow. And when I do a barium swallow, you are able to see the classical corkscrew appearance, beta, also called as the rosary bead appearance. This is classically referred to as the corkscrew appearance, also known as the rosary bead appearance, beta. That is what is important to be remembered. Apart from this, we know investigation of choice here also is the esophageal manometry. In cases of diffuse esophageal spasm also, we know the investigation of choice is the esophageal manometry, and on that esophageal manometry you get a pressure of more than 120 millimeters of mercury. In diffuse esophageal spasm, on the manometry the pressure is going to exceed more than 120 millimeters of mercury, and the treatment is myotomy surgery again. The treatment has to be the myotomy surgery. Okay? Hopefully clear. Chalo. Next important is a case. We are having question number 25 says we are having an elderly patient who was diagnosed with a carcinoma in the periampullary region, beta, along with a mass which was arising from antrum of the stomach. So actually a mass is arising from antrum of the stomach, beta, but there was also a cancer which is basically extending up to the periampullary region now. The PET scan was done, which reveals there are few metastatic cells in the left lobe of the liver. So that means the cancer has spread, or the cancer has already metastasized to the liver, beta. Now they're asking you what shall be done to manage this case. Now this is some uncommon question which can come rarely in the examination, but this was just basically to see, even if you don't know the answer directly, are you able to rule out the options or not. So read the options and please carefully tell me what is going to be the answer. What do you think? What is the most probable answer in this question? Let me know in the chat box. Option A says pylorus preserving pancreaticoduodenectomy, that is a modified Whipple surgery, beta, or the Longmire and the Traverso surgery. Second, option B says gastrectomy with a left hepatectomy, beta. Option C says Whipple's procedure, that is a pancreaticoduodenectomy that we do. And option D says palliative gastrojejunostomy and chemotherapy, beta. So what is going to be your answer? So do remember, beta, this is definitely a case of a periampullary cancer, but it is not only a periampullary cancer, it is a metastatic periampullary cancer. Okay? It is not only a periampullary cancer. What are periampullary cancers? Any cancer which occur in the 2 centimeter range, beta, of the ampulla of Vater. Any cancer that arises basically in the 2 centimeter range of ampulla of Vater, beta, then we basically call it as the periampullary cancer or periampullary carcinoma. Periampullary cancer can arise from the head of pancreas. Periampullary cancer can arise from the duodenum, or periampullary cancer, beta, may arise from the common bile duct. So from the pancreas, from the duodenum, or from the common bile duct, beta, you can have a periampullary cancer. Now here definitely it was a carcinoma in the periampullary region, as they have said, and that was a mass arising from the stomach also, and metastatic cells were seen in the left lobe of liver. And as soon as they said metastatic cells are seen in left lobe of liver, our diagnosis changed from only periampullary cancer to metastatic periampullary cancer. And we know whenever the cancer has gone outside the organ, beta, then definitely doing a surgery is not a very good or a very feasible option. Whenever there is spread or metastasis, I've told you surgery is not going to be a very good option, because if the cancer has spread, even if you do any surgery, beta, you will not be able to remove the whole cancer from the body now. Clear? So what is the care that we do, or what is the treatment that we do? Let me know. So if it was only a case of periambulary cancer, my answer would have been definitely nothing else but this surgery beta. And this is the classical Whipple's surgery or the Whipple's procedure that we do beta. This was the previous year image based question. So the question was, what is the procedure performed in the below given image? And this image was asked in the PYQ. So this is a classical picture of the Whipple's procedure or the Whipple's surgery. And do remember, Whipple's surgery is a pancreaticoduodenectomy done in a case of periambulary cancer or carcinoma in the head of pancreas beta. Here what we remove? We remove the head and neck of pancreas. We also remove the duodenum. We also remove the common bile duct, and we remove the gallbladder along with the cystic duct. And after removing all these structures, then we have to make 3 anastomosis beta. The 3 anastomosis that we make in Whipple's surgery. One is basically the PJ stomy or a pancreaticojejunostomy. Second important is the GJ stomy, that is a gastrojejunostomy. And third is the HJ stomy, that is hepaticojejunostomy. Clear? And in cases of Whipple's surgery, these 3 anastomosis are done beta. And they should be done in which sequence? The anastomosis are always done in this sequence. Pancreaticojejunostomy followed by gastrojejunostomy followed by hepaticojejunostomy. That means the one which is going to be most dangerous, that anastomosis has to be done first beta. So which is most dangerous? The pancreatic enzymes like lipase and amylase are most dangerous. If these pancreatic enzymes like lipase will get leaked inside the abdominal or peritoneal cavity, they will damage the fat tissue. Therefore, do a pancreaticojejunostomy first. Second most dangerous is acid. So after doing a pancreaticojejunostomy, immediately do a gastrojejunostomy beta. So acid will not leak. And last one will be the hepaticojejunostomy, because bile is comparatively going to cause less damage as compared to the pancreatic lipase or the acid beta. That is what is important to be remembered. Clear? So this is the sequence. Do you remember one more point about Whipple's surgery or pancreaticoduodenectomy, and that is, what is the most common complication of Whipple's surgery? The most common complication of Whipple's surgery is a impaired gastric emptying or a gastric stasis beta. This is also important question. So the patient has poor gastric emptying or impaired gastric emptying. That is, food is not able to go properly from the stomach to the jejunum beta. Okay, so there will be impaired gastric emptying after the Whipple's surgery, which is the most common complication. And most common cause of death mein, if they ask you the cause of death overall, then the answer is going to be the cardiovascular complications. Okay, if they ask you what is the most common cause of death overall, then the answer can be the cardiovascular complications beta. But if they ask you what is the procedure specific complication which can lead to death, the procedure specific complication or the complication due to Whipple's surgery which can cause death is known as anastomotic leak. We know so many anastomosis we are making beta. The procedure specific complication which can lead to death, if they ask you, answer has to be anastomotic leak beta. That is important. Okay. So we know Whipple's surgery would have been done if definitely the patient was having carcinoma in the head of pancreas beta. Okay, if there was a carcinoma in head of pancreas, or there was a periambulary cancer, but a non-metastatic periambulary cancer, then definitely my answer would have definitely been option C, that is Whipple's surgery. So Whipple's surgery too is out from the options now. It cannot be done in this scenario. Next important now, if I talk about the option beta, we know palliative care is given whenever the cancer spreads or cancer metastasizes outside the organ. That's the reason the best answer has to be option D beta. That is a palliative gastrojejunostomy to be done along with chemotherapy. So do a palliative gastrojejunostomy, okay, along with the chemotherapy. That is what is treatment. Okay. Hepatectomy is also not going to help us beta to completely remove the cancer from the body. So it's better to go for palliative gastrojejunostomy and chemotherapy. So done with this. This was an uncommon question, I agree. So that definitely you are used to even solving these kind of questions beta. Okay. Next important is the question number 26, which states, we are having a 60-year-old male who presents to you with complaints of chronic progressive abdominal distension along with recent onset hiccups. On inquiry, he is neither passing flatus nor passing stools beta. Okay, so no passage of flatus is known as obstipation and no passage of stools is known as constipation beta. X-ray shows there are dilated loop of bowel with 2 fluid levels which are seen. Whenever a patient is having bowel obstruction beta, patient will have features like constipation, obstipation, and the dilated or distended bowel loops on X-ray abdo or air fluid levels on the X-ray abdo. Now they're asking what shall be the most likely management of the patient. So pehle to do remember all these features which are there, like a progressive abdominal distension along with the constipation and obstipation like features and dilated loop of bowel. All of these are definitely in favor of a case of bowel obstruction beta. Now it is which type of bowel obstruction that we have to see. They have mentioned only two air fluid levels beta or two fluid levels. Okay? So do remember, if they have only mentioned two fluid levels beta, that means this is how the fluid levels are going to be seen on the X-ray abdomen. Now, what is basically this appearance? That please tell me in the chat box. Patient is having features of bowel obstruction like abdominal distension, constipation, obstipation. Okay. And this is the classical picture seen on X-ray abdo. So you can see these are the two fluid levels that are seen beta. And these two fluid levels which are seen, they are giving us a very classical appearance called as the coffee bean sign. So we know beta the X-ray abdomen gives you the classical coffee bean sign. Okay? So either they can say coffee bean sign directly or they can say two fluid levels were seen on the X-ray abdo. And we know these are the classical feature of nothing else but a sigmoid volvulus, right? So whenever coffee bean sign is seen on X-ray abdomen or the two fluid levels are seen on the X-ray abdomen, we know definitely it is a case of sigmoid volvulus beta. So the provisional diagnosis in this condition is going to be sigmoid volvulus. And we all know sigmoid volvulus means the sigmoid colon which is there beta, it is basically twisted or it is going to be malrotated. So whenever there is going to be a twisting or malrotation of the sigmoid colon, that is classically known as sigmoid volvulus. That is what is important to be remembered. Okay, twisting or malrotation of the sigmoid colon is known as sigmoid volvulus beta. That has to be remembered. Now, if they ask you if it is a case of sigmoid volvulus, we know X-ray is only the first line investigation. It cannot confirm the diagnosis. So then later on, to confirm the diagnosis, we have to do a CCT abdomen beta. So if they would have asked me what should be the next best step, then my answer would have been definitely CCT abdomen or a contrast and CT scan of abdomen beta to confirm my diagnosis. But they have not asked you about the next best step. Now they are asking you what is the most likely management, final management. Any which way CCT abdomen is not even an option. Okay? So in this condition beta, we will do a CCT abdomen, and after that, once the diagnosis of sigmoid volvulus is confirmed, then what we do in emergency, understand. In emergency beta, we have to do a sigmoidoscopic decompression. That is, insert a sigmoidoscope in the colon beta, and once you have inserted the sigmoidoscope, then the gas will be released and that will cause decompression of the bowel or decompression of the sigmoid colon. Once you have done a sigmoidoscopic decompression, followed by that, then you better go for a sigmoidectomy beta over sigmoidopexy. Yes, I can do a sigmoidopexy also, but the problem is sigmoidopexy, that is fixation of sigmoid colon, will have a risk of recurrence. Even after sigmoidopexy beta, do remember the patient will have a risk of recurrence. So it's better that we go for a sigmoidectomy beta. Okay, so if you do a sigmoidectomy, then there will be no risk of recurrence at all beta. That is a better surgery which is preferred commonly for a case of sigmoid volvulus. So as they are asking you about the final treatment or final management, then the answer has to be option D, that is nothing else but sigmoidectomy to be done beta. Clear? Now Hartmann's procedure or Hartmann surgery is what? Hartmann's procedure is we do an exploratory laparotomy along with peritoneal lavage, along with sigmoidectomy, along with proximal colostomy for a few days. And once the inflammation has resolved in the peritoneal cavity, then we go for a delayed anastomosis beta. That is known as a Hartmann surgery. The exploratory laparotomy plus peritoneal lavage plus sigmoidectomy and a delayed anastomosis beta. Clear? So do remember definitely this is known as Hartmann's procedure, but Hartmann's procedure is only done in a complicated case of sigmoid volvulus. That is, if the patient would have presented to us with strangulated or a perforated sigmoid volvulus beta, then the treatment would have been definitely option B, that is nothing else but Hartmann's surgery or the Hartmann's procedure. If it was a case of a strangulated or a perforated sigmoid volvulus. Understood now? Got the answer? Okay? Cecal derotation is usually done in a case of cecal volvulus. Okay, cecal derotation is done for cecal volvulus. But do remember, in cases of cecal volvulus, you don't have two fluid levels on the X-ray. You only have one fluid level on the X-ray, beta. That is what is important. How? This is the picture. Can you see? Here there is only one fluid level which is usually found on the X-ray. And as there is only one fluid level on the X-ray, beta, okay, so only one fluid level is basically seen on the X-ray, and that is a classical case of cecal volvulus. And cecal volvulus hota, then my treatment would have been option A, that is cecal derotation, beta. Hopefully clear. So that is what is important. Conservative management is done for bowel obstruction, beta. But in cases of sigmoid volvulus, even if you do conservative management, the patient's condition is not going to improve. So in other conditions of bowel obstruction, conservative management is definitely done. But in sigmoid volvulus, it is not very useful. Clear? That is important. And here in sigmoid volvulus itself, when you do the barium enema, you are able to see narrowing of the sigmoid colon, beta. And this narrowing of the sigmoid colon gives you a very classical appearance called as the bird beak appearance, also called as the bird of prey sign. So bird beak appearance, bird of prey sign on the barium enema is a feature of sigmoid volvulus. So bird beak appearance on barium swallow, achalasia cardia. Bird beak appearance on barium enema, sigmoid volvulus, beta. Understood? So these are the features that you have to keep in mind. Next, another is a favorite question from biochemistry and surgery of your FMGE examiners, beta. A 45-year-old patient or a 45-year-old man with recurrent peptic ulcers has undergone a truncal vagotomy along with antrectomy, okay, with Bilrod 2 surgery. So Bilrod 2 is nothing else but a gastrojejunostomy, beta. So obviously, as you are doing a antrectomy or as you are removing the antrum and pylorus of the stomach, you may have to do a gastrojejunostomy, that is Bilrod 2 surgery. And this was done for a case of gastric outlet obstruction. 5 weeks later, the patient complains of dizziness, palpitations, and diaphoresis, beta. Which among the following will be the best initial management strategy in this patient? What is the provisional diagnosis of this question? Let me know in the chat box. First, tell me the provisional diagnosis. Patient has undergone the peptic ulcer surgeries, beta, like vagotomy, antrectomy, or the Bilrod 2 surgery. And after this, the patient is having these kind of symptoms. What is your provisional diagnosis? It is with syndrome. It is a complication of peptic ulcer surgery, that I can tell you. But which complication of peptic ulcer surgery is it? With the symptoms given below. What is the complication of peptic ulcer surgery which presents like this? I hope all of you are quite aware. Very good. Shabash. It is a provisional diagnosis of nothing else but dumping syndrome, beta. Yes, it is a classical diagnosis of nothing else but dumping syndrome. Now, if I talk about dumping syndrome, dumping syndrome is going to have two things. Either it could be a case of early dumping syndrome or it could be a case of late dumping syndrome. I'll just tell you easily how to differentiate whether it is a early dumping or a late dumping in a clinical case scenario without wasting a lot of time in the mechanism part. Do remember, early dumping syndrome, if it is there, then the patient comes to you, okay, with symptoms like sorry, as there is rapid influx of fluid inside the bowel, the patient comes to you with symptoms like epigastric fullness, epigastric pain. Okay, the patient is going to have symptoms like epigastric fullness, epigastric pain, along with vomiting, okay, and bloating, beta, along with features like vomiting and bloating. So these symptoms are going to develop, do remember, beta, within 10 to 15 minutes of food intake or maximum within half an hour of food intake. So usually around 10 to 15 minutes after food, usually 10 to 15 minutes after food, if the patient is going to have these kind of symptoms, beta, always remember it is a classical diagnosis of early dumping syndrome. Hopefully clear. Second, in cases of late dumping syndrome, the patient is actually going to develop rebound hypoglycemia, and due to the rebound hypoglycemia, beta, the patient develops all the hypoglycemic symptoms, symptoms like dizziness, along with headache, along with palpitations, along with tremors. Okay? So dizziness, headache, palpitations, tremors, that is nothing else but all the symptoms of hypoglycemia beta. So hypoglycemic symptoms, and these symptoms are usually going to develop बच्चे 45 minutes to 1 hour after food intake. They are not going to develop immediately. They are going to develop 45 minutes to 1 hour after food intake, and therefore we basically call it as a case of late dumping syndrome beta. Okay, therefore we classically call it as a case of late dumping syndrome. यहाँ पे they have said the patient has undergone a peptic ulcer surgery and is having the symptoms like dizziness, palpitations, diaphoresis. So due to the symptoms, dizziness, palpitations, diaphoresis, we know it is more commonly a case of late dumping syndrome beta. That is what is important to be remembered. Now, if the patient is having dumping syndrome, please tell me what is going to be your initial best management strategy. What should be your best initial management strategy beta? Let me know in the chat box. Late dumping syndrome now. Dizziness, palpitations, diaphoresis are there. Obviously, hypoglycemic symptoms means late dumping syndrome. So they are asking you what is the best initial management strategy beta. So in this condition, you can start a IV dextrose infusion beta, but here definitely the patient is only having dizziness, palpitations, diaphoresis. So even if you give oral glucose to the patient, still the patient's condition is going to resolve. Then you don't need a IV dextrose infusion immediately. Just give some dietary advice and counseling to the patient beta. Okay, you can definitely, if the option was, one of the option was check the random blood glucose of the patient, that would have been my answer. Yes, if one of the option was check random blood glucose of the patient, that would have been my answer. And if there was a severe hypoglycemia, I would have definitely started on IV 5% dextrose infusion beta. Okay, but here there is no such option. Therefore, you can just mark it as option B. That is a dietary advice and counseling has to be given. And what is dietary advice or counseling in this patient beta? Do remember one point, whether it is a case of early dumping syndrome or a late dumping syndrome beta, whether it is an early dumping or a late dumping syndrome. In this condition, the advice that we give is going to be same. It is nothing else but avoid the large meals or hyperosmolar food beta. Don't take a lot of food at single time. So avoid large meals, avoid hyperosmolar food means highly concentrated food or sugary food beta. Okay? Or also avoid basically beta plenty of fluids with food. Also avoid excess amount of fluids along with food basically beta. That is what is important. Okay? These are the things that the patient has to avoid. Apart from that, you can advise the patient to take small frequent meals. You can definitely ask the patient to take some small frequent meals rather than taking large meals at a time. You will advise the patient to take small and frequent meals beta. Okay? So avoid large meals, avoid hyperosmolar food, avoid excessive fluids with food, and advise small frequent meals basically in the patient. Do remember, preparation for revision 2 Roux-en-Y gastrojejunostomy is not done immediately. In case beta, if the patient is given or advised dietary modification, still after that the patient's condition does not improve, you can use IV octreotide, which is a somatostatin analog. So octreotide can help in the dumping syndrome. If octreotide also does not help, then the answer is converting this Billroth surgery to the Roux-en-Y gastrojejunostomy beta. Clear? Work up to rule out recurrence. It is not a case of recurrence. Do remember beta, IV is definitely best, but if there is a severe hypoglycemia which is seen, so for that definitely beta, you have to check the patient's random blood glucose, and here definitely dizziness is there. So dizziness can be seen even in mild hypoglycemia, not necessarily it is going to be always a severe hypoglycemia. If you should give a oral glucose also, the patient's condition is resolved. Why you need to give IV glucose? Even oral glucose, if you give, still the patient's condition will be resolved. Then why you need oral IV glucose in the patient? Hopefully clear hai baat. So do remember, that is the reason definitely. Oral glucose also, if it is helping to resolve the patient's condition, why you need definitely to give IV glucose in the patient. Hopefully clear. So that is important. Here you can see definitely these are the various types of peptic ulcer surgeries beta. One is nothing else but the gastrojejunostomy beta. That is nothing else but the Billroth 1 surgery that you are able to see. Okay, so gastroduodenostomy, sorry. So gastroduodenostomy which is there beta, it is going to be the Billroth 1 surgery. So you do a antrectomy, followed by which you do a gastroduodenostomy, that is your Billroth 1 surgery. Second is your gastrojejenostomy, and that gastrojejenostomy is known as your Billroth 2 surgery. So after antrectomy, if you do a gastrojejenostomy, that is going to be your Billroth 2 surgery beta. And third one, if you are able to see, is basically the Roux-en-Y gastrojejenostomy that you are able to see in the picture. The third one is the Roux-en-Y gastrojejenostomy beta, which is seen. Roux-en-Y mein there are two anastomosis that we make. One is the gastrojejenostomy that we do, and second is the jejunojejenostomy that we do. One is the gastrojejenostomy, second is the jejunojejenostomy beta that can be done. Hopefully clear. Next important is a question, that is question number 28. If they say we are having a 48-year-old female beta who presents to you with slow growing breast lump, which is around 5 by 6 centimeters in size, which is slightly mobile. On examination beta, there is a bosselated appearance and some skin color changes which are noticed or which are noted beta. Okay? True cut biopsy was done and the histopathological examination has been given below. What is the most probable diagnosis in the patient? What is going to be answer? So there is a 40-year-old female with a slow growing breast lump around 5 by 6 centimeters in size. The tumor is slightly mobile beta. It is having a bosselated appearance along with some skin color changes as well. Okay? And the histopath is given below. What is the most probable diagnosis? Please tell me the provisional diagnosis. Anybody? The provisional diagnosis of this condition. Very good. It is a classical case of nothing else but pyeloid tumor. Yaad rakhna ye baat. That is what is important beta. We know answer has to be option C for this question. That is nothing else but cystosarcoma pyeloids or pyeloid tumor. Why? Because pyeloid tumor is usually a giant tumor. Yes, commonly pyeloid tumor is a rapidly growing tumor, but sometimes it can be a slow growing tumor also beta. Do remember this. Second, pyeloid tumor, if it is benign in nature, it is not only slow growing, but it can be slightly mobile as well, because benign pyeloid tumor will never invade the pectoral fascia. Therefore, it will be slightly mobile. Yes, it is not freely mobile like a fibroadenoma, but it is slightly mobile that you are able to see. Bosselated appearance and skin color changes are seen in patients of pyeloid tumor beta, because pyeloid tumor is going to cause pressure necrosis that basically leads to the skin color changes in a case of pyeloid tumor. And what confirms the diagnosis is the classical histopathological examination. On this histopathological examination beta, you are classically able to see the leaf-like structures. And whenever the histopath shows you the classical leaf-like structures beta, we know it is a sure shot diagnosis of nothing else but a pyeloid tumor, also known as cystosarcoma pyeloids beta. Hopefully clear. Now do remember, if it is a case of benign pyeloid tumor beta, if it is a case of benign pyeloid tumor, then definitely the treatment is going to be a wide local excision. If it is a case of benign pyeloid tumor, my treatment is definitely going to be a wide local excision beta. That has to be remembered. But if it is a case of malignant pyeloid tumor, or if it is a case of a recurrent pyeloid tumor, or if it is a case of large or a giant pyeloid tumor. So in case if it is a malignant pyeloids, recurrent pyeloids, or large or giant pyeloids, then please tell me, treatment will be a simple mastectomy or a modified radical mastectomy. Then the treatment would be a simple mastectomy or a modified radical mastectomy. Let me know in the chat box. Malignant pyeloids mein the treatment is simple mastectomy or a modified radical mastectomy. Anybody? Please let me know in the chat box. It does not matter. The answer to this question is nothing else but a simple mastectomy beta. That is what is important. The management of even a malignant pyeloids is going to be a simple mastectomy. And you will be like, why? Because do remember, pyeloids does not spread via the lymphatic route. There is no lymphatic metastasis seen in pyeloid tumor. As there is no lymphatic metastasis in pyeloid tumor, I don't need to remove the lymph nodes or axillary lymph nodes in cases of pyeloid tumor. I'll just do a simple mastectomy even if the pyeloids is malignant in nature. Hopefully clear. So benign pyeloids goes for a wide local excision, but malignant pyeloids goes for a simple mastectomy beta. That is what is important to be remembered. Hopefully clear. Next important, if they ask you beta about the other conditions, do remember invasive lobular carcinoma does not show any kind of leaf-like appearances beta on the histopath. Okay, do remember invasive lobular carcinoma classically shows you the single file pattern or the Indian file pattern on histopath where malignant cells are arranged one behind another. Clear. Next important is invasive ductal carcinoma also does not show this kind of leaf-like structures beta. And fibroadenoma, if I talk about, so first of all, fibroadenoma can be seen in 40-year-old females, but it is uncommon. More commonly, fibroadenoma, which is the most common benign tumor of breast. So this most common benign tumor of breast or fibroadenoma, it is more commonly seen in very young females around 15 to 25 years of age beta. More common in young females around 15 to 25 years of age. Patient comes to you with the complaint of freely mobile rather. The patient comes to you with complaints of beta, a freely mobile, painless, firm lump beta. The patient comes to you with complaints of freely mobile, painless lump. Reason is if the patient is having freely mobile lump beta, therefore we call this fibroadenoma as breast mouse. As there is a freely mobile lump beta, we call this fibroadenoma also as breast mouse beta. That is what is classically important to be remembered. Clear? In cases of fibroadenoma, investigation of choice is only a ultrasound beta mostly. In majority cases of fibroadenoma, investigation of choice is only ultrasound. Very few cases we may have to go for a FNSE or a true cut biopsy. In very few cases, we may have to go for FNSE or a true cut biopsy. And what is the reason? Reason is when you do an ultrasound of the breast beta, you get a BI-RADS score. In fibroadenoma, the BI-RADS score is mostly 2 or 3 beta. In fibroadenomas, mostly the BI-RADS score is 2 or 3. And what is the next step? BI-RADS 2 mein, we just go for routine screening or a routine follow-up after every 1 year. No FNSE. In BI-RADS 3, we do a short interval screening or a short interval follow-up after every 6 months. No FNSE. So BI-RADS 2 or 3 mein, we only go for a routine or a short interval screening. No FNSE is done. Yes, only if the BI-RADS score is high, like BI-RADS 4 or BI-RADS 5, then we go for FNSE beta. That is what is important to be remembered. No issues with this. Now, in cases of fibroadenoma, majority cases mein the treatment is just observation beta. In majority cases of fibroadenoma, the treatment is nothing else but observation and a follow-up. Follow-up timing depends on the BI-RADS score. Okay. But in some conditions, basically beta, we may go for a surgery or a surgical excision. Now, very few cases where you go for a surgery or surgical excision. The most common indication of surgical excision of fibroadenoma is cosmetic. That was a PYQ and FMGE exam. Most common indication for removal of fibroadenoma is cosmetic beta. Okay. Whereas other indications can be a giant fibroadenoma more than 5 centimeters in size, or a rapidly growing fibroadenoma, or if the fibroadenoma turns painful, or if the female is having positive family history for breast cancer. Clear? In these conditions only you do a surgical excision. In cases of fibroadenoma, you are able to see there is excess fibrous tissue or excess fibrous trauma in the histopath, and due to that excess fibrous trauma beta, you can see there is going to be compression of the glandular structures, and these glandular structures which are compressed, they are giving us a very classical sign known as the antler sign. This was also histopath in a PYQ of FMG. So antler sign on histopath is a classical finding seen in patients of fibroadenoma beta. Okay? So that is what is important to be remembered. Next important, if I talk about, is nothing else but question number 29. Now when I talk about question number 29 beta, here the question is, a patient comes to you with complaints of a long-standing abdominal pain along with icterus, that is nothing else but jaundice, and the patient was diagnosed with hydrated cyst. They are asking you, CCT abdomen has been given below. As per the Garbi's classification beta of the given cyst, the given cyst will be classified under which type of Garbi's? That was the PYQ also in the NEET PG examination once beta. So you have to be aware of this. No issues with this? Understood? So if they ask you, the patient is having abdominal pain and icterus and he was diagnosed with hydrated cyst. And for hydrated cyst, we know there are two classifications. One is the Garbi's classification and the newer one is the WHO classification beta. Now, if I talk about the picture, the CCT abdomen shows me a classical feature, and that is nothing else but you can see a detached membrane beta, and that detached membrane is floating inside the fluid, giving us a very classical appearance called as the water lily sign, also called as the serpent sign beta. So you are able to see the classical water lily sign or serpent sign beta on the CCT abdomen. That is basically due to detached membrane. Now let's see the Garbis or the WHO classification once. First of all, Garbis type 1 or WHO CE, sorry, Garbis type 1 or WHO stage CE1, which is there, it is going to be an unequivocal fertile cyst beta. That is, there is a single cyst, okay, which is only going to contain fluid, nothing special inside it, okay, single fluid filled cyst. Next important is Garbis type 2, that is the WHO stage CE3E beta, CE3 beta, and in this you are able to see the detached membranes, okay, that is suggestive of a fertile cyst. The detached membranes are seen beta, which is giving you a classical water lily sign or the serpent sign in the appearance. Next is going to be Garbis type 3, also known as the WHO CE stage 2, and in this you can see beta, there are multiple daughter vesicles that are going to be seen. If you are able to see multiple daughter vesicles inside the cyst, that is Garbis type 3 or WHO stage CE2 beta. Next is Garbis type 4 or WHO stage CE4 beta. So WHO type 4 or the Garbis type 4, both of them is actually going to show you a heterogeneous cyst basically. That means some solid and cystic areas will be seen inside the cyst beta. So therefore it is going to be called as the WHO type 4 or Garbis type 4. And last is Garbis type 5 and WHO stage CE5 again. In this condition, you are able to see a completely calcified cyst or an inactive cyst beta. That is important. At least remember this stage, and that is very, very important. Okay. So do remember, if there is a detached membrane or there is water lily sign, it is nothing else but the Garbis type 2 beta, or it is going to be nothing else but the WHO stage or WHO type CE3A. It is going to be the WHO stage or WHO type CE3A beta. That is important to be remembered. Hopefully clear to all of you now. That was a straightforward answer, nothing much to be thought of. And we know in cases of hydrated cyst, if they ask you what is the causative organism, we know hydrated cyst is basically due to a dog tapeworm beta, and that dog tapeworm is nothing else but Echinococcus granulosus beta. It is basically due to an organism known as Echinococcus granulosus, also called as dog tapeworm. In cases of hydrated cyst, we all know, yes, somebody rightly mentioned. Do remember, if they ask you what is the investigation of choice? So radiological investigation of choice for hydrated cyst, if you ask me, radiological investigation of choice for hydrated cyst has to be a CECT abdomen. If the patient is a child, then you can only do an ultrasound abdomen. So CCT or ultrasound abdomen, depending on the age, will be the radiological investigation of choice. But which is the best investigation or the gold standard investigation overall to confirm the diagnosis of hydrated cyst or to confirm the diagnosis of echinococcus infection? Answer is going to be ELISA or immunoblot. So ELISA or immunoblot is going to be the best investigation or the gold standard investigation to confirm the diagnosis of echinococcus infection. And treatment, we all know beta, it is nothing else but you have to give albendazole to the patient. Along with that, you have to perform the pair therapy. You give albendazole to the patient beta, and along with that, do a pair therapy, that is percutaneous aspiration, injection of scolicidal agents and reaspiration. Percutaneous aspiration, injection of scolicidal agents and reaspiration. Now, if this is the picture beta, then what is the causative agent? This is also a case of hydrated cyst, but here it is not a single hydrated cyst but multiple hydrated cysts which are present. So if there are multiple hydrated cysts beta which are usually found inside the liver, if there are multiple hydrated cysts which are usually found inside the liver, then what is the causative agent? Please tell me beta. Then what is the causative agent? Then it is due to an organism known as echinococcus. Then it is due to a causative agent classically known as echinococcus PYQ PYT. Same picture was given of CCT abdomen with multiple hydrated cysts beta, and then the causative agent was asked. Yes, it is giving you the classical honeycomb appearance. So when multiple cysts give you honeycomb appearance on CCT abdomen, then what is the causative agent? Echinococcus multilocularis and not Echinococcus granulosus. Do remember, It is Echinococcus multilocularis and not Echinococcus granulosus. That is very, very important to be remembered. Hopefully clear. Yes. And treatment in cases of multiple hydrated cyst, we don't go for a pair therapy beta. We better do a liver resection. It is not practically possible to go for pair therapy for each and every cyst. So it's better that we definitely go for a liver resection in the patient beta. The part of the liver has to be removed which has multiple hydrated cyst beta. Hopefully clear. Next important is question number 30. Easy question it is. And that is, we are having an elderly patient beta who suffered from burns, and on assessment 10% first degree burns are seen beta, 20% second degree burns are seen, and 10% full thickness burns are seen. Full thickness burns are usually the third and fourth degree burns. Clear? Now they are asking you, weight of the patient is around 60 kg beta. BP of the patient is 100 by 60 millimeters of mercury. Pulse rate of the patient is 110 beats per minute. They are asking you how much amount of fluid shall be given to this patient beta while the resuscitation is going on using the ATLS formula. In the patient of burns beta, initially we give more fluid, okay, because the patient is at a high risk of hypovolemia beta. That is what is important to be remembered. Now please calculate the amount of fluid to be given in this patient in the first 24 hours, but using the ATLS formula. So I hope all of you are quite aware that ATLS formula is not going to be the same beta for an adult or a child. So if the patient is going to be an adult, then the ATLS formula is 2 into body weight into total body surface area of burns beta. Whereas if there is a child who is basically less than 14 years of age, there is a child who is less than equal to 14 years of age, then we use the formula 3 into body weight into total body surface area of burns. Whereas if the patient is suffering from electrical burns beta, if the patient is having electrical burns, then the ATLS formula changes. It becomes 4 into body weight into total body surface area of burns beta. Hopefully clear to all of you now. So that is what is important to be remembered. Understood? Now Parkland's formula, if they ask you, then Parkland's may we use the multiplier as 4 into body weight into total body surface area of burns, irrespective of whether the patient is an adult or a child. In Parkland's the multiplier is always 4. Clear? So this is the ATLS formula. Now if I want to calculate, so we know they have said that the patient is elderly. So obviously you have to use the formula that is for an adult 2 into body weight into total body surface area of burns beta. Now when I use this adult formula of 2 into body weight into total body surface area of burns, then please calculate how much will be the total amount of fluid in this patient needed. They have said the weight of the patient is 60 kilogram and the total body surface area of burns we have to calculate now. So do remember the amount of fluid that is needed in the patient to be given in the first 24 hours beta is going to be calculated according to 2 into body weight into total body surface area of burns. So here the body weight of the patient, we know it is 60 kg, but how much is the total body surface area of burns to calculate the fluid? So they have said 10% first degree burns, next 20% second degree burns, and 10% full thickness burns. So how much should be the total body surface area of burns that you are going to take in the formula? Please let me know in the chat box. How much is the total body surface area of burns we are going to take in the formula? We will not take 40%. Reason is first degree burns are not considered while we are actually calculating the amount of fluid needed for the fluid resuscitation. Whenever we are calculating the amount of fluid needed in a patient beta. So no, first degree burns are not considered when you basically calculate beta the amount of fluid that is needed in a patient of burns. So you calculate the 20% second degree burns and the 10% full thickness burns. So that is going to be around 30%. Clear? So basically it is 260. So it is going to be 3600 ml beta, right? So the total amount of fluid that has to be given in the patient in the first 24 hours, it is going to be 3600 ml. Out of this, half fluid, that is going to be 1800 ml beta, that should be given in the first 8 hours. So half fluid which is there that is the 1800 ml, that should be given in the first 8 hours to the patient. But the remaining half fluid, that is the other 1800 ml beta, that should be given to the patient in the next 16 hours. So in next 16 hours, you have to give the remaining half fluid, that is 1800 ml. So here definitely they have only said how much amount of fluid should be given. They did not mention the first 8 hours or next 16 hours, nothing like that. You have to tell the amount of fluid for the total 24 hours, and that has to be option B, that is nothing else but 3600 ml. If Parkland's formula would have been used, that is 4 multiplier, then the answer would have been come out to option A, that is 7200 ml beta. Clear about that is what is important. Or if they would have asked only for the first 8 hours how much fluid should be given, then the answer would have been option C, that is 1800 ml. Hopefully clear. That is what is important to be remembered. We know whenever we have to calculate the total body surface area of burns in adults, we basically use the Wallace's rule of 9 beta. To calculate the total body surface area of burns in adults, we tend to use the classical Wallace's rule of 9. And according to the Wallace's rule of 9 beta, all the body parts in the patient is going to be 9% except the genitalia and perineum. We know all the body parts of the patient will be 9% except the genitalia and perineum. We know genitalia and perineum is an exception, which is going to be 1%. Rest all the body parts are going to be 9%. That is, the head and neck of the patient is 9%. The chest of the patient is 9%. Upper back is 9%. The anterior abdomen of the patient is 9%. Lower back is 9%. Next, one upper limb anteriorly it is 4.5%. One upper limb anteriorly it is 4.5% and posteriorly it is 4.5%. That means so anterior upper limb 4.5, posterior upper limb 4.5. So one upper limb completely is 9% again. Next, one lower limb anteriorly it is 9% and posteriorly it is 9%. So one lower limb completely anterior plus posterior is 18%. One lower limb anterior 9, posterior 9. So one lower limb completely it is going to be around 18% beta. That is what is important to be remembered. Hopefully clear. Next is a question that says beta, we are having a 20-year-old male who presents to you with complaints of severe pain in the right-sided scrotum, and he was referred, the patient was referred to the abdomen beta. The patient is a 20-year-old male having a severe pain in the right-sided scrotum, referred to the abdomen, along with features like fever and vomiting. The scrotum on the right side appears to be swollen beta and it appears to be higher than normal. What shall be the next best step in this condition? Another common question that is sent to me on a repetitive and a regular basis is this, where a lot of people tend to get confused. What is the provisional diagnosis of this case? Let me know in the chat box. What is the provisional diagnosis of this case? What is the provisional diagnosis of this case? Anybody? What is the provisional diagnosis of the case? A young adult male between 10 to 50, a young adult male between 10 to 40, 25 years of age beta, coming to you with severe scrotal pain referred to the abdomen along with vomiting, fever and scrotal swelling like features. Has to be a case of testicular torsion beta. It has to be a case of nothing else but testicular torsion. Hopefully clear. It is going to be a classical case of testicular torsion. हमें पता है that testicular torsion is nothing else but when the testis or when the spermatic cord gets twisted or malrotated beta, due to which there is decreased blood supply to the testis. That is known as a case of testicular torsion beta. That is what is important. So severe pain in the right sided scrotum along with fever, vomiting, and the scrotum appears to be swollen, and a keyword, the scrotum appears higher than normal. So if the scrotum appears higher than normal, that is a keyword for a case of testicular torsion beta. Clear? Epididymoarchitis is a very close differential of this case. Yes, epididymoarchitis is also seen in the same age group, also presents with same features like scrotal pain, abdominal pain, fever, vomiting, scrotal swelling beta. Okay, but in that condition, the testis is not higher than normal. Why the testis will be higher than normal in a case of epididymoarchitis? But still, if you are having a doubt, you can perform a clinical test beta, classically known as French test. So we know French test is nothing else but it is going to help us to differentiate between a case of testicular torsion and epididymoorchitis. Just remember, French test is going to be positive in cases of epididymoorchitis. Means when you support the scrotum or when you lift up the scrotum, the pain is relieved beta if the patient is suffering from a condition that is nothing else but epididymoorchitis beta. The pain will get relieved if the patient is suffering from a condition that is epididymoorchitis. But the French test will be negative or the pain is not relieved even after lifting the scrotum if it is a case of testicular torsion beta. Hopefully clear. So that is what is a classical clinical test which will be used beta to differentiate if you are having a doubt between a testicular torsion and the epididymoorchitis. So if they would have asked me what is the next step and French test was an option, I could have marked yes, French test could be done so that you can differentiate clinically whether it is epididymoorchitis or torsion beta. But here French test is not an option and they have asked you what should be the next best step. Yaad rakhna, in cases of testicular torsion, we don't wait. If you delay, that means there will be high risk of testicular necrosis. The next step is directly option C, that is a surgical exploration has to be started. Color Doppler can be done, but it is not a priority or it is not a condition that you have to always do a color Doppler. No. Reason is beta, more important is time is very crucial in managing a case of testicular torsion. If you delay your testicular torsion, if you delay your management in torsion beta, the necrosis is going to happen and then you will not be able to save the testis and you may have to go for an orchidectomy. I've always told you that torsion is usually a clinical diagnosis. Doppler is done to support your diagnosis. Clear about? So that is what is important to be remembered. The answer has to be option C, that is a surgical exploration. So color Doppler may or may not be done. It is not a priority. It is not a necessity to be done. Clear? So that is important. Orchidopexy, yes, when you do a surgical exploration and once you find the testis, then the definitive management is orchidopexy. But first start doing a surgical exploration beta. On surgical exploration, then you are going to definitely derotate the testis and you'll do orchidopexy. But condition is what? Condition is that your testis is viable. So when you do a testicular exploration or a scrotal exploration beta and you find that the testis is viable, then you go for an orchidopexy beta. But on scrotal exploration, if you find that the testis is non-viable or the testis has already undergone necrosis, then you better remove the testis beta, that is do an orchidectomy. If the testis is non-viable, in those conditions, it's better to remove the testis, that is do an orchidectomy beta in the patient. Hopefully clear? No issues with this? Sorry. So these are the important things that you have to remember. Clear hai? Next important, if I talk about, is question number 32, which states beta we are having a 54-year-old woman who presents to us with complaints of abdominal pain along with bilious vomiting beta. She had a history of abdominal hysterectomy 2 years back. Okay, auscultation of the abdomen reveals there are high-pitched bowel sounds. CECD abdomen is done, which shows there is air within the biliary tree or air within the bile ducts. What is the most probable diagnosis of this case? Please tell me. Options are gallstone ileus, second, adhesive bowel obstruction, third, systemic enterocolitis, fourth, paralytic ileus. There are total 40 questions, beta. So 8 questions are left. Some are easy, don't worry about them. What is the provisional diagnosis, anybody? Hopefully all of you are quite aware now. See, if the patient is having abdominal pain along with bilious vomiting like features, so we know it is a classical case of bowel obstruction, and high-pitched bowel sounds or hyperperistaltic bowel sounds are definitely suggestive that the patient is definitely having a bowel obstruction. But there are two types of bowel obstruction, beta, we all know. So bowel obstruction or intestinal obstruction is the diagnosis. Okay, and I've always told you bowel obstruction or intestinal obstruction will present to you with abdominal pain, abdominal distension, constipation, obstipation and vomiting. Either there can be a dynamic bowel obstruction. Dynamic bowel obstruction means there is some physical obstruction in the bowel, but the motility of the bowel is absolutely normal. And adynamic bowel obstruction means there is no physical obstruction in the bowel. The problem is the bowel is not motile or the bowel is not able to perform peristalsis beta. So do remember the most common cause of adynamic bowel obstruction which is there. It is nothing else but adhesions. The most common cause of adynamic bowel obstruction is going to be adhesions, beta. But most common cause of dynamic bowel obstruction is going to be adhesions. But most common cause of adynamic bowel obstruction is paralytic ileus, beta. Most common cause of adynamic bowel obstruction is paralytic ileus, means the bowel is not motile. Hopefully clear to all of you now. So with all the features which are given, my diagnosis is more likely to be a bowel obstruction, and that too a dynamic bowel obstruction. Reason is high pitched bowel sounds. Do remember abdominal pain and high pitched bowel sounds, they are only and only seen in a dynamic bowel obstruction. In dynamic bowel obstruction, as proximal to the obstruction there is a vigorous peristalsis, beta. Therefore patient has a colicky abdominal pain, or the patient will have a hyperperistaltic bowel sounds or high pitched bowel sounds. Pain and hyperperistaltic bowel sounds are not seen in adynamic bowel obstruction or paralytic ileus. Clear about? So do remember, in paralytic ileus, beta, there is going to be no abdominal pain and the patient will have no bowel sounds which will be there. Because there is no peristalsis only, how there will be bowel sounds on auscultation? Clear? So no pain and no bowel sounds are seen in case of paralytic ileus or adynamic bowel obstruction. So option D is any which way is ruled out for those who are confused with option D. Clear? Now, if they say adhesive bowel obstruction, we know, yes, after surgeries, beta, adhesive bowel obstruction can happen. Okay, but the problem is here it has been 2 years for the surgery. She has undergone an abdominal hysterectomy, but it has been 2 years for the surgery. After 2 years, there won't be adhesions. Adhesions are seen usually immediately, few days after the surgery, beta, not 2 years after surgery. So obviously option B, that is adhesive bowel obstruction, is again ruled out because it does not cause any adhesions after 2 years. Then we are left with gallstone ileus and ischemic enterocolitis. We know enterocolitis is an infection, beta. The patient may have other features like fever, diarrhea, etc. But here there are no other features like fever and diarrhea. So again, ischemic enterocolitis becomes less likely. So yes, the diagnosis is a dynamic bowel obstruction, but that dynamic bowel obstruction is due to a gallstone. And whenever a gallstone is going to cause a dynamic bowel obstruction, that condition is classically known as gallstone ileus. Okay. So dynamic bowel obstruction is basically seen. And why I confirm it is definitely a gallstone ileus? Reason, because of this classical feature that they have mentioned. There is air within the biliary tree, beta. And as soon as they mention air within the biliary tree, it is pneumobilia. And pneumobilia is a feature of gallstone ileus, beta. Clear about? So we know in cases of gallstone ileus, there is a classical triad called as the regular triad, beta. And what are the features of regular triad? First, you can see this shadow in the right iliac fossa or in the terminal ileum. This shadow in the right iliac fossa or the terminal ileum is the gallstone, beta. So you can find the gallstone in the terminal ileum or right iliac fossa. Second important, there are going to be multiple air fluid levels, beta. And these multiple air fluid levels are usually suggestive of small bowel obstruction. So there are multiple air fluid levels suggestive of small bowel obstruction, beta. And third important is this picture over here. What is this? This is basically air or gas inside the gallbladder. And air or gas inside the gallbladder is classically known as pneumobilia. Air or gas inside the gallbladder is known as pneumobilia. So whenever these three features are present, gallstone in right iliac fossa, small bowel obstruction, and pneumobilia, this is the classical regular triad, beta. And always remember that the classical regular triad is a feature of gallstone ileus, which has been a question in the FMGE examination earlier. It is a feature of nothing else but the gallstone ileus, beta. Hopefully clear to all of you now. So these are the points that you have to keep in mind. Okay, chalo. Done. Next important, if I talk about, is question number 33, easy peasy question. The question says a young female was brought to the emergency, beta, after consumption of a toilet cleaning product, beta. After consumption of a toilet cleaning product which contained 100% sodium hydroxide or which contained 100% alkali, beta. Okay. As she was attempting suicide, she was having complete dysphagia or difficulty in swallowing along with ulcerations in the upper GI tract, beta. They are asking you that what is the best step in managing this patient's case, beta. Now we all know this is nothing else but a case of caustic injection. Okay, this is nothing else but a case of caustic injection, beta. That means the patient has basically ingested chemicals, okay, caustic products or chemicals, beta, something like acid or alkalis. It is a classical case of caustic ingestion. And we know always that alkalis are much more dangerous as compared to acid. Here the patient has ingested a alkali, that is sodium hydroxide. Obviously, we all know beta that alkalis are much more dangerous as compared to acid, because alkalis cause liquefactive necrosis and a deeper damage, increasing the risk of perforation. But acids cause coagulative necrosis and a localized damage, therefore lesser risk of perforation as compared to alkali. Okay? As the patient has ingested 100% sodium hydroxide, you can say it is a caustic ingestion or it is an alkali ingestion case. Patient was having complete dysphagia and ulceration in the upper GI tract. What is the treatment? So do remember, the next best step in this condition is you have to feed the patient. But for feeding the patient, beta, we do not insert the RT or we do not insert the nasogastric tube, because in cases of acid or alkali ingestion, if you insert the nasogastric tube, do remember there is a very high risk of perforation, beta. So insertion of rice tube or insertion of nasogastric tube is not done. Better is for feeding, you go for a FGE, that is known as a feeding jejunostomy. So feeding jejunostomy is considered as a better option, beta, whenever a patient has ingested caustic or basically acid or alkalis, beta. Gastrojejunostomy is not required and stent placement is also not done. Clear? Do remember just the stages of caustic ingestion or the grades of caustic ingestion. Just remember one thing. Grade 1 is nothing else but edema or hyperemia of the mucosa, that is swelling and redness in the mucosa. Grade 2A is going to be superficial localized ulcerations, beta, along with some blisters. Grade 2B is going to be circumferential and deep ulcerations, beta. Grade 3A is going to be multiple and deep ulcerations, but along with that, there are small scattered areas of necrosis. So, along with ulcerations, if you are having small scattered areas of necrosis like these, that is grade 3A. Grade 3B is extensive necrosis or complete necrosis. And grade 4 is basically perforation, beta. So, these are the various grades of caustic ingestion. Just remember this, that's it. Clear? Next is question number 34. The question says we are having a middle-aged female patient, beta, okay, who came to the hospital with complaints of right flank pain and hematuria. On examination, a mass was palpated and a CCT abdomen was performed, which is suspicious of a malignancy. Surgical resection was performed, beta, and after doing a surgical resection, the histopathological examination is given below. They're asking you, this condition is most commonly associated with which gene mutation? So these kind of questions come, beta, which are definitely a integration of pathology as well as surgery. So you can see the patient was having a right flank pain, and we know flank pain is usually seen in kidney related problems or renal problems. Patient was also having hematuria, beta. A mass was palpated and the CCT abdomen was performed, which was suspicious of a malignancy. So we know it is more likely to be a case of renal cell carcinoma or a renal malignancy, beta. Surgical resection was done and that reveals this kind of picture, which is that renal cell malignancy or a renal cell carcinoma, which shows you this classical picture, beta. What is the diagnosis? We know diagnosis is definitely a renal cell carcinoma or a RCC, beta. But there are various types of RCC or renal cell carcinoma that we have. See, renal cell carcinoma mein, the most common presentation is usually a painless hematuria. The most common presentation in renal cell carcinoma or bladder carcinoma is a painless hematuria. But sometimes renal cell carcinoma or bladder carcinoma can cause pain, beta. Usually it is painless hematuria, but sometimes they can cause pain. And if you see the histopath, on the histopath, beta, you are able to see there are cells which are having a clear cytoplasm or a ground glass cytoplasm. So here if you see, there are cells in the renal cell carcinoma with a clear or a ground glass cytoplasm. This is a very classical diagnosis of a most common type of renal cell carcinoma. And the most common type of renal cell carcinoma is nothing else but clear cell carcinoma, beta. Do remember, the most common type of renal cell carcinoma is nothing else but clear cell carcinoma. And I hope all of you are quite aware that clear cell carcinoma is the one which is commonly associated with which gene mutation. So clear cell carcinoma is the one, beta, which is commonly associated with the VHL gene mutation or the von Hippel-Lindau gene mutation. And therefore it is a part of the von Hippel-Lindau syndrome. This was a PYQ NEET. The VHL gene mutation or the von Hippel-Lindau syndrome, beta, is commonly associated with which subtype of renal cell carcinoma? The answer is the most common subtype called as the clear cell carcinoma, beta. The answer to this question is nothing else but option D. That is going to be VHL gene mutation beta is associated with this. Clear? NMIC gene mutation which is there, we all know it is usually associated with neuroblastomas beta. Neuroblastoma is the most common abdominal malignancy in children, and in neuroblastomas NMIC gene mutation can be seen. APC gene mutation is associated with familial adenomatous polyposis. The familial adenomatous polyposis is due to the APC gene mutation, and MLH1 or MSH2 gene mutations are associated with HNPCC or hereditary non-polyposis colorectal cancer. The HNPCC or Lynch syndrome are associated with the MLH1 or the MSH2 gene mutation, that is mismatch repair defect beta. Understood? That is important. In cases of renal cell carcinoma, do remember there are other subtypes also. Just remember one more subtype, and that is chromophobe carcinoma. The chromophobe type of renal cell carcinoma beta is going to have a special histopath finding, and that special histopath finding is nothing else but plant cell-like appearance it is going to show us on histopath. In cases of chromophobe carcinoma, we are able to see the classical plant cell-like appearance beta, and it is going to be having the best prognosis among all the renal cell cancer. It is going to be having the best prognosis among all the renal cell cancers beta. That is what is the 2 points that you have to remember for a case of renal cell carcinoma. Do remember renal cell carcinoma ke investigation of choice is CCT abdomen itself. Treatment: if the cancer is less than 4 centimeters in size, we go for a partial nephrectomy. If the cancer is less than 4 centimeters in size, we usually go for a partial nephrectomy. And if the cancer is more than 7 centimeters in size, then we always go for a radical nephrectomy. If the cancer is more than 7 centimeters in size, we always go for a radical nephrectomy. 4 to 7 centimeters mein, it depends on a lot of factors beta, lymph node status and everything, that whether we should go for a partial or a radical nephrectomy. Okay, between 4 to 7 centimeter, it depends on the factors like lymph node status, capsular invasion, etc. Okay, that is what is important to remember. No issues with this. Next, question number 35. Again, integration with surgery and patho. A 55-year-old chronic smoker patient presents to you with complaints of significant weight loss beta, along with dyspnea or respiratory distress, and hemoptysis, that is blood in sputum. Investigations reveal there is a peripheral lung mass beta, and TTF1 positivity is seen on IHC or immunohistochemistry. TTF1 is the tumor marker of this cancer or tumor marker of this malignancy beta. What is the most possible diagnosis they are asking you? So we know the patient is elderly, the patient is a chronic smoker, having significant weight loss, usually suggestive of lung cancer or lung malignancy beta. Along with that, the patient is having dyspnea, along with hemoptysis, other features of lung cancer. Peripheral lung mass was noted beta, and it is TTF1 positive. Then what is going to be the provisional diagnosis? Histopath, if you see, you are able to see a classical appearance beta. On histopath, you are able to see the classical appearance. These are all nothing else but glands which are seen beta. The histopath of this mass or this cancer shows you a lot of glands beta. So we all know peripheral lung mass with multiple glands and napsin A or TTF1 positivity has to be nothing else but a case of option B beta, that is an adenocarcinoma lung. Recent NEET question, this has to be a case of an adenocarcinoma lung. Yes, TTF1 positivity and peripheral lung mass along with glands on histopath. These are the keywords why the diagnosis becomes adenocarcinoma even if the patient is a smoker beta. Okay, this is not true that all smokers will only have squamous cell carcinoma. Yes, squamous cell carcinoma is the most common cancer in smokers beta. Okay, squamous cell carcinoma of lung is the most common lung cancer in smokers, and the strongest association is with oat cell carcinoma. The strongest association of smoking is with the oat cell carcinoma or small cell carcinoma, but even adenocarcinomas can be seen. Okay, that is important. So do remember, the most common cancer that can be associated with smoking is going to be squamous cell carcinoma. But the difference is squamous cell carcinoma is going to have a central mass beta, and it is positive for the tumor markers like P40 and P63, not TTF1. Whereas small cell carcinoma has the strongest association with smoking beta. It has the strongest association with smoking. But this is also not going to have any glands, but rather it is going to have small cells with a salt and pepper chromatin on histopath, and it is positive for tumor markers beta like chromogranin and synaptophysin. As it is a neuroendocrine tumor, It is positive for tumor markers like chromogranulin and synaptophysin beta. Clear about that is important. Large cell carcinoma is not going to show you glands and no TTF1 positive, and it is very rare also. So if I talk about these basic differences, yaad rakhna, adenocarcinoma lung which is there, it is going to be peripheral in location, as I've told you, associated with gene mutations like KRAS, EGFR and ALK beta. So KRAS, EGFR and ALK gene mutations are associated with adenocarcinoma. It mainly involves the Clara cells and the type 2 pneumocytes. Clubbing can be a feature which can be seen in this patient beta. And the best tumor marker, if they ask you, answer is going to be napsin A followed by TTF1 beta. The best tumor marker is going to be napsin A followed by TTF1. Okay. Next important, if I talk about is large cell carcinoma. Large cell carcinoma is somewhat rare. It is also going to be peripheral in location. It can be associated with smoking. But on the histopath beta, it is going to show you undifferentiated cancer or pleomorphic giant cells are seen beta. Patient may have gynecomastia because this cancer may release HCG or estrogen. Next important is squamous cell carcinoma. Squamous cell carcinoma is central in location, most commonly associated with smoking beta. And histopath will show you the classical keratin pearls. All squamous cell carcinomas show keratin pearls on histopath with the intercellular bridges. And the paraneoplastic syndrome is hypercalcemia. Tumor markers I have told you is going to be P40 and P63 are the two tumor markers. Next is small cell carcinoma beta. Small cell carcinoma is also central in location. It is also associated with smoking beta. It is due to the MYC gene mutation as well. So L-MYC oncogene amplification. The L-MYC oncogene amplification is associated with small cell carcinoma of lung. Do remember, it is going to have undifferentiated cells on the histopaths along with the Kulczycki cells. Apart from that, you can see the classical features like salt and pepper chromatin beta. One feature, definitely you are able to see the salt and pepper chromatin and the azoparty effect. The classical salt and pepper chromatin beta along with the azoparty effect will be seen on histopath in patients of small cell carcinoma of lung. And the tumor marker, if you ask me, it is going to be chromogranulin and synaptophysin. The tumor markers in patients of small cell carcinoma of lung is either going to be chromogranulin or the second one is going to be synaptophysin beta because it is a neuroendocrine tumor. And we know this tumor is most commonly associated beta with a lot of paraneoplastic syndrome. And the paraneoplastic syndromes that are associated with small cell carcinoma of lung beta is going to be the Cushing syndrome. It can be associated with SIADH. It can be associated with the Lambert-Eaton syndrome, which is like myasthenia gravis. Okay, this cancer is more aggressive, and that's the reason among all the lung cancers, it is going to have worse prognosis. This cancer is very aggressive in nature and it also metastasizes to the brain. Therefore, among all the lung cancers, it is going to have the worst prognosis. And I've told you, it is going to have an early metastasis and that too to the brain. Therefore, has the worst prognosis. And last one are the bronchial carcinoid tumors beta. The bronchial carcinoid tumors which are there, they can be central in location, they can be peripheral in location. Do remember, this bronchial carcinoids are also neuroendocrine tumor. So here also you are going to have the neuroendocrine cells beta, and histopath will show you the classical rosette pattern. So histopath shows you rosette pattern. All the neuroendocrine tumors can cause excess secretion of serotonin. So patients are going to have carcinoid syndrome or serotonin syndrome. So all the neuroendocrine tumors will cause excess secretion of serotonin, causing a serotonin or serotonin syndrome, also known as carcinoid syndrome, due to which the 5-HIAA levels in the urine are going to be high, PYQ. So the 5-hydroxy-indole acetic acid levels, 5-HIAA levels in the patient's urine will be high. Carcinoids will have usually a slow growth and they will have rare metastasis beta. Okay? So these are the features about all the lung malignancies or lung cancers that you have to remember. These are the classical keratin pearls that you are able to see on the histopath, and I hope all of you are quite aware. Whenever keratin pearls are basically seen on the histopath, we know it is a classical case of nothing else but squamous cell carcinoma of lung. It is a classical diagnosis of squamous cell carcinoma of lung. Second picture, you can see there are small to medium sized cells along with minimal cytoplasm, nuclei which is going to be round and oval in shape, blue to purple in color, but finely dispersed chromatin called as salt and pepper chromatin beta, along with nuclear molding, nuclear smudging. So these are all the features which are usually seen on the histopath of nothing else but a small cell carcinoma beta. Classically seen on the histopath of a small cell carcinoma. And lastly, these are nothing else but the rosettes. You can see all the malignant cells are usually arranged in a circular manner or a rose petal like manner beta. So this is basically called as the rosettes. So with an empty lumen, you are able to see nothing else but rosette like pattern on the histopath. And whenever rosettes are usually seen on histopath, I have already told you the diagnosis is nothing else but bronchial carcinoids beta. The diagnosis of this histopath is going to be bronchial carcinoids. Hopefully clear. Yes, I'll share the PDF in my Telegram group. Don't worry. Dr. Omkar's prep for next is the Telegram group. You can find it in the file section. Next important question number 36 beta. We are having a school age child who has been admitted in the hospital with a mass prolapsing from the rectum beta. So a mass is hanging out of the rectum and the patient is having painless bleeding per rectum. Histopathological examination reveals there are enlarged and inflamed glands beta which are filled with mucin. Okay, enlarged or inflamed glands which are filled with a lot of mucus or a lot of mucin beta. Which among the following genetic alteration would you consider as your primary diagnosis beta? Okay, which are the gene mutations which can be associated with this condition? But what is this condition? Let us try to understand. We know the patient is a small school age child beta who is coming to us in the hospital with a mass coming out of the rectum or a mass prolapsing out of the rectum and a painless bleeding per rectum beta. Now we know this mass which is present in the rectum, that could be a case of rectal polyp, and we know rectal polyps are the most common cause of lower GI hemorrhage in children. Yes, rectal polyps are the most common cause of lower GI hemorrhage in children. That has to be remembered. Clear? And this condition, the histopath confirms the diagnosis. There are enlarged and inflamed glands with mucin beta. So these enlarged and inflamed glands with mucin are nothing else but a diagnosis of hematomatous polyps beta arising from the rectum. Okay? So these are diagnosis of rectal polyps, and these rectal polyps could be a classical hematomatous polyps beta which can be seen. So if the diagnosis is rectal polyps, then they are associated with which gene mutation? So do remember rectal polyps which are there beta, which are commonly seen in children, known to cause lower GI hemorrhage, and histopath showing you glands filled with mucin, has to be commonly associated with option B, that is a SMAD4 gene mutation or SMAD4 gene mutation beta. Clear? Straightforward. You remember APC, I've told you it is associated with FAP or familial adenomatous polyposis. We all know STK11, it is going to be associated with sabka favorite Peutz-Jeghers syndrome beta. So STK11, okay, that is located on chromosome number 19, is associated with Peutz-Jeghers syndrome, where patient has multiple hematomatous polyps, but those are not seen in the rectum. Those are found in the jejunum beta. The patient is going to have multiple hematomatous polyps in Peutz-Jeghers syndrome, but that is usually found in the jejunum. Second, patient will have the perioral melanosis or lentigens beta. So around the oral cavity, the patient will have melanosis or lentigens which are going to be found. And third important, patient will have a high risk of multiple cancers, but most commonly pancreatic cancer. Yes, the risk of pancreatic cancer increases by 100 times if the patient is suffering from Peutz-Jeghers syndrome beta. Hopefully clear. Next is P10 gene mutation is commonly associated with Cowden syndrome. We know Cowden syndrome will also have multiple hematomatous polyps in the jejunum beta. Cowden syndrome will also have multiple hematomatous polyps in the jejunum, but patient has increased risk of three cancers known as BET cancers beta. BET cancer means BET BET. B for breast cancer, E for endometrial cancer, T for thyroid cancer. So B for breast cancer, E for endometrial cancer, T for thyroid cancer. PYQ it was in NEET. Next important is question number 37. A patient presents to you with complaints of sudden onset hematemesis and abdominal pain beta. He has been taking aspirin, that is a non-steroidal anti-inflammatory drug, and also the patient drinks occasionally beta. He gives history of pain abdomen along with nausea intermittently. That is sometimes the patient has abdominal pain and nausea. On examination, no abdominal mass or no abdominal tenderness or pain is elicited. What is the most probable diagnosis in this case? Please tell me, what do you think is the most probable diagnosis of this case? Easy peasy. Anybody, what is the most probable diagnosis that you are going to think about in this condition? Anybody? Let me know in the chat box. What is the probable diagnosis? So here They are saying the patient is having sudden onset hematemesis beta along with abdominal pain, and they give a patient has been taking aspirin for a long time, and the patient also drinks occasionally. Two risk factors: NSAIDs and alcohol. Patient is having history of abdominal pain and nausea intermittently. That is, sometimes the patient keeps on having abdominal pain or nausea beta, but there is no abdominal mass, there is no abdominal tenderness beta. Very good. So now here the diagnosis is more commonly option C, bache. That is nothing else but peptic ulcer disease. Yes. You will be like, so peptic ulcer disease, how they cause hematemesis? Beta, we all know that the most common cause of hematemesis or the most common cause of upper GI bleeding is peptic ulcer disease itself. So sometimes the peptic ulcer disease can bleed, right? Duodenal ulcers may it is the gastroduodenal artery, and gastric ulcers may it is the left gastric artery which bleeds. Rather, the most common complication of peptic ulcer disease is upper GI bleeding itself, right? So peptic ulcer disease, because NSAIDs are known to cause erosive gastritis, which can lead to peptic ulcers. Alcohol is also a risk factor for peptic ulcers beta. And in acute exacerbation or in acute worsening of peptic ulcer, patient can come to us in the emergency with complaints like hematemesis or abdominal pain. So peptic ulcer disease is the most common cause of upper GI bleeding, as we all know beta, or upper GI hemorrhage. And we know here the most common vessel to bleed overall is the gastroduodenal artery beta. So most common vessel to bleed in peptic ulcer, gastroduodenal artery. Most common vessel to bleed in duodenal ulcer, gastroduodenal artery. But most common vessel to bleed in gastric ulcer, if they ask you, then the answer changes to left gastric artery. In gastric ulcer, it is the left gastric artery, has to be remembered. Now, if they ask you what are why not the other conditions, understand one by one. Option A says Mallory-Weiss tear. We have discussed already. Mallory-Weiss tear can present to you with hematemesis, but abdominal pain will be very less common or unlikely in Mallory-Weiss tear. Second, Mallory-Weiss tear should have a history of binge drinking, not occasional drinking. And third, Mallory-Weiss tear should have a history of severe retching and vomiting. Here they are not giving any history of retching or vomiting. So Mallory-Weiss tear becomes very unlikely. Next, GERD-induced esophagitis. Yes, a chronic alcoholic can have an increased risk of gastroesophageal reflux disease or GERD, and that GERD can lead to a complication, that is esophagitis. But GERD-induced esophagitis mein, the patient has the classical symptoms of GERD, that is nothing else but retrosternal burn or a hard burn, retrosternal pain and epigastric pain beta. Clear? That would be a classical feature which is seen in patients of GERD-induced esophagitis. Clear? And next important, bleeding esophageal varices, if I talk about. Do remember, in bleeding esophageal varices, the patient should be a known case of chronic liver disease, that is cirrhosis, or portal hypertension. If they would have said the patient is a known case of CID or portal hypertension, then I can mark it as bleeding esophageal varices. But again, in bleeding esophageal varices, abdominal pain is less likely. The hematemesis, abdominal pain, both are classical features of peptic ulcer disease, and aspirin and alcohol both are risk factors for the same. Hopefully clear now. And the treatment of choice in peptic ulcer disease, we all know beta. Okay? In cases of emergency, when the patient comes to us, when the patient comes to us, the first line treatment has to be basic resuscitation, that is give IV fluids to the patient, because the patient is having bleeding, so he may be hemodynamically unstable beta, and then try to control the bleeding. As it is an acute exacerbation of peptic ulcer disease, you have to give IV proton pump inhibitors beta. Even after IV proton pump inhibitors are not going to help you to control the bleeding, then you can definitely go for an endoscopic intervention to control the bleeding beta. Even if the IV PPIs will not help you to stop the bleeding, then you go for endoscopic interventions beta to stop the bleeding. And then definitely we all know, if it is a normal case of peptic ulcer disease, not an acute exacerbation or the patient not having hematemesis, then the treatment is always lifestyle modifications along with PPIs beta. Okay, so then the treatment is lifestyle modifications along with PPIs. Do remember beta, we all know that P caps which are there, that is nothing else but the potassium competitive the P caps are nothing else but the potassium competitive blockers beta usually. Okay, so these are the ones which are the new group of drugs beta, but they're not commonly used nowadays. Still, the drug of choice for GERD, peptic ulcer disease and gastritis is still PPIs beta, so don't get confused with that P caps as the answer. Your P caps are not the drug of choice yet. They are not in common practice, their side effects are not known yet, and therefore they are not considered as the drug of choice. Question number 38. We are having a chronic alcoholic patient beta who presented to us with complaints of right hypochondriac pain along with fever. He had an episode of diarrhea few days ago. CT abdomen was done and it reveals a classical hypodense collection beta in the right lobe of liver that is measuring around 3 by 3 centimeters in size. What shall be the next best step in management of the patient? So please tell me what is the provisional diagnosis of this scenario. Chronic alcoholic had a right hypochondriac pain along with fever. Episode of diarrhea few days ago. CT abdomen shows a hypodense or a fluid collection in the right lobe of liver. What do you think? So we know alcoholic patients beta are known to eat anything. So definitely they can eat contaminated food and water, and due to that beta the patient might have developed diarrhea, right? So definitely this diarrhea could be due to an intestinal amoebiasis. Right, the patient might have developed an intestinal amoebiasis few days ago, and due to that the patient would have features of food poisoning beta. Okay, so the patient might have developed intestinal amoebiasis few days ago, causing the diarrhea, and few days later the patient would definitely develop a amoebic liver abscess, and due to that amoebic liver abscess beta the patient now is having the pain in the right hypochondrium along with fever and all. Okay, so due to that amoebic liver abscess the patient is having all the other features. Hopefully clear. So this was the reason why I did not consider it to be a pyogenic liver abscess, because pyogenic liver abscess is common in the immunocompromised patients beta, but amoebic liver abscess is more common in alcoholic patients basically. Clear? And we know amoebic liver abscess usually causes a pus collection or a hypodense collection mainly in the right lobe of liver beta in the postero superior quadrant. Okay? So all these features are definitely pointing towards the diagnosis of amoebic liver abscess. What is the next step in management, they have asked you. We know diagnosis confirm करने के लिए, to confirm my diagnosis of amoebic liver abscess beta, initially I can go for a radiological investigation. So we all know beta, radiological investigation of choice is usually a CECT abdomen or an ultrasound abdomen. But once the CCT abdomen or ultrasound abdomen is done, the best investigation to confirm the diagnosis, or the best investigation which can tell you, yes, definitely it is an amoebic infection or an amoebic liver abscess, is nothing else but ELISA or an immunoblot. Do remember beta that pyogenic liver abscess mein you can do a blood culture or a pus culture, but blood culture or pus culture is not possible for amoebic liver abscess. So here we do one ELISA or the immunoblot beta to confirm the diagnosis. Okay, and then the treatment begins. Do you remember the treatment usually is nothing else but metronidazole. Initially you have to start IV metronidazole in the patient beta. Okay, you have to start metronidazole in the patient. After giving metronidazole, then there are going to be two possibilities. Either the patient's condition is going to improve or the patient's condition is going to worsen. Okay, either the patient's condition improves or the patient's condition worsens beta. If the patient's condition is going to improve, then obviously we know that the metronidazole therapy is working, and therefore I should continue the metronidazole therapy in the patient itself. I should continue metronidazole therapy in the patient itself, but along with that, I should definitely add diloxanide furoate. Reason, metronidazole can only kill the amoeba inside the liver. Because it is a tissue amoebicide, metronidazole can only kill the amoeba in the liver. But I also have to kill the amoeba inside the intestine, and therefore I need a luminal amoebicide like diloxanide furoate beta. Clear? So I add diloxanide. Next important, if the patient's condition worsens, then better go for an early aspiration or early drainage with the help of the pigtail catheter beta. If the patient's condition is worsening, then go for an early aspiration or early drainage beta. Clear? So here definitely they have asked you to start the management beta. Okay, here they have basically asked you to start the management. To start the management, obviously my answer has to be nothing else but bolo. Now I have told you the whole treatment itself. So once you have diagnosed it as a case of amoebic liver abscess beta, now what should be your next step? CCT abdomen has been done already and the diagnosis has been confirmed. Tell me please, what is going to be the next step in the management? Next step in the management of the patient is going to be nothing else but Anybody? Option C, beta, that is medical therapy. We know na the initial treatment that we start with is metronidazole. Yes, very good. So medical therapy with metronidazole has to be started. After few weeks, check whether the patient's condition is improving or worsening, and depending on whether the condition is improving or worsening, beta, you have to decide the next step in the management. Yes, shabash, that is important. Pair therapy is any which ways not used in the treatment of now, amoebic liver abscess. It is used for the treatment of hydrated cyst. Percutaneous drainage can be done, but only if the medical therapy fails or if metronidazole the patient's condition does not improve. Surgery is not usually required. We know in cases of amoebic infections or intestinal amoebiasis, you are able to see a very classical flask-shaped ulcer in the intestine. So if there are flask-shaped ulcers in the intestine, beta, do remember the diagnosis has to be a intestinal amoebiasis, beta. The diagnosis is going to be a classical intestinal amoebiasis. Whereas if they ask you this is the classical pus, then do remember beta, then it can be called as the classical uncovy sauce pus, beta. Then it can be called as the classical uncovy sauce pus or the chocolate pus. And we all know uncovy sauce pus or the chocolate pus is a classical feature of nothing else but the amoebic liver abscess has to be remembered. Hopefully clear to all of you. Yes, metronidazole usually around 800 mg it is given with us. Usual dose is 400 mg, but 600 to 800 mg has to be given 3 times a day almost. Clear? Next important question number 39. A toddler was playing by herself, beta, and the toddler was brought by the mother to the hospital with complaints of difficulty in swallowing or dysphagia for the last few hours. The X-ray image has been given below. What is the most appropriate treatment in this case, beta? Okay. Now, in case if the patient has been brought or the child has been brought, what is the most appropriate treatment if they ask you? Now, what is seen over here? Here, definitely there is a foreign body which is found on the X-ray, beta. Now, we know the foreign body can be either inside the trachea, that means in the airway, or the foreign body is in the esophagus. For those who don't know, do remember whenever the patient comes to you with a complaint of foreign body ingestion, mostly the commonest age group affected is the child, and the most common foreign body ingested in children are the coins or the peanuts. The coins or peanuts are the commonest foreign body ingested by children, beta. Whenever a child comes to you with foreign body ingestion, the first investigation to be done has to be an X-ray, beta. The child will be brought to you with complaints like choking sensation, dysphagia, dyspnea, stridor, all of this. The first investigation is X-ray. X-ray has to be done in the AP view as well as the lateral view, beta. And do remember how to find out the location. We all know the AP diameter of the trachea is going to be more. That's the reason when the foreign body goes inside the trachea, it goes like this, beta. That means on the AP view, the foreign body in the trachea appears slit-like, and on the lateral view, the foreign body in the trachea appears circular, beta. So if the foreign body is slit-like on the AP view and circular on the lateral view, that means the foreign body is inside the trachea, beta. Second, the transverse diameter of esophagus is more. So whenever the foreign body goes inside the esophagus, it usually goes like this, beta. That means on the AP view, the foreign body is going to appear circular, and on the lateral view, the foreign body is going to appear slit-like. So do remember, whenever the foreign body appears circular on the AP view and slit-like on the lateral view, we know the foreign body is inside the esophagus. As you can see in the picture here, the foreign body is appearing slit-like on the lateral view, beta, whereas the foreign body is appearing slit-like on the AP view, beta, but circular on the lateral view. So that means the foreign body is inside the trachea or in the airway. In second picture, completely reverse. Here you can see the foreign body is appearing circular in the AP view, beta, and slit-like on the lateral view. And whenever foreign body is circular on the AP view and slit-like in the lateral view, the foreign body is inside the esophagus, beta. Hopefully all of you are quite aware. Now here definitely, beta, we know the foreign body is appearing circular on the AP view, and whenever foreign body appears circular on the AP view, beta, that means the foreign body is inside the esophagus. That was the question in the recent 17th Jan examination last time. They just ask you the location of the foreign body, beta. That is what is important. Now, if the patient is basically unstable and he's having foreign body, then initially you can directly go for management, directly go for treatment. Like if a child has been brought to you with choking sensation, then X-ray won't be a priority. I've said not the first step. I've just said first investigation to be done. I did not say the first step. Okay. I just said first investigation to be done. And obviously, if the patient is having choking sensation, then you go for management directly. Okay, that is important. Now, in this condition, beta, do remember they are asking you that what should be the most appropriate treatment in this case. So you can see the foreign body which is there, beta, it is in the esophagus, and the foreign body is appearing above C6 or below C6. Please tell me. Because one thing to be clearly know, whenever the foreign body is in any part of the airway, does not matter whether the foreign body is in the trachea, larynx, or the bronchi. Whether the foreign body is in the larynx, trachea, or bronchi, beta, that means an airway foreign body always needs an endoscopic removal. An airway foreign body always needs an endoscopic removal. But we know an esophageal foreign body, we have to look at the location first. Whenever the foreign body is inside the esophagus, look at the location first. If the foreign body is above C6, that is above the cricopharyngeal sphincter, then you can go for an endoscopic removal or an esophagoscopic removal, beta. As the foreign body is large in size and it is not able to cross the C6, or as it is not able to cross the cricopharyngeal sphincter, you can go for endoscopic removal. But if the foreign body is below C6 or below the cricopharyngeal sphincter, that means it is small in size, then in this condition you can just go for observation and serial X-rays. Yes, just wait and watch, because if the foreign body has crossed the smallest part or the narrowest part of the GI tract, that is cricopharyngeal sphincter at C6, then it will be able to pass throughout the GI tract and it will get excreted out in the baby stools. You just have to do an observation, or you just have to wait and watch, beta. No issues with this, anybody? Now, here though we know I am not able to count the number of cervical vertebra properly. So in those conditions, always see whether the foreign body is touching the clavicle or not. If the foreign body is touching the clavicle, that means it is definitely below the C6, beta. Why? Clavicle is over here and C6 is over here. So if the foreign body is touching the clavicle, that means it is definitely below C6. And we know whenever, beta, the foreign body is touching the clavicle and it is below C6, we have discussed the management is nothing else but observation, or you can answer it as wait and watch. The answer to this question is nothing else but option A, that is wait and watch, beta. Just encourage the mother to give some meshy foods to the child, beta. You can encourage the mother and parents to give meshy foods to the child so that the foreign body is easily passed throughout the GI tract and it gets excreted out in stools, beta. Hopefully clear about that is what is important. In case if the child's condition does not improve, then you can go for an endoscopic removal. If the child is not able, if the foreign body is not moving further on the serial X-rays, if the foreign body is not moving further, then you can definitely go for an endoscopic removal, beta. Okay? Next, Heimlich's maneuver and 5 back blows. 5 back blows can be the first step which can be used in the treatment. Heimlich's maneuver is not going to be very much useful, beta, if the foreign body is in the esophagus and that too below the C6. It will not come out. Do remember, Heimlich's maneuver can be definitely useful when the person has aspirated the food. That means whenever there is a foreign body or a food substance in the airway. In that condition, Heimlich's maneuver is useful. It can also be useful, beta, if the foreign body is in the esophagus but above the C6, not below the C6. It is not going to be very much useful over here. Hopefully clear? Chalo. Next important is last question for today, and that is question number 40. We are having a 40-year-old man, beta, who came to you with complaints of recurrent discharge as well as pain due to lesions around the anus, beta, for the last 2 years. What is the most probable diagnosis which is there? So do remember, if a person comes to you with complaints of recurrent discharge, okay, recurrent pus-like discharge can be there, or pain around the anal canal for the last 2 years, then let's see one by one what are the differentials. Option A says pilonidal sinus, beta. Do remember, pilonidal sinus is not exactly seen around the anus. Pilonidal sinus can present to you with pus discharge and pain, beta, but it is not seen around the anus. It is usually seen in the natal cleft or in the butt crack, beta. It is usually found in the natal cleft or in the butt crack. That is one thing. Second important, here there is going to be some hairy skin, beta. Hairy gluteal skin will be mentioned. Okay, because only if there is a hairy gluteal skin and infection of the hair follicles, beta, then a pilonidal sinus is going to form. And it is usually seen in people who had a prolonged sitting or a prolonged immobilization. Therefore, Pylonidal sinus is also called as the Jeep driver bottoms disease beta. Okay, due to prolonged sitting, so Jeep driver bottoms disease. We know in cases of pylonidal sinus, investigation of choice is going to be the MRI beta to confirm the diagnosis. And treatment which is there, either you can go for an excision of that pylonidal sinus called as the Bascom's procedure. So Bascom surgery or Bascom's procedure can be done, or you can use the rhomboid or the Limburg flap beta, or you can use the rhomboid or the Limburg flap. This was the PYQ in the examination. You can use the rhomboid or the Limburg flap for the closure of the pylonidal sinus beta. Clear? Yes, it is more likely to be a case of option B, that is nothing else but fistula and ano. All of you are correct. Recurrent discharge along with pain beta, and that too around the anus or in the perianal region. More likely is due to a case of perianal fistula, also known as fistula in ano beta. That is important. Do remember carbuncle which is there, it is nothing else but multiple boils or multiple furuncles which are going to be there, and therefore carbuncles which is going to be having beta, it is going to have multiple pus discharging sinuses. So multiple pus discharging sinuses which are there, that can be a feature of carbuncle beta. That is what is important to be remembered. Okay? Whereas if I talk about furuncle, furuncle is nothing else but boil beta, and furuncle or boil which is there, it usually does not present to you with recurrent discharge beta. Okay, it is usually just an infection of the hair follicle along with the surrounding skin. That is known as furuncle. It can present to you with some swelling, but usually does not present to you with recurrent discharge or pain. That is very unlikely. So answer has to be nothing else but beta. Option B, that is fistula in ano or perianal fistula. According to Park's classification, we all know beta, the perianal fistula is going to have multiple types. In recent examinations, they have started asking you types also. So according to Park's classification of the perianal fistula, the multiple types are, the first one that you are able to see beta is the intersphincteric fistula. As you can see, this one is passing between the internal and the external anal sphincter. So we call it as intersphincteric fistula. And do remember another PYQ, which is the most common type. So do remember the most common type of perianal fistula is the intersphincteric fistula. Second one, which is crossing both the sphincters beta and then it is opening outside, that is basically called as the transsphincteric fistula. So if it crosses both the sphincters, it is transsphincteric fistula. Next, the third one, the one which goes above the sphincters and then opens up, is classically called as suprasphincteric fistula beta. The one which goes above the sphincters and then opens up is classically known as the suprasphincteric fistula beta, has to be remembered. And last, the one which is outside the sphincter, the one which is outside the perianal sphincters beta, it is classically known as an extrasphincteric fistula. But most common time yaad rakhna, it is the intersphincteric fistula. For fistula in ano, if they ask you what is the investigation of choice, we all know it is a MR fistulogram. But don't get confused with options. Now in a PYQ, they did not give MR fistulogram as an option. So if MR fistulogram is not an option, I will mark MRI as option, because MR fistulogram is nothing else but a T2 weighted fistula of the, MR fistulogram is nothing else but a T2 weighted MRI of the fistula beta. That is what is MR fistulogram. So if MR fistulogram is not an option, don't mark fistulogram, because only fistulogram if they mention, that is the X-ray. बस fistulogram mention किया है, उसका मतलब X-ray होता है, वो better नहीं है. ठीक है? So either MR fistulogram, if not an option, then mark it as T2 weighted MRI. And treatment, we know in cases of a case of perianal fistula, any fistula that opens above the anorectal ring, it is a high perianal fistula beta. And for high perianal fistula, we have to insert a thread and do a sequential tightening of that thread called as set-on thread. So for high perianal fistula beta, the treatment is nothing else but set-on thread insertion and sequential tightening. Whereas low perianal fistula, any fistula that opens below the anorectal ring is known as a low perianal fistula. Treatment can be of two types. One, either you can just open up the fistulous tract. Okay, if you just open up and drain the fistulous tract, that is known as fistulotomy. Or you can excise or remove the fistulous tract, that is known as fistulectomy. If there is a recurrent fistula, then it's better to excise or remove the fistulous tract, that is nothing else but fistulectomy. So that is the treatment for a case of a perianal fistula, also known as fistula in ano beta. Clear? So that was all about surgery. These are the most expected questions, as I've told you on my YouTube channel as well, on Dr. Omkar's Phoenix Prep for Next. You will find there are some expected questions. Also do that for surgery. Okay? So all of that from my side. Thank you so much. And it was great having a session with all of you. and all the very best for the examination. Last few days left for the examination, so just try to revise your notes multiple number of times. Solve all the previous year questions of FMG and NEET PG examination from 2020 onwards. How many, whatever you are able to do, please solve all the previous year questions of FMG and NEET PG since 2020. And don't keep on investing a lot of time in reading all the explanations. At least read the explanations of the topics which you don't know, so that you can save time and you can solve more number of questions. Clear? For in case if you are not able to understand the explanation, read the explanation of that same topic from your own notes, so you'll have a better photographic memory of your own notes itself. Work on your weaker subjects. At least do the bare minimum for your weaker subjects, beta. That is previous year topics or the high yielding topics along with all the PYQs. That is the bare minimum for weaker subjects. Don't pick up anything new. Don't completely switch your sources at this point of time. Don't pick up anything new, beta, to be studied at this point of time, because that is not going to help you. Rather, that is actually going to make you forget whatever you have learned till date, because you will not be able to develop a proper photographic memory of your own notes. Clear? So don't keep on changing sources. Don't keep on switching a lot of PDFs and a lot of videos at this point of time. That is what is my recommendation. And if you have any doubt, you can reach out to me on Telegram, on Instagram, anywhere basically. Okay? And any doubt, reach out to me and get your doubts resolved. All the very best for the examination, and I know all of you are going to come out and pass with flying colors, bache. Okay? I understand it is a loop, bache, but once you have to put in all, give your 100% in this examination, be much confident, be calm and composed during the examination, and keep reminding yourself, I am confident that I have studied hard and I'll be able to pass this examination. Because if you are not confident, do remember, anxiety and nervousness will peak, and that anxiety makes you do a lot of mistakes in the examination. So avoid those mistakes. Keep on reminding yourself throughout the examination that I have to definitely maintain my composure throughout the exam. Does not matter, even if every third question is wrong, you are still scoring 200 plus in the exam. Even if every second question is wrong, you are still scoring 150 in the exam. So keep on telling yourself, and you don't know whether the answer is right or wrong, beta. Even when you come outside, don't discuss the questions with anyone else nearby. Clear? That is going to hamper your performance, and it is going to hamper others' performance in the examination too. Clear? So I know that you are going to pass the examination. My best wishes and are always with you. Okay? My pleasure, bache.